Good morning, and welcome to Pune. It's my honor and privilege to represent New York City, HSS, and my father in organizing the 20th ROC meeting. I know you guys have been here maybe for a day or so already and have had some wonderful educational experiences so far, at least as it relates to sports. We're going to continue that trend this morning for a little bit and talk about some osteotomies and maybe some unis, and then we're going to get into some real surgery. You were supposed to laugh. But before we do that, we're going to have a traditional lighting ceremony. But first, I'm going to pass the microphone over to my brother to let him say a few words, and then to our wonderful host, Parag Sanchetti, and the wonderful job he's done organizing this meeting and having this venue be as fantastic as it is. So good morning, thank you, and welcome.
Thanks, Amar. It's an honor to be here. We had a great showing yesterday. I think 1,400 people, standing room only. I really want to thank Parag Sanchetti. I want to thank Sachin Tapasvi. It was really a great combination of two great courses. I am sure this would be a packed room, and I know my father's very proud. Thank you.
So, good morning, everybody. I will now request the founders of this meeting. You know, this meeting 20 years ago was started by Professor Chit Ranawat, along with Professor Lad and Professor K. Sanchetti. And it's really a very momentous moment today for us today when we celebrate the 20th anniversary. And as you might have seen one of the sayings here by Professor Ranawat, all good things in life will prevail. And why do you think this meeting has prevailed for 20 years? How many meetings have you seen which lasted for 20 years? Very few. So this is one meeting which is good, and that's why it has prevailed, as Professor Ranawat has said. And I'm sure, under the leadership of Amar, Anil, supported by Sachin, myself, this meeting will be even better in the years to come. May I now request Professor Lad and Dr. K. Sanchetti, sir, to light the lamp and inaugurate this meeting. I will now request Professor Nandu Lad to say a few words on this occasion.
First, let's all wish our Guru, Dr. Ranawat, a very healthy life. I would like to congratulate the torch bearers of Ranawat Foundation Amar Anil, and now Parag and Sachin to carry the flag. I remember Chit always said that tradition has to be respected. And if the tradition has to be respected, we must know what is the significance of lighting the lamp. Lord's surgeon was Shushruta, and there is a saying in Shushruta, in the shloka, Rugnanam Vyadhi Nyashaya Kshipram Charogya Hetave Shushruta Shushrusha Bhuya Swe Nishkama Sevaya. To allay the suffering and pain of the sick, let's follow the tenets of Shushruta, the surgeon, to restore full function and pre-disease status to the sick. It tells all, and that's why I say, 20 years is a long time, and I'd like to congratulate you. And I'm sure the crowd I see in what I saw 20 years ago, I predict that next 10 years, you may need a ground, because this country with population will have large number. As I said, Amar and Anil yesterday, Goa was 300, today is 1,500. So I wish that this grows and grows and grows, and someday this country will equal, maybe more, in total joint surgery. Since Ranawat Foundation training, this country, every hospital, every district, every state has a well-trained orthopedic surgeon. I'm glad that I have survived to be here today, and I wish you all of good success. God bless. Thank you very much.
Thank you very much, Lad sir. We really bow down to you on this day today. Dr. Lad just gave an oration at the ROC, and he said, "One life is not enough." That was the title of his oration. And honestly, these are the people, Dr. Lad, Dr. KHS, and Dr. CS Ranawat, who have really done work of 10 lifetimes in one lifetime. And a big round of applause for Professor CS Ranawat, Dr. Lad, and Dr. KHS. I now request KHS sir to say a few words. As he walks up, there is one more gentleman whom I need to mention today, Les Jacobs. He's on the way. He's going to be here in the evening. And he's one person who's really been there for all 20 meetings. Even Professor Ranawat missed one meeting in between, but Les Jacob has attended all 20 meetings. One round of applause for Les Jacob. And I now request KHS sir to say a few words.
Namaskar. What a great pleasure to come here and talk about the Ranawat Foundation conference, which was started 20 years before in Goa. First meeting I remember, Nandu, was in Goa. And after that, 10 years before in Pune, and now again in Pune. What a great pleasure. This meeting, myself, Dr. Nandu Lad and Chit Ranawat sat together one day evening when we were in some of the conferences, and there we got the idea, why not to get people from US and UK and get the knowledge to Indian orthopedic surgeons, whatever is happening there. And from there it started, it grew and grew, and has come to a present status where this conference is, see how attended by big people. And that shows the importance of this conference to the delegates and to the orthopedic surgeons, young and senior, both, we are benefited. In life, we learn. We learn to improve, we learn to teach, and we learn how to live with the people. All these things are useful when such organizations, such conferences are held together, which grew this point so far and will grow further, these 3 points which I remember, which I think are very important. I don't take much of your time, and I am thankful to Amar Ranawat and Chit Ranawat and Dr. Nandulad and members of the Ranawat Foundation for organizing such a good conference. Parag, Tapasvi, all you deserve deserve a pat on the back. Thank you.
Thank you so much for those kind words and for the inspiration you provide, which you, 3 of you have always done. I will now request Sachin Tapaswi to say a few words on the 20th anniversary of ROC. Yesterday we had a wonderful PKC day. You saw 6 live surgeries, and Sachin has been instrumental for that. And I would now request Sachin to say a few words.
Thank you, friends, and a very good morning to you. This is day 2 of this historic meeting. It was really a nice feeling for all of us to have 2 different flavors combined. We did the first day in a different way. The normal sports day that we normally have at the ROC had a different flavor with the PKC flavor coming in. And it is a great amalgamation of different thought processes with the same whole intention that we need good academia. I think we all go and have different religions, we have different faiths that we all believe in, but I think this is probably the most important temple of worship for all of us, young surgeons who want to learn, we want to give our best to our patients, and this is probably the best place that you can learn, and when you learn, when you educate, when you share, is possibly the best kind of worship that anyone can ever had. I'm so very grateful to all my senior teachers who are here sitting in this hall, Sanchedi sir, Lard sir, all my senior mentors who are sitting right in front of me. And it's really important that because of all of you and efforts that you've taken over the last 2 decades, is that you've given unadulterated, unbiased learning and sharing of knowledge, which has helped us come to this level. And I think in whatever capacity we can, we will continue to share it for the next generations to come in, which is, I think, a testament to the philosophy of Dr. Ranawat, which is what he wanted. He wanted everyone to do their best and to have the best care to their patients. So thank you so much for having this amalgamation between the PKC and the ROC. Though they are different contrasting styles, but I think the ethos is the same. It's pure science that we want to share with all of you. Thank you very much.
Thanks, Sachin. This time has been a record participation. We have 1,550 delegates who have registered for this meeting, and that's a huge number. And yesterday, in one of the talks, Dr. Peter Alexandria from Australia commented, there are more orthopedic surgeons in this room than whole of Australia. That is what he said, and that's actually true. So it's all because of you, the faculty. This particular Congress is successful. And I also want to now mention the international faculty and the national faculty who've really added value. I think it's the faculty and the scientific program, as Sachin just said, which makes this meeting so important. And every time you see, Amar will tweak the ROC program depending on what is required. Anil will give inputs for the sports program along with Sachin. And they will always add in scientific content which is relevant to this day and time. So I want to take this opportunity to thank the entire international faculty, Dan Berry, Ed McPherson, Michael Henry, Thorsten Gerke, Taylor Reef, Alberto Cali, along with Camilo, Cassandra Lee, Jason Koh, Kristen Clay, Mark Tompkins, Nicholas Klans, Peter, Taylor Reef. And I also want to acknowledge the Indian faculty. And I'll tell you, this is one meeting. If I show you the list, it has 84 Indian faculties. So that's the kind of presence the Indian faculty has. And it's a huge, huge presence. And everybody who deserves gets a platform. But I would just like to mention Professor Ashok Rajgopal, Dr. Maniyar, Dr. Arun Mullaji, Dr. Wakankar, amongst many others who have been here. Harish Bhende is here, we have Anup Jurani, Mohanty, and so many Indian faculties who really add that flavor, and they know. And whenever there are panels, you will see Amar will ask, okay, what do you do in India? And that's what comes out. I think that's the fantastic thing about this meeting, and a big, big round for our faculty, international and national. I would now like to call upon Ashok Sham to propose the vote of thanks.
Good morning, everybody. And I'd like to thank the Ranawat Orthopaedic Foundation, ROC, the Tapasvi Foundation, and PKC for this amazing meeting that we are all witnessing since yesterday. And I'd like to thank CS Ranawat, KHS sir, Nandulad sir, and everybody on the dais, all the faculty, national, international, and all the delegates too. So let's begin the day 2. Thank you.
Thank you. Now I declare the inauguration ceremony over and hand it over to Amar to conduct the proceedings. And as Dr. Ranawat said, time and tide wait for nobody, and this program won't wait for anybody. Let's kick it off. Amar, it's all yours.
Wow, that was amazing. Well done, Parag. Thank you for that video. We're going to start the ROC program, the academic portion. It gives me a great honor to introduce the only person on the planet I really want to beat, and that is my brother. He's an outstanding orthopedic surgeon, an outstanding sports surgeon, and lucky for him, he doesn't do total joints. So, without further ado, I want to introduce one of the people on this planet that I truly love, my brother Anil Ranawat.
Yeah, if he loved me so much, why he always gives me the first session when the room's not packed, and he gives his session always the afternoon session when the room is packed. So he knows exactly what he's doing. He's done this for years. So I invite the panel up, please. Can everyone come up who's on the panel? Arun, Anoop, Rajesh. And as we're going, again, it's always great to be in Pune. And it's one person we always have to thank is our AV team. In the United States, you don't get AV like this. This is just, I don't even know how you have a circular screen. I don't know how they even do that. So that's amazing. I just want to thank the AV team as always, and phenomenal. Taylor. So I always say one of my dad's most VIP patient was Harry Belafonte. And we called him, Uncle Harry. I had a lot of fake uncles. Another fake uncle was Larry Dorr, and we have to, we should mention Larry. Larry was another ROC family, and really what all you people are, this is all just a family. We are an orthopedic family, so thank you everybody. Thank you, Dan Barry. A lot of family here. But like in families, families fight. So my dad, enough praise. Let's get down to work. So I want everyone in the panel to, this is going to be a rapid fire session where we're going to talk about various different topics. We're going to talk about osteotomy, uni, total knee. So I want everyone to raise their hand if they do total knees of the panel. Everyone raise their hand if they do unis. Everyone raise their hands if they do osteotomy. All right. But you did osteotomies at one point. All right. So we're going to talk about the varus knee. The varus knee is what I do for a living. And the varus knee is what everyone does for a living. Where do we intervene on that varus knee is really what orthopedic surgery is all about. So we'll talk about indications, alignment goals, recovery time, activity level, and longevity. And really what I want to focus this session on, what do we tell our patients, and what's the level 5 evidence, which means what you tell the patients, and what's the real evidence. Okay, so this is really what we're talking about. First, let's talk about osteotomy, because when I was a young resident, I saw 0 osteotomies HSS, and my dad's friend Harry Belafonte didn't have a knee replacement. He had a closing wedge osteotomy that lasted his entire life. So we're seeing a renaissance of osteotomy. And while we love osteotomy, well, it preserves the cruciates, but if the cruciates are out, I don't matter, I can adjust the slope. It helps my collateral surgery. And when you give an osteotomy, I can say, you can jump out of an airplane, you can play professional sports, you can do whatever you want, you can run on it. Things that we probably don't ever say about an arthroplasty. However, still osteotomies are still going down, and arthroplasty is going up. So I wonder that issue. And unis are exploding. It's a shorter operation, a quicker recovery. It gives you a more normal kinematic knee. And with better technology, we're better at doing the operation. When I brought the robot here 15 years ago, you all thought I was crazy. Now there are robots everywhere out there. So it's fascinating to see the evolution. So then the answer is always going to be total knee, total knee, total knee, total knee. And my brother, for his indications conference, it's pretty simple. It's total knee, or maybe a total knee. That's not my indications conference. But realize the cost of total knees are going up, the revision burden is going up, the economic burden going up, and it still has a higher mortality and a higher morbidity. But no one's saying it's not the gold standard for severe OA. So now let debate begin. Let's go to the panel. Okay, so I'm going to walk down the panel. Let's start on Sachin and come towards me. Okay, you're allowed 3 sentences. Not 4, hopefully not 2. So what are your ideal indications for an osteotomy, Sachin?
So for me, an osteotomy is someone who has got a bony deformity. His deformity needs to be in the bone. That's sentence number 1. Sentence number 2, he should not be bone on bone. And 3, is that he should want to lead an active lifestyle.
Parag?
Yes, so for me, UK is only when it's bone on bone and
No, osteotomy.
Okay, talking about osteotomy. So osteotomy when there is no bone on bone, as Sachin said, and it is a deformity more in the metaphyseal area, and which is demonstrated when you do the long leg X-rays, the CT scan, and you can see that, and by doing the various angles. So that's HTO for me.
Sachin, I want to go back to you. You said it has to be not in the joint. So if you have early varus deformity, and most of your deformity is from the joint, you have early chondral wear, you're saying you can't do an osteotomy?
Yeah, that's correct. So if you have normal bone angles and you have an isolated intra-articular deformity, it is unlikely that your osteotomy is going to be successful in this particular aspect, because with the bony correction, you can correct metaphyseal deformity. It does not act, it does not give the same kind of beneficial effect on isolated
Right, so you would, but you wouldn't do it.
Sorry?
You wouldn't do it. So Dr. Reef,
Yeah.
you have early chondral wear. Does offloading that compartment help early chondral wear?
I believe it does. Osteotomy is done typically when there's a bone deformity, but it really is correcting alignment. So if you correct alignment away from that chondral wear, patients often feel better.
So Sachin, I think you're saying you prefer more of a coronal deformity, but it doesn't mean it's a contraindication to do it for early chondral wear. Because if you go to Japan, they would disagree with you. They could show studies where they regrow cartilage.
That's true. But then I think to try and create a deformity in the opposite direction when the leg is neutral is not a great idea.
Right.
Yeah.
Well, we'll get to alignment. Arun, what is your ideal indication for a uni?
Bone-on-bone contact, medial, anterior-medial OA, that's it. An intact ACL. That's all I need.
Anoop, can you do a uni without bone-on-bone contact?
Yes, especially in spontaneous osteonecrosis of femur. That's one indication. And yes, so there are other indications as well.
Selective, but it still doesn't. So, but how about early OA? Would you do a uni for early OA?
No, not if the lateral compartment is involved or if there is patellofemoral arthritis, no.
Okay. Next question. What about the patellofemoral joint in unis? Do we really care about the patellofemoral joint? Because all I hear from these people, they can resurface the patella, they don't have to resurface patella, everybody has anterior knee pain anyway. What do I care about the patellofemoral joint with the uni?
Two things I care about in patella. One is whether the tracking is okay or not.
Okay.
Even if there is a little OA of the patellofemoral component, with good tracking should be okay for the unicondylar knee replacement. But what I really worry is whether you have the lateral facet, which is bone on the bone erosion. You have a lot of involvement of the lateral compartment, is going to be a contraindication for my patellofemoral OA for the partials.
Yeah, so I think, you know, early chondral of the patellofemoral joint is probably not a contraindication. Arun, you have a question? You have a point?
Yeah, bone-on-bone contact between the trochlea and any part of the patella, contraindication, and lateral facet as well as lateral subluxation are contraindications.
Okay, quickly down the line.
But medial facet, grade 1, grade 2 changes, no problem.
Sachin, do you need an ACL to do a uni?
The ideal answer is yes, but if you have recent data that shows that if you do not have an ACL, then if you use a fixed bearing uni and you adjust the tibial slope to 3 to 4 degrees, then you get equal survivorship of your uni. So if you're doing a mobile bearing uni, well, ideally you should have an ACL. If you're doing a fixed bearing uni, then if you do not have an ACL, you have to ensure that the slope is 3 to 4 degrees and no more than that.
And so does everyone agree that although for a fixed bearing uni, you can get away without an ACL, but it's still suboptimal? Everyone agree with that? Because that would not be the answer 5 years ago, right? All right. Good. So look, we talked about this. This is, you know, my ideal indications for a uni. For an osteotomy. Here's my ideal indications for a uni. Let's talk about body weight and an osteotomy versus uni. Taylor, what do you care about BMI?
I don't. I think there's a lot of heavier patients who develop arthritis and they still do great with osteotomy. The alignment correction is powerful.
Arun, what about a uni? Do you care?
For mobile bearing unis, there's really no evidence that BMI matters, but I think common sense
You believe everything you
dictates-
read from Oxford?
Most of it, but I tailor it to our patients' condition, and most of them, if some of them have significant osteomalacia, osteoporosis, they're short, then I might rethink doing a uni. But otherwise, I'm not terribly concerned.
Anoop, what about body weight?
Yeah, so some of these patients, apart from body weight, have metabolic syndrome. And metabolic syndrome leads to progressive arthritis. So I would guard my patients, especially if they've got significant high BMI.
I do worry about the obese patients with high BMI. And in my current practice, I do think that, you see, the uni in these obese patients may have an inferior result compared to the patients who BMI is within a lower limit. And that's why I think I'm very careful in choosing these patients if I'm going to do in obese patients.
The reality is obesity is bad for every operation. An osteotomy is probably the best operation, but I would always err more on the total knee than a uni because that little piece of cement is all they have versus a total knee, I have more cement or more fixation to hold. Okay, osteotomy. Sachin, what's your ideal alignment goals for an osteotomy?
So if it's an osteotomy that's done for a ligamentous problem, my ideal alignment is going to be 52% or just beyond the neutral on the valgus side. If I'm looking at an arthritic patient, then my ideal alignment is around the 54 to 56 percentile point, which is on the downslope of the lateral tibial spine. If I'm doing a uni, I want to leave the knee in about 2 to 3 degrees of varus. If I'm doing a fixed bearing, if I'm doing a mobile bearing uni, then it's as much as the intra-articular deformity correction will allow.
Parag, what's your goal for an osteotomy versus
I
a uni?
agree with what Sachin has said, but just to add on, it depends on whom you ask this question, and later on in the day, we are going to talk so much about alignment. So the alignment means different things to different people. For a knee replacement person, if you are trying to reproduce the native alignment, and that's all kinematic alignment about, then it's different. But here, I would say that I would like to go a little more than neutral to the Fujisawa point when I'm doing an osteotomy in a young, non-arthritic patient. For an arthritic patient, I'm not yet sure whether kinematic alignment works, it doesn't work, but I'm getting there. All I would like to say is that if it is too much in varus, leave them a little bit in varus, what we call as the adjusted mechanical alignment. That's the goal, and that's similar for uni.
Right. So Taylor, we were taught Fujisawa's point. Is that the holy grail? Sachin's saying it's not. So do you tailor your alignment based off different types of osteotomies?
Yes, this is a very individualized, tailored to the patient answer. I think Sachin gave a great answer that, anywhere between 45 degrees if you're trying to leave, or 45% if you're trying to leave a little varus, up to 55%, if you're trying to offload a compartment. I've always thought Fujisawa's point was a little aggressive, and I think that was really for a very arthritic knee, coming out of Japan. But yeah, somewhere in that 45 to 55%, depending on what patient and what their goals are.
Right. So I would say it's a clear thing that saying Fujisawa's point was based off bone-on-bone arthritis, probably outdated data. We're all tending to undercorrect, especially for the younger patient. No female likes to be overcorrected. So, but at the same time, if you do an osteotomy and you undercorrect too much, probably not a good operation either. Arun, I was taught neutral, neutral, neutral. There's tibial spine, split the uprights for a total knee. Then I was taught for a uni, maybe we undercorrect. Now a total knee is sounding more like a uni. What the hell am I supposed to do?
My philosophy for unis and total knees is completely different, because in the uni you have the ACL which is intact, and in a total knee you don't. So therefore the indications are different of what alignment I'm aiming for. In a uni, it's pure natural alignment. Whatever is the pre-arthritic alignment of that patient is what we have shown in our publications, that gets restored. Once you do a uni, no soft tissue release, you just remove the osteophyte and balance your gaps. The alignment you get will be that patient's pre-arthritic alignment, whatever that was. If it is the more severe the deformity, the more the residual varus that you'll end up with. The problem is actually when the deformity is very minimal, that's where you run the risk of overcorrection and causing transfer arthritis. In a total knee, of course, I think we're going to be talking about alignment later on, so we'll probably skip that.
But just answer one question. Can you put a total knee into varus?
Yeah, most of the time I do keep my varus knees in a little bit of varus, yes.
All right. My dad's scratching his head somewhere. Anoop, what's your philosophy? Uni, total knee. Are they, do we put them both in 3 degrees of varus? Or do you still want to put more valgus on your total knees?
Yeah, so kinematic alignment for both. Recreate the pre-arthritic joint line and leave them in the pre-arthritic varus. So usually my uni would be in 3 to 4 degree varus.
Can I ask you guys, what percentage of your patients do you have x-rays before they have arthritis? How do I know what they're, I mean, in India, do you just know, oh, that's 3, this guy was 6, this guy.
No, it's not the x-ray. It's cutting the bone equally in a total knee, cutting 8 and 6, 9 and 9. Right. So it's recreating the pre-arthritic joint line on the table.
For the partials, I will not overcorrect, I will not undercorrect. So the varus about 1 to 4 degrees for most of them for the medial, and I never overcorrect. And for the totals, it's a functional alignment, less than about 3 degrees of varus for most of my knees.
Sachin, osteotomy, when do you tell the patients they're back to their ADLs?
Okay, so again, this is a very mixed cohort if you look at osteotomies, because the indication for an osteotomy may be all over the place. So typically an osteotomy combined with a ligament surgery, the ADLs are roughly around 4 to 6 weeks, and return to sport only after, or return to light sport only after 9 months. Osteoarthritis alone, osteotomy, ADLs back at about 4 weeks, and return to light to moderate activity after about 9 months.
So 4 to 6 weeks, that's pretty, Parag, when do you tell your osteotomies they can go back to ADLs? 4 to 6 weeks seems a little bit rosy.
So I would say minimum 3 months is what I tell them.
I would think that's a little more.
And anywhere up to 6 months max.
I do think the closing versus opening wedge makes a difference.
Sure.
Closing wedges tend to get back to ADLs faster, feels more stable faster.
Arun, what do you tell your unis when they can get back to ADLs?
You don't have to tell them, they will get back to their ADLs. As soon as they're comfortable, most of them will recover and do whatever they want.
They asked you, when am I going to go back to my ADLs? Because I'm a uni versus a total knee. So they're going to ask you every time, when does the uni go back to ADLs and when does the total knee go back to ADLs?
I think total knees take a little longer than unis in general. But I don't have any specific restrictions for unis. I tell them not to sit cross-legged on the floor for the first 2-3 months because these are mobile bearings and they're prone to dislocation. Mm-hmm. So that's the only restriction I have. Otherwise, and I don't allow them to run no impact activities. Other than that, they're allowed to do everything from day one.
Right, but I'm not giving you restrictions. I'm saying, when am I back to working in my normal life? Give me a week. In America, they ask you, when am I go back to work?
2 weeks.
2 weeks.
I tell them that you can return to work in 2 weeks. For example, we've done doctors, politicians, etc. In 2 weeks, they're all back to work.
And what about a total knee?
Total knee generally takes around 4 weeks minimum. Mm-hmm. A lot of them have to climb stairs where they go, and they find that difficult for the first month. They need to drive, so I'll allow them to go after about 4 weeks. So I give them a time period of about 4 weeks.
That seems a little rosy to me. What do you tell your patients? Uni, total knee, return to work.
4 weeks, 6 weeks.
4 weeks, 6 weeks. So it's a 2 weeks difference.
Yeah.
4 weeks for a uni, 6 weeks for a total knee.
Yeah.
It actually depends on what kind of the ADL they have.
Right.
Most of our patients are either housewives or working at home.
Right.
And most of them go back to their kitchen in about 4 weeks' time. Right. And if they're a desktop job, which is not that common, is around 4 weeks again. But more than that, it's going to be after 6 weeks or 8 weeks' time.
Right. Okay, so let's talk about activity level. Sachin, what's the highest activity level? What do you tell a patient after an osteotomy? What can they get back to?
So I think
you said 9 months, they're back to sports. What does that mean?
So I think I'm looking at doubles tennis. I'm looking at maybe hiking. a short hike, and that's what I'd advise them. Because
Sachin, can I run after my osteotomy?
can you run? You could run, but that's the exception rather than the rule. I mean, normally you'd see that these patients have come to you with some sort of compromised activities of daily living. They have come because they've got arthritis and their activity level has already gone down. So typically this is what the best that they'll get. So if you look at it on a Tegner activity scale, they're roughly around a Tegner 6 or 7. They can never go to a 9 or 10.
Parag, do you agree with everything Sachin said?
Yeah, so I would allow them to run. It depends on what indication the osteotomy is done for. If it is a non-arthritic knee, if it is a ligamentous thing, they definitely can get back to what they want to do, including running or even something more. But if it's an arthritic knee for which you're doing an osteotomy, then of course I would like to restrict them, but jogging is all right with me.
I think Sachin and Parag, you're saying different things. Sachin's saying it's unlikely that they'll get back to running. You're saying you'll let them run. So those are two very different statements.
So if it is a non-arthritic knee and the osteotomy is done for ligamentous reasons, surely, once you get them back. But if it is an arthritic knee, I will see what he can do and what he cannot do. If he wants to do slow jogging, I wouldn't restrict him. Because anyway he's going to do it. Even if you tell him not to, the patients don't listen to you.
Taylor, in your experience, what's your return to higher level sports after an osteotomy? What do you tell your patients?
Yeah, I tell them they certainly can return to that. It does take 6 to 9 months, but I think the sky should be the limit and it should be patient determined. And I will say, this hasn't been mentioned yet, but they're going to return to their highest activity level when the plate comes out.
Arun, you kind of implied before that you're not letting your unis run. Are you letting, if a patient comes to you with medial compartment OA and goes, I want to run, will you not do a uni on them?
Yeah, I wouldn't.
Anoop, what about you? Do you tell your patients that they can run?
Yes, they can. A lot of my patients do, actually.
What percentage?
A lot of our patients don't want to run in our country. Running is not a great hobby in India.
Okay.
So, in this room,
What about cupboardy?
Yeah, no. So
What about
most of them want.
What's the return to cupboardy in India?
So Anil, most of them want to sit on the ground and do yoga.
Right.
That's the common want in our country, and all of them can do it. Uni patients.
Nobody would like to run, and not many will play kabaddi either. And most of my patients, I tell them that the repetitive impact activities like skipping, running, and probably the high level of sports are not allowed because of the polywear. They are okay with the lighter sports, something like a table tennis, swimming, cycling. But most of my patients, as Dr. Jurani was saying, is they are not into sports and they just would like to get rid of that medial joint pain. So they are okay to get back to most of their activity.
Anoop, you have one question?
So we had Anand Joshi, who's an arthroscopic surgeon who wanted a medial uni, and he said, I'm not going to stop running. So I said, okay, then I'm not doing a uni, and that's how he had an HTO.
We have to go. One last question. Sachin, if you were an ideal osteotomy candidate, and I want everyone on the panel to say, would you get an osteotomy for yourself?
Yes, I would.
Parag?
Yeah, I would get an osteotomy.
Taylor?
Absolutely.
Anoop? Arun? Everyone?
Yes, yes. If I was an ideal candidate, yes.
Not an osteotomy, I'd go for a uni.
Right. But you don't have bone-on-bone arthritis. I said an ideal candidate.
Then I'm
So you
not
say no.
going to do an osteotomy. I'll sit it out.
You say that.
If no bone on bone, no surgery. And if there is bone on bone, I will have a uni.
Now, if you are in between a uni, Sachin, and a total knee, what do you want? And remember, this is videotaped, and we're showing this to my father.
So if I'm between a uni and a total knee,
Yeah.
at my age, I'll do a uni.
I would err on a total knee. I would do a total knee.
Taylor?
Unis seem happier.
A uni by, no question about it.
Yeah, uni, if I'm an ideal candidate for uni, yeah.
Total knee in this country because the longevity is much better with a TKR.
So as you could all tell, we've solved this problem. Everyone knows the right answer. And I will tell you this. My father would always, I always would tell my dad, if a total knee is such an awesome operation, why come, my dad never got a total knee. And he goes, Anil, because I have neutral alignment and low body weight. So the boss is always right. Thank you very much. Thanks for the panel.
Thank you. Now, the panel, please be seated. We have question answers, and You can be there, right there, Anil. 10 minutes.
Any
Questions? Please line up to the microphones which are there in the alleys. Yes, lights
Mike,
behind.
5.
Hi, good morning. Just one question. Is synovitis or inflammation within the joint a contraindication to do a uni?
So let's say an inflammatory arthropathy.
Not exactly. So negative for rheumatoid, negative for inflammatory, but you have an MRI, the patient keeps complaining of repeated episodes of effusion in the knee, and it's only medial compartment.
I'd call that a hot joint, meaning that it's the itis of arthritis, right? Arthritis is called that on pathological specimens because early stage arthritis has an increase in inflammatory milieu. Do you feel doing a replacement in an inflamed knee versus any replacement versus a non-inflamed knee have different outcomes?
I would not do a uni on this patient because this could well be an undiagnosed rheumatoid arthritis.
Let's just say it's not rheumatoid, it's early OA.
Yeah.
It's the itis of arthritis.
You're talking about an inflammatory or a non-inflammatory?
Non-inflammatory. So why does cortisone work? Cortisone works in early arthritis because you have an effusion and early inflammation. Grandma's arthritis is burnt out. The inflammatory milieu, if you look at all the serial markers, go lower. So my question is to Anoop, do you have different outcomes when you operate on a hot joint, right, a synovitic joint from OA versus a burnt out arthritic joint?
Absolutely, because that joint will remain hot for a longer time and remain painful if you do a uni.
Yes.
So better to do a synovectomy, a mild synovectomy, and do a total in these cases.
I agree. I think you want to wait till that joint calms down. If you operate an inflamed joint, it's a hard result.
So 56 active male with combined intra-articular as well as extra-articular varus deformity, answer from the osteotomy as well as from plasty.
What, say that, what did you say?
It's a combined deformity. It's an intra-articular deformity as well as there is a metaphyseal varus. Patient is 56 male. He's an active individual. So what would be your choice?
So if he has got bone on bone, I'd still consider a uni. It's assuming his patellofemoral and the ACL are good.
There is no bone on bone.
No, it's early. It's an early varus knee.
Early varus knee.
But it's a combined. I mean, there is a chondral wear, intra-articular deformity. It's a combined.
So I'm going to tell. Anoop said he wouldn't even get an osteotomy if he was a perfect candidate. I mean, Arun said it. You know the answer. That's osteotomy. Mic 1.
Dr. Mohanty from Mumbai. My question to all the panelists, how do you decide your pre-arthritic varus alignment in patients, each one of you? What is your method?
Oh, I kind of asked that question. They have smoke and mirrors. But Sachin, start
so
with you.
in uni,
No. How do you assess the constitutional varus that everyone talks about preoperatively? How do you assess that number?
So MDFA is easy to calculate. That usually is what it is if the other side is normal. So the other side is normal or near normal, MDFA and MPTA can be calculated.
Usually both knees are arthritic.
No. So that's a fair answer. I'll give him that. God gave you 2 limbs, and sometimes one limb is worse than another. So that's your only scientific method. But to Dr. Mahani's point, very commonly they're both beat up, so you don't know. So assuming they're both arthritic, how do you assess it?
So then it's intraoperative. When you, as I said, in total knee, when you go in, you cut 8 and 6, and that will restore the pre-arthritic joint line to the kinematic axis that passes through the center of the femoral condyles.
So, Arun, I have a 7-degree varus knee. I'm doing a uni on. Do I make that 7-degree 6, 5, 4, 3, 2?
So whatever the cartilage thickness is, you replace it, and
there is no cartilage. It's gone.
No, you said it's bone on bone, right?
Bone, yeah.
That's why you're doing a uni.
Right. So what's my goal?
Your goal is to just replace whatever you're resecting, and that will give you a pre-arthritic alignment, residual 2, 3, 4, whatever it is.
Arun, what's your answer?
The answer is you're guided by the soft tissues because they are not affected in this situation. So you're going by the soft tissue tension as to how much you should
restore the MCL.
In a uni, your insert thickness is going to determine your alignment. and the insert thickness is dependent on your soft tissues. So this is not something you can plan on a CT scan or an MRI. It's an intraoperative decision, and therefore your final alignment cannot be predicted, both in a total knee as well as in a uni, because you've got to go by the soft tissues. They are not affected. The collateral is not affected.
You'd be an excellent lawyer, because you gave me a really long answer with not giving me a number. Microphone 2.
Sir, I'm Dr. Shetty from Mumbai. My question to the panelists, most of them said that they'll undergo a uni. So if they have to undergo a uni, would it be a mobile bearing or a fixed bearing?
Good question.
And would they choose the robotic technology for their uni, or it would be a non-robotic?
So first question, fixed bearing, mobile bearing. Let's go down the panel. Just say one or the other.
So if my ACL is intact, mobile bearing. If my ACL is not intact, then I'll do a fixed bearing.
Parag?
Mobile bearing.
Taylor?
Okay, same thing with Sachin said.
Same as Sachin.
Robotic fixed bearing.
Robotic fixed bearing, and if ACL is not there, no uni.
Microphone number 1.
So Dr. Ashit Shah from Bombay, Osteotomy Group. Now we've been taught closing wedge osteotomy 20-25 years ago. Of late, the open wedge osteotomy has come. Now with this impact that patients want to get back to their activity level very quickly, would you think that the closing wedge osteotomy will have a role again, because there is good compression and you initial stability straight away?
I think that's a great question, but we've seen over a period of time the various fallacies with the closed osteotomy. You know, the patella issues with that. You alter the joint line to a large extent, and therefore that is gone out of vogue. But ideally, to answer your question, yeah, if it's a closed osteotomy, a closed wedge, you get back to activities of daily living much earlier, and return to sports is also earlier.
I wouldn't say it's much earlier, but how about this? Conversion of a closed wedge versus opening wedge to a total knee.
Open wedge is much better.
Everyone agree?
Yes.
Yeah. So that's why we do opening wedge, because you have to respect my father's operation. Microphone 3. Harish.
I'll ask this last question which you asked and in a different way. You ask about if a patient is in between indication of uni and total knee. Like if I do uni, it is slightly extended indication. If I do totally, it may be a little too early. That patient, would you do uni or TKR? And why?
Well, you know what they're going to say.
So I answer it, I'll do it totally only for the reason, because if you see the long-term data of unis, they do get converted at 8 years, 10 years, 12 years to totals, and it's a progressive thing. So I don't want to let my patient have another surgery, which is going to happen eventually, in my opinion. So I would rather do a totally and, give him one surgery which will make him happy for at least 20 years.
All right, I'm going to ask that question differently. Longevity, because that was the last slide I had. Sachin, what do you tell your osteotomy, uni, and total knee? Give me a number.
Yeah, so osteotomy is longevity 10 to 15 years, uni 10 to 15 years, total 15 years.
Okay. Anyone disagree with that?
Total is more.
Total is 15 is too less, I think.
I think you can't count out an osteotomy. It could be longer. It's very hard to predict.
So you tell, Anu, do you tell your unis and total knee they're both 15 years? Or do you say one's longer than the other?
Total knee is longer.
Yeah, I would say that I would totally you would say it's longer. That's a fair statement.
Because
the Australian data is too compelling.
Because the patients we operate for total knee are generally elderly, and they would wear off less as well.
Right.
I think age is critical over here. The younger the patient, the less the longevity of whatever you do, and the older, the greater. Yeah.
Behind?
Yep.
Yeah, 5.
This is Dr. Kharia. I'm confused about the BMI. We see some patients which are very obese in the upper part, but around the knee there is no peripatellar fat. Can be considered for peripatellar fat or total fat in the body?
So do you care where the body weight is, or poly fails because of weight? Does anyone care if it's a skinny limb with a big body, or is it just the weight that matters?
I mean, the skinny leg probably will be easier for you to operate, but on the poly, it's going to be the same. So the poly wear which you are talking about, or the loosening of the tibial component, I think it's just the general overall body weight, not just whether it is the central obesity or the small legs.
It's Newtonian physics. Microphone 5.
Hello.
Yep.
Yeah, Dr. Lalit Modi from Jaipur. So if a ideal candidate of unicondylar came to us and has hyperlaxity, So if you want to put the appropriate amount of poly on medial side, that goes into significant valgus. So my question is, how do you manage those cases? Do you choose fixed bearing or you directly convert them to total knee?
Okay, let's just say you have a overly correctable varus deformity. Does that change how you do your uni? Your MCL is quite loose.
That's a contraindication. So if the MCL is lax, I think that's a
if the MCL is lax, it means that the cruciate's gone. So I think you've got to assess the cruciate first. Otherwise, you won't get MCL laxity. Very unlikely.
So it's a case of natural hyperlaxity, not the MCL laxity. It's hyperlax in medial and lateral plane.
So in hyperextension, I think you have to be careful with your mobile bearing unis. If at all you're doing them, you've got to make sure you resect very little on the femur.
Yeah,
that's the most important.
That's Chit Ranawat 101, right? If you have a very ligamentally lax, you don't want to over resect because then you're going to have a big problem. That's total knee 101. Microphone in the back.
A lot of patients come with medial compartment OA, but which is not bone on bone. MRI shows that there's a root tear, posterior root tear, but with full thickness cartilage loss in areas. Would these be ideal candidates for a uni, or would you ask them to just wait it out if they're not young enough to maybe have a osteotomy?
So we're saying the same question over and over. The early arthritic knee has a joint space, but not bone on bone.
So
I'm going to say half the panel is going to say osteotomy, and some people may say wait it out.
Yeah. So I think,
but the point is that we have newer implants, we have the Moxymed, the Kinespring, newer things, but that is always the bane of our existence. The early arthritic knee, there's a lot of debate.
So I think, Anil, what he's trying to point out is a very specific subset of patients that we see quite typically in our clinical practice. They have varus, their Mikulicz line is passing maybe around 10, 15, 20%. They're not bone on bone. They were doing pretty okay. They've got a root tear. They have been conserved, but they're not doing well. So they're probably not going to do well with an osteotomy because they're grade 3, grade 4 KL stage. And for these, I have followed up almost about 40 patients on whom I've done a primary uni, and their long-term survival at 10 years does not seem to make a difference.
Yeah, but I still think we want to stress the point, we're not doing unis for non-bone on bone arthritis. Microphone 2.
For unis, what do you do about recurvatum patients? Do you consider those patients as indication? Recurvatum and FFDs.
We just talked about that, right? A mobile bearing for recurvatum loose knee, probably a bad idea. And a really loose knee, you want to make sure, is the MCL incompetent, is the ACL incompetent? So probably not an ideal unique candidate.
But I think the second part of his question is more important. What about the flexion deformity? I think that's a very critical point. So you've got to really see how much flexion contracture is there. And are there osteophytes which are preventing extension, causing a flexion contracture? Because you can remove those, and therefore you'll get full correction. The question is the flexion contracture due to medial and soft tissue contractures which will not correct with the uni? So that's the differentiation. If you have osteophytes, you can go ahead. If you don't have, don't do it.
Yeah, but for the most part, you don't want to do unis on big flexion contractures.
Last question. Oh, microphone one.
Yeah, Dr. Pradeep from Bangalore. So is it 100% pre-op decision that we'll be doing UKR or total knee? Or is it a conversion per op that planned for UK and TK done, or other way around also? If it is there, then what was the thing we could not pick up in pre-op period?
That's a good question. So in your development of arthroplasty, I would say, well, at least for me, I used to say uni possible total knee. We used to say that a lot. Has that changed in your practice where you can figure out who needs a uni and who needs a total knee? Sachin, quickly.
So I think the answer is yes. I'd always consent my patient to have a total as well. So they have a consent for a partial / total. And the conversion rate probably is about 3 to 4%. And it's basically based on that ulcer which is present on the lateral femoral condyle, which you cannot pick up preoperatively, and synovitis, which you feel does not look too happy.
So all my unis get consented for a total, and that is why I have moved away from the hanging leg position, which was popularized by the Oxford group. and I do it in a TKR position, the uni. So conversion is easier, and I would say about 10 to 12% of my patients
Arun
get
and
converted
Anoop,
on table.
Have you changed, or you still say both?
No, I generally take a consent, but usually the conversion on the table is very minimal.
Yeah.
Yeah, sometimes you do find that we do an MRI for everyone. Sometimes the MRI says that the ACL is not there and you find it. And the reverse also is equally true, that it looks intact, but actually physically it's of no use. They're just strands. So that's the time when I'd switch. And if I find wear which is more than what I expected, on the lateral facet of the patella, on the trochlea, because sometimes you can't read this on an MRI very well, the cartilage loss. So that's when I would convert.
Yeah, I would say in the beginning of your uni practice, there's a higher conversion rate. As you get better with physical exam, you should be able to tell where the ACL is intact or not. That's an exam finding, not an MR finding, not an X-ray finding like in Oxford. It's a clinical exam finding. It's your hands. But I would say as we've all gotten better with unis, the conversion rate is getting much and much less because we know how to preoperatively evaluate. You want to know, if there's a big flexure contracture, if there's correctable varus. We're all getting better than what Oxford first taught us years ago. Well, thank you very much. That was an excellent session. And let's move on now to...
take a group photo, please line up here.
It's now my privilege to introduce Dr. Taylor Reef. He's going to give a keynote lecture on what I believe may be the future of orthopedic surgery. Dr. Reef is an outstanding individual, graduated college from Northwestern in Chicago with honors in engineering, medical school with honors, the AOA Society. He completed his residency at Loyola, graduating with honors in research. He completed 2 fellowships, one in musculoskeletal oncology and one at HSS in limb lengthening, deformity, and correction, and received the Elizaroff Award for excellence on that service. He's going to present today information and techniques that I think will revolutionize surgery on the knee and on the legs that we do. And he's going to change the way we think. So this is my opportunity to introduce Dr. Taylor Reef to give us an idea of what the future holds.
All right, thank you so much. It's a real privilege to be here. So I did, in talking to Anil, expand this talk a little bit to sort of better bridge the gap between the knee course and then the more arthroplasty heavy course. So I will talk about what Amar was just speaking about, but I think I broadened it to really how a deformity specialist can be an ally to an arthroplasty surgeon's practice and how we should be on speed dial along with the infectious disease doctor, and a select few, and the plastic surgeon. So with that, I'll get started. So the goal of arthroplasty is really to put in a perfect joint, every time. You want to go into the OR and you want to leave knowing that you achieve perfect alignment. And, when you have normal anatomy, that's relatively easy to achieve, when you're a high volume surgeon. But that's not always feasible when you have bones that have deformity pre-op, and rushing into an arthroplasty is going to get you into trouble, and really you should step back, analyze your deformity, and ask yourself, is this person ready for an arthroplasty? So here's a person, obvious bone deformity. Yes, the hip, was probably dislocated, never formed, needs a hip replacement, but is that really a good idea right away? So call a friend in these situations. So as a deformity specialist, when I'm talking with my arthroplasty colleagues, I'm helping them correct extra-articular alignment prior to arthroplasty, correcting length and rotation ahead of arthroplasty, since doing a total knee is not the place you want to be correcting a lot of length or rotation in that limb. Post-operatively, I'm going to try to prevent early revision. If there's other deformities, I can still correct, restore limb length. And then we'll get into what Amar mentioned, what happens when the knee is failed and needs to come out. Are we doing a knee arthrodesis with a true fusion? Are we going to do more of like a pseudo fusion with an antibiotic spacer? And then kind of the next frontier, I think, is osseointegration limb reconstruction in those patients who, the above knee amputation is the treatment. So first we'll start with correcting extra-articular deformity. So I'll go back to that case that I just showed. This person both has valgus as well as a large procurvatum deformity. Both of those are going to need to be corrected, and there's going to be a hip stem in there shortly. But I want to correct this deformity with an intramedullary nail. So really I need to talk to my colleague and say, I really need to go first in this situation. Otherwise, you're really going to limit my ability to correct this. Usually this pattern of deformity will also have a lot of external rotation or retroversion of the femur. This case did not happen to have that, but in general, that's going to be needed as well when I'm assessing these deformities. So relatively simple deformity correction, was able to do this with one osteotomy. You kind of bridge the difference between where the apex of your deformity is in both the sagittal and the coronal plane. The only one that makes this a little bit unique is, you do want to use blocking screws whenever you're using intramedullary nails to try to, get the correction that you set out to achieve. Those heal pretty well. This was, I think, about 9 months later that I was able to remove the nail, and then, my colleague comes in and does the arthroplasty that the patient really desired up front. This looks like, really, a patient who was being evaluated by a colleague for a total knee arthroplasty, but more and more of our surgeons are getting standing x-rays as part of the preoperative evaluation. Noticed that there was a leg length discrepancy in this patient, and then when I evaluated this patient, I also noted that there appeared to be aneversion of the femur, which was about 32 degrees, which you would argue is about 15 degrees more than normal. So prior to the total knee, we can do a deformity correction. And so I'm going to shorten the femur, I'm going to rotate it, and then am I going to correct the valgus? This question just came up as part of our panel. In this case, I'm not going to. If this person's planning for a total knee, I'm going to say a lot of this deformity is coming from intra-articularly. There's also the MPTA of the tibia is greater than normal, but that can be compensated for with a bone cut during the arthroplasty. So I'm going to ignore the valgus for now in this patient and just worry about the rotation and the shortening. So I used a lengthening nail here in compression mode. I found this to be shortenings were at high risk for non-union. My partners also feel this way, so we've all kind of converted to doing this with compression nails. You can see once you do the rotation, the shortening, how robust the callus is that you can get with these compression nails. This person, is a 65-year-old patient. You're not expecting them to necessarily have robust bone healing, but when you apply the appropriate forces, you can be surprised. 1 year later, I can actually show you the total knee arthroplasty because just based on this deformity correction, shortening that leg really offloaded her knee. She still hasn't had a total knee. And then, this is a patient who, again, 62, has kind of had neglected multiple hereditary exostosis. You can see valgus both at the knees and the ankles. Severe pain with angulation, and was initially seen by an arthroplasty colleague. But when you look at what that's going to require, this is mechanical axis planning. This requires some pretty large bone cuts, especially along the tibia. And you're going to ask yourself, well, is this a situation where I'm going to have to put in a primary hinge? Do I want to put a primary hinge in this patient bilaterally? Sagittal plane, similar scenario. Going to be a large bone cut there, removing a lot. So what else can we do ahead of time? So I chose to correct the deformity in this patient to set him up for an easier total knee down the line, maybe using primary components instead of a hinge. So here's what it looked like after the osteotomy on the left and right, and then here in the middle showing what it looks like after the valgus and procurvatum correction. Certainly he's going to feel even much better after this and make the total knee easier. And if you really zoom in, I just said how much bone you'd have to remove to do the arthroplasty. When you do the deformity correction first, you gain a lot of bone. So, between the yellow lines, this is all going to be new bone that you can use. And so, if you're going to have, if you can use primary components, great. If you have to stem the tibia, you have that much more room. Same thing on the sagittal plane. You've gained a lot of bone here. This, is going to help this patient down the line if they need, revisions down the line. People with MHE tend to form bone really well. You can see this was about 6 months later, healed really well. And he also has 6 months later not undergone his TKA, although I assume this patient will. What about after a total knee replacement? Can you still correct deformity without doing a revision? This was a patient who about 15 years ago had their deformity corrected. The knee still went on to have bone-on-bone arthritis. Went to another institution to get their total knee done. The knee was put in really without respect to the mechanical axis and only respected the corrected anatomic axis. And as a result of that, the knee was in significant varus, which you can see here. So that amount of varus was also leading to a leg length discrepancy. Overall about 13 degrees of mechanical axis malalignment. And a 2 centimeter leg length discrepancy, very unhappy. So the question is, do you revise this knee? Do you say, oh, the knee was the problem, let's take it out and put in a better one? It's well fixed at this point, and this was relatively recently, so she has very mild laxity. Her answer was no. The reason she was sent to me was that she did not want a revision. She thought that was, silly if her knee was functioning well. So could there be a deformity correction? So I executed an opening wedge distal femur osteotomy using some patient-specific instrumentation. I used an opening wedge because that does restore some of that LOD. When we were talking about opening versus closing wedge earlier, I think one thing is when you get these standing x-rays, you have to assess what their leg lengths are. If you do a closing wedge on a leg that's already a little bit short, you're going to set that patient up for an over centimeter leg length discrepancy, and they're not going to be happy. So here I used iliac crest autograft. That's pretty uncommon. This patient was in her 70s, so doing an opening wedge was already a little bit risky. And then I built some additional support into that plate. But the deformity correction was excellent. You can see there, pretty much restored mechanical axis and limb length leg length discrepancy, and then she went on to get a solid fusion. One of those screws did back out, but did not bother her. So here we have after total hip replacement. This was a congenitally dislocated hip that was untreated from another country. So she undergoes total hip with a shortening osteotomy, well done hip replacement. But then you can see here she's standing on a 3 centimeter block, has some significant leg length discrepancies she needs corrected along with valgus. So the lengthening nails have come a long way. They're now, you can have shorter ones which fit below these hip stems. So you want to template these cases, make sure you have your right nail length, your right osteotomy location. You're going to need to use blocking screws both for the deformity correction and to not induce deformity when you lengthen, and you have the appropriate starting point. So you can see the execution of that based on the planning. You go in with a plan so you don't plan to fail. And then so you're going to lengthen her until she's standing even on that standing x-ray, and then you're going to allow full weight bearing once 3 cortices abridged. This is the beauty of distraction osteogenesis. The bone heals very well. She was extremely happy with this result. These magnetic nails do need to be removed at about 1 year. Same thing post-TKA, 36-year-old male. His knee is painful, feels unstable. He's got a flexion contracture. You can see it looks like the distal femur replacement there has pistoned up into the femoral diaphysis. A CT scan confirmed that. Had a negative aspiration for infection. Whoops. I know I'm going to have to revise the femur first, but I want to gain length afterwards, so I'm going to keep my stem short. I'm going to use a cone and a collar for bone ingrowth. Maintained the tibia in this situation because I didn't want to remove bone in a younger gentleman. Then I was able to squeeze this lengthening nail above that stem, and then you can see 6 months later we restored about 2.5 centimeters of length that he had lost when that distal femur had subsided in the metaphysis. Now getting to what this talk was initially going to be on, when sometimes the TKA is unsalvageable, you have a recurrent infection, a severe problem with the extensor mechanism, maybe massive aseptic loosening. This was classically, the answer was knee fusion. And sometimes that fusion is really more like a long-term antibiotic spacer because obtaining bone contact is very difficult. So here's a case of bone-to-bone knee fusion. 60-year-old male, had a history of a kidney and liver transplant. He's on some pretty serious immunosuppression. And then he also, on top of that, now has a chronic draining sinus from his total knee. Classic signs, periprosthetic osteolysis of both the femur and the tibia, cultured out multibacterial. So had a long discussion. This was not a patient who you want to be taking to the OR many times. Each time, he gets 1 2-stage, which fails. He gets another 2-stage. This is very hard to take these transplant patients to the OR. Requires a lot of preoperative work. So how can we make this patient's life simpler with fewer operations? Remove the knee, put on a long leg fixator to then you have to compress the distance because sometimes you can't get that acutely. This was right after the OR. You can see the alignment's not quite perfect, but using the hexapod, I can correct my bone surfaces. I can dial in that amount of flexion that I want as part of the knee fusions, let the tissue settle down for 8 to 12 weeks while they get antibiotics, start the compression, and then when everything's looking good, I can convert him to a long nail and quickly transition to weight bearing. This is a durable reconstruction, and he had no infection recurrence. Was very happy he chose this. And then sometimes we call this, I get consulted by one of my colleagues for a knee fusion, and this is actually the more common situation. They've done many attempts to salvage a knee. Here's how it looked. It has a recurrent infection. Now the cement mantle is broken. There's clearly osteolysis around the implant. So it needs to come out. The problem is these are usually older hosts. They're in their 70s and 80s. And if you want to try to get a true bone-to-bone fusion, you're either going to have to do a massive shortening, which is cosmetically going to leave you with a very abnormal leg, or you're going to require a bone transport, which really none of these patients are going to opt for because that's at least a year-long process. You hope that they can even make that amount of bone. So what is more commonly done is they end up with some sort of long-term spacer. Again, chose to use a long nail in a lot of these situations with just an antibiotic cement in between. This is a good way to usually maintain them without infection. You can see this, I've done this a number of times. They can ambulate on this construct, sometimes with no pain, sometimes with minimal pain. But I will say that the one issue is femoral neck fractures, especially in some of these older hosts. They don't have good bone quality anymore, and they can end up with this, which is not the phone call that I like to get, because it means I'm going back to the OR, more surgery, etc. And then as we all know, if you do enough knees, some of them, an above knee amputation potentially makes more sense. If you have infection, its extensor mechanism doesn't work, it's a very difficult leg. But I think there's more hope for these patients than there have been in the past. Classically, they've needed a socket prosthetic, which is very hard to wear on an above knee, amputation residual limb. You can get wounds, you get a lot of dermatitis when you wear sockets, a variety of skin infections can develop, pain is very common, sweating, perspiration, change in the residuum, and often this just leads, especially above the knee, disuse of the prosthetic entirely. They're going to be using crutches. It's very difficult to fit some of these at all with the prosthetic. So with osseointegration, we use a bone-anchored prosthesis that's intramedullary within the femur. It's textured titanium, which provides a strong bond to the bone, and this comes out through a permanent transcutaneous aperture, which you can see here. You really want the skin to be as close to the bone as possible so that it's really not moving. This is going to keep the skin quiet and help prevent your infection. But the ability of these people to ambulate versus a socket is pretty incredible. They increase their prosthetic wear time, they're more mobile, their functional scores on pretty much any exam you give them are going to be higher, they're going to use less oxygen consumption, and then overall they're just going to have a higher quality of life versus wearing a socket. You can get some osteoperception through the skeleton so that this patient can feel that she's walking on sand and can do it safely. This is really a paradigm shift for our above knee amputees. On the left, you can see a bilateral. This is a wounded warrior, obviously not a post-arthroplasty patient. There is an infection risk that exists. Superficial infections around that aperture are common, usually just treated with oral antibiotics. Deep infection has thankfully been uncommon and is why this technology exists. We tell patients about 10% at 15 years, although this data is still being developed. And right now, I think if you're in this field, you would say that the functional benefits and the quality of life that these patients have outweighs the risks. So I could talk about osseointegration all day, but I think I'm very much out of time, so thank you for your attention.
Good job, Taylor. Yeah, any questions from the audience? Parag, you can go first.
Great talk, Taylor. I think you told us when to say no, because there are at times when we just want to do a debridement, do a 1 stage, 2 stage, and get back again if it doesn't work, but it's a great talk. My question to you is, in one of the slides you showed that there was a fusion done with a cement spacer with a nail.
Mhm.
So in that, do you ever go back and remove that cement spacer, or that just stays on forever?
Generally, again, this person's 78 years old. They're usually low activity, so we're going to try to make that last as long as possible. And you know, I've patients 10 years into these things, and they're still walking on them. So it certainly can be a longer-term construct.
Okay.
Microphone 2.
My question is about putting the implant inside the bone with the osseointegration. And most probably it is hydroxyapatite or whatever it is. If it gets loose, as happens with the THR and TKR, then what do you do next?
So the loosening is actually rare. These are all, you know, templated on a CT scan, and you get a press fit, or if you're using a different type of implant, a screw-in fit. And if it's loose, it's usually because of an infection down the line. But as I said, that has just not happened as commonly as you would intuitively think it would, having that transcutaneous aperture. I mean, if it's loose, it has to then come out. The thing is, most patients will then elect to have their bone, you know, debrided, antibiotics, and then have another osseointegration, because these patients, after experiencing it, will not go back to a socket. You know, they'll say, whatever it takes, give me another osseointegration.
Thank you. Great talk, Dr. Reef. I just wanted to ask, when the patients come for knee replacement in our Indian scenario, they already have a lot of femoral as well as tibial bowing, and we kind of do an extra valgus correction angle to correct it. Do you recommend correction of bowing first for take care, or try to correct it intra-articularly?
Yeah, you know, I try to tailor it to the situation. I mean, it depends on the patient's age, the amount of arthritis, the amount of deformity. You know, I think I've always can be surprised at how just correcting the deformity, all of a sudden their knee feels better, even though they still have the arthritis. You haven't changed that. But, you know, it's hard to know how long that will last them and how much better they're going to feel. So I think I always would prefer to correct the deformity up front before, you know, settling on arthroplasty.
Microphone 3.
Yeah, just comment on what Parag pointed out. We have a lot of patients. We do a lot of endoprosthesis also, our tumor team, and we have been using this technique in which we put a lot of, you know, we push 2 or 3 stacked K nails with a cement, a big block of cement just like you, and we supplement it with a locking plate also. And some of these patients are young also, because some patients are tumor patients, you know, in which they're infected on, and they do good. So, you know, so that's a good salvage operation that we have been doing it.
Excuse me. Yeah. One last question.
Sure.
Yeah. When we use an external fixator around a knee, I'm sorry, when you use an external fixator around a knee, does it increase the chances of infection when we are doing a replacement because of the pin tracks?
Yeah, that is always something that gets discussed. I'm not aware if that's been proven that there really is a higher infection risk. Obviously, I wouldn't you want there to be some sort of holiday between, you know, when the fixator comes off, you debride those pin sites, you irrigate them, you let everything close up. But is there enough residual bacteria within the bone to cause total knee or an infection of the knee? I don't know. If anyone has that data or knows of that data, I would love to see it.
Thank you.
Taylor, thank you very much. My prediction is that the future of operating on the stiff knee, especially post-total knee, is going to be osteointegration. Because once the soft tissues, once they become arthroplastic, it's not a joint or an implant problem anymore.
Right.
So I really believe you guys hold the future there.
Yeah, I think the future is definitely bright for osteointegration. I mean, there's still a lot of getting implants approved and everything, but I think as we can more routinely show patients how well they function and what their future can look like, more and more of them are going to say, why am I putting up with this terrible knee that's stiff, infected, the extensor's out, and more of them will opt for the osteointegration.
Fantastic, amazing stuff. It's now my honor and privilege to introduce Dr. Dan Barry, who's going to moderate the next session on performing a total knee.
All right, thanks, Amar. Ladies and gentlemen, can I ask the panel to please come up? The panelists, you all know who you are. While the panel's coming up, let me first just begin by saying a big thanks to Amar, Anil, Chit, and Abstentia, and Parag and team for the opportunity to be here and join you again. I really love the privilege of coming to India. It's been great to be here with you many years in the past, and I'm really thrilled to be back with you again and look forward to a great couple of days of discussion. It should be a whole lot of fun. So the panel's getting assembled. I'm just going to ask the panel, first of all, just to go down the list real quickly and just introduce yourselves, starting with Sanjeev. Just quickly.
Yep. So Sanjeev Jain, I'm from Bombay.
Yep.
I'm Dr. Prakash Patil, I'm from Nasik.
Yep.
Ashok Raj Gopal from Delhi.
Rajesh Manyar from Mumbai.
Arun Mulaji, Mumbai.
Parag Sincheti, Pune.
Alpesh Patel from Ahmedabad.
Okay, great. We've got a terrific panel. They're all expert knee surgeons, and what we're going to do for the next 21 minutes is talk about key decisions in the perioperative and intraoperative management of the total knee arthroplasty patient. Many of you who have been here in the past will have heard me conduct this session previously. And what I'll tell you is interesting about it is that while I ask some of the same questions and some new ones every year, the answers are always changing. Why is that? Because practice is always evolving. So use this as an opportunity for yourselves to ask yourself a question. Am I within the boundaries of what these experts are doing? They're not all going to have the same opinion, but you're going to get an idea of the boundaries. And you're going to get an idea of what is standard practice nowadays and what has fallen aside and what is coming on as a new way of doing things. And so with that, we'll get going with the panel. Panelists, I will ask some of you a question in every case, some of you a question in certain cases, and I'll ask all of you to be concise with your answers because we've got about 30 or 32 questions to get through in just 20 minutes. So quick answers, and with that, let's get started. My disclosures are as listed. I receive royalties from DePuy on some hip and knee products. Preoperative decision making. Body mass index. Do you have a strict cutoff for whom you'll operate on, and if so, what is it? Starting with Sanjeev.
I have no cutoff.
No cutoff. You'll operate no matter what, and you won't make them lose weight. Okay? Prakash?
Actually, no cutoff. Basically, the physiological quality of the bone and the activity preoperative.
Okay.
40 is my cutoff.
40 is a cutoff. Is that a hard cutoff for you?
40, 42 I would not stretch it to 45. I mean. 40.
So you'll be a little flexible in the low 40s, but if they get really heavy, you're going to say lose weight first.
Absolutely.
Thanks, Ashok. Raj?
No cutoff.
No cutoff. Arun?
I discuss with the patient and explain to them the risks of very high BMI.
Yeah.
Get them to lose weight if they want to, if they can. If
Yep.
they say no, we can't, then I go ahead, provided I can flex the knee.
Okay, so you'll have some sort of look at the tissue envelope. Parag?
40 is my cutoff. Anything more than 40, I talk them into do a bariatric surgery.
Okay, Alpesh?
40 is the cutoff, but we have to discuss the morbidities and complications associated with the knee replacement, post-knee replacement.
Fair enough. So it sounds as though roughly half the panelists have no cutoff, roughly half of them have a sort of soft or medium hard cutoff at around 40. And everybody, the main thing, of course, everyone's concerned about is infection. That's the big differentiator based on body mass index. I'm going to ask for a one-word answer here. Smoking. Do you allow patients who are smoking to have a total knee or not? Yes or no, starting with Alpesh.
Smoking, we just check the vascular status. If there is a vascular problem, then we have to tell them that you have to first get the vascular problem corrected. And we recommend them to stop the smoking because of the wound complications that can happen.
Okay, Alpesh, I wasn't counting, but that was definitely more than one word. Parag.
So strictly tell them not to smoke. What they do is another story.
Okay, you asked them not to. Yeah.
No. I asked them not to, but it doesn't occur that way.
Arun, was your no a no you don't care, or no they can't have it?
I don't care.
You don't care. Okay.
Always.
Ashok.
Always.
Stop. Okay.
Yeah, we'll ask them to stop, but if not, at least 4 weeks preoperatively.
Okay, that's an important point. That's probably the biggest risk is smoking in the perioperative period. The long-term smoking issue is a little harder to solve. Sanjeev?
You ask them to stop 4 weeks prior, but they don't stop. Chronic smoker, they never stop.
So if they don't stop and you know they didn't stop, will you still do the surgery?
No, you need to tell them the risk and then.
Okay, but you'll still go ahead. Nutritional assessment. Does anybody do any specific nutritional testing routinely on all of their patients? Raise your hand if you do that. Oh, so quite a few of you do it. Okay, so let me ask Ashok, what do you do and why?
I look at the albumin status.
Okay.
And I also look at the hemoglobin.
Okay, does anybody else do anything different? Total lymphocyte count, anything else? Transferrin, no?
So the AG ratio, the proteins, what Dr. Ashok Rajgopal said, we'll look at if it is low, we need to supplement it.
Okay, Raj, you were going to say something?
Yeah, total leukocyte count, always have a look at
Total
that.
leukocyte count?
From the infection point of view.
So will you check it on every patient?
Yeah, I think that counts.
Okay, fair enough. And for me, I've usually kind of done the eyeball test, and if I'm worried, then we start doing more testing. Diabetes patients, quite a few here. Hemoglobin A1C testing, do you do it? How many people do it? Yes or no? Yes? Okay. And what's your cutoff? Is it around 7 to 8?
7.5 HbA1c, we have a cutoff, but we extend it up to 8.
Okay, anybody much different than that?
More than 10, it's a strict no, I'll try and get it down. Up to 10, I will take
So you'll go ahead even if they're a little bit higher. Most of the data shows that hemoglobin A1c does not correlate very well in orthopedic surgery with postoperative infection risk. Perioperative blood sugar management, however, does. So if a patient's poorly controlled, you can assume they'll have poor perioperative blood sugar management, so it's a good idea to control them. This is an area where there have been a lot of changes recently. Preoperative urinalysis. How many of you routinely get it on every single patient? Most, but not all of you. And if you have a positive urinalysis, how many of you will go ahead and treat the patient and go ahead with surgery within the next few days?
So if they are diabetic and they have a chronic UTI, I will go ahead.
You'll go ahead if it's a chronic UTI.
No, if there's a documented UTI, we will treat the UTI first because it's one of the most common factor for causing post-operative infections.
Okay, that's an interesting point, although it's actually been hard to prove. Yes, Ashok?
Symptomatic UTI, I would treat.
Yeah.
Asymptomatic bacteriuria.
You do not. Will you give them an antibiotic anyway?
Yes, we would.
An antibiotic, but you'll go ahead?
Yeah.
Raj?
I would treat them and wait till the urine becomes negative.
Okay, so you want to treat?
I want.
Okay, Arun?
1 lakh count, colony count or more, I treat them. And then after their course of antibiotics, whatever the duration, then I would operate on them.
Correct.
If the urine does show pus, I'll wait for 2 days, I'll get a culture, and if the culture grows something, I'll treat them. Otherwise, I don't care for the urine pus cells which are seen, because sometimes it's a wrong report.
Alpesh?
If that is asymptomatic urine infection, nothing doing. If it is symptomatic, then get a culture done, treat it, and then go ahead.
Okay, thanks. And this is an area where in North America the practice has changed quite a bit. Most surgeons are no longer getting a urinalysis routinely on patients before total knee or total hip replacement. If patients are symptomatic or there's some reason to be particularly concerned, they are, but most people have abandoned routine urinalysis in North America. Standard antibiotic prophylaxis. How many of you routinely use a first-generation cephalosporin as your standard antibiotic prophylaxis? How many of you use something else? Okay, Arun and Rajesh, you both raised your hands. What are you doing differently?
It's a second generation
Cephalosporin?
3 doses.
Why a second generation cephalosporin when it has poor Staph aureus?
Second or third, I think it was established at our hospital by the ICU chief, the infection control, and that's what we follow.
Okay, fair enough. Arun?
The other problem is cefazolin is not available.
Oh, you can't get it? Unbelievable. It's cheaper and better. Okay, we won't fight about it. Antibiotics and cement. If you are cementing an implant, will you use routinely antibiotics in the cement only in a high-risk patient or never? Let's start with Alpesh and go down the panel, but quick answers, please.
In primary TKR, we don't use antibiotic impregnated cement even in high risk. If it is a revision, then only we use antibiotic.
Okay.
Antibiotics for everyone.
You give it to everybody.
Yes.
So quite different answers there. Arun?
High risk only.
High risk only. Rajesh?
Everyone.
Everyone. I like you two guys' succinctness. Thank you. That's great. Ashok, everybody else take note.
High risk.
High risk.
For everyone.
For everybody?
Only in two-stage infected infection division.
So, you see, you got exactly no consensus there. But I think everybody said they would do it in high risk, at least. Is that right? So for sure in high risk, the rest of the patients, you decide. Tranexamic acid, is everybody using it? Hands up if you are. Yep. Is there, oh, two of you are not. Oh, you are? Yeah. Okay.
Depends upon the high risk group of the patient. If it is more thrombotic, then I would like to avoid.
You're a little afraid of it, huh? Okay. And do any of the rest of you have any exclusions? Most surgeons in North America have now gone to giving it to absolutely everyone with very little concern about the risk of patients who've had a previous thromboembolic event. Is that consistent with most of your practices? Yes, Ashok? Yes. Parag, I see you're shaking heads. Arun? Rajesh? Yes.
So there is one thing that can happen.
Okay.
And is that a lot of them get some reaction when the anesthetist is giving it, an urticaria or something, or they feel uncomfortable. Then I only use the local.
Okay.
The local doesn't get absorbed and you get a...
So you give a local to everybody, or you give a local if they've had a problem previously?
No, I give local to everybody, but
Okay.
those who I can't give IV, I would probably use extra local.
But how do you know they can't get IV?
So the anesthetist starts off giving the IV.
Oh, if it starts out and it's a problem, I get it, okay. Corticosteroid administration. Now, in the era of outpatient arthroplasty in North America, a lot of patients are getting corticosteroids perioperatively. Let me ask you what your practice is. Rajesh?
No.
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 Yes.
Yes.
No.
No.
Yes.
Yeah.
No, my spine colleagues are trying to convince me, but they haven't convinced me yet.
Yeah, Alpesh?
And, IV, no, we use interarticular,
Okay.
except diabetic.
Okay, so this is an area where practices evolve quite quickly. Intravenous steroids in a single dose definitely decrease postoperative nausea. There's quite a bit of data that says they decrease postoperative pain. Personally, I was always worried about the risk of infection, but so far in quite a few studies that has not emerged as a problem. So in North America at least, with a lot of outpatient surgery being done, most patients are getting at least one dose of IV steroids around the time of surgery. Radiographs preoperatively, standard radiographs. A full-length hip film, hip-to-ankle film, or just 14 by 17-inch films? Rajesh? Excuse me, Sanjeev?
Standard X-rays.
Standard X-rays?
Standard X-rays.
Scanograms.
Scanogram on everyone, Ashok? Okay, Rajesh?
Normally standard X-rays. Currently, I'm doing the scanogram for some study that
Because you're doing a robotic study, probably.
Scanograms for all, pre and post.
And is that because you're worried about deformity that you can't see, or because you're doing robotics that needs it?
Even before robotics, we were doing it.
Okay.
For all scanograms, hip to ankle.
Okay.
All scanograms.
Okay, so about half the panels at least is getting a full-length hip-to-ankle film and using scanogram technology. Use of a tourniquet. Tourniquet for everyone, tourniquet just for exposure or cementation, or is there anybody you will never use a tourniquet on? Let's start, maybe let's start in the middle of the panel. Let's start with Arun.
I use it selectively.
Okay.
So if I'm doing a very obese patient, obviously I wouldn't use it.
Okay.
If there's any vascular problem, I wouldn't use it.
Otherwise, you'll use it most of the time?
And in a bilateral, I use it on one side.
Okay. All right, Rajesh.
So almost everyone, except for some of the contraindications, and I use it for exposure cementing. Once the cementing is done, I deflate
You'll let it down.
Get the, yeah.
Okay, Ashok?
I use it for all my patients except for those with vascular issues.
Okay, anybody else that grow dramatically different than the three speakers? Nope, pretty similar? Is anyone not using a tourniquet most of the time? It's interesting, in North America it got very popular not to use a tourniquet, and actually none of the data supports that approach. All the data shows that using a tourniquet is quite safe and doesn't really have major downsides, so, except in the vascular path.
Then can you ask one
Yeah.
question to the panel?
Sure.
Whether they stopped using tourniquet and then have gone back to using tourniquet?
Okay, it's a great question. So let's ask that question. Did anybody stop using the tourniquet routinely and then go back to the tourniquet? Three of you, four of you.
So I think it's very important because these patients have some medical comorbidities or hypertension and blood pressure. And if they're not regulated preoperatively a couple of weeks prior, then probably it's best to use a tourniquet.
Fair enough.
So I stopped it and then I come back.
Thanks. Roger, you brought up the question, so let me just very quickly ask you, why did you go back to using the tourniquet? You got tired of the blood?
So I think the benefits of not using the tourniquet
Hard to
in short,
quantitate.
Except there's only one, and that the thigh pain in the first few days or maybe a week. But the discomfort of operating with that high blood in the field is much bigger, and therefore I've gone back.
So it's better for them to have a little pain than for you to have any pain. Just kidding. Sorry.
So we did a study where we were doing bilaterals and we were inflating them in both, and we found there was no difference except at 24 hours they could actively SLR when we didn't use the tourniquet, otherwise there was no difference.
Yeah,
So
most of the best data have failed to show any big advantage to not using a tourniquet, and for sure it makes your life easier as a surgeon. Routine exposure. Everybody doing median parapatellar, anybody doing anything different? No.
I do subvastus approach for selected patients, lean and thin.
All right, one surgeon's doing subvastus, but most are using median parapatellar. All right, now we're going to get to it. Do you aim for neutral mechanical axis or something like kinematic alignment? How many, let's just raise their hands because there's going to be 100 answers to this question. How many of you shoot still for a neutral mechanical axis? That's interesting. Roughly 4 of you, 5 of you. How many of you are doing something else like kinematic alignment or functional alignment or something as a modification? Yes? 2 of you. Okay. Thank you. I'm not going to ask you exactly what you're doing because it's too complicated. Instrumentation. Manual, computer-assisted, robotic, which are in your standard vanilla knee, what are you doing most of the time? Starting with?
Computer-assisted and manual as well.
Okay.
Manual for the standard knees.
Okay.
I use manual instrumentation robotics only where there are implants or extra-articular deformities.
Okay, so selective use of robotics.
So computer assisted for all at one center where I have all robotics.
Okay. Arun?
Computer assisted for all.
Okay. Parag?
Manual most of the times, but if my patient does insist he wants robotic, then I would do it reluctantly.
Okay. Reluctantly. Okay. Alpesh?
We use robotics and manual for selected patients.
Okay, great. We're going to have a big discussion about robotics later, so I won't ask more questions about that. Do you generally align your femoral rotation using some sort of anatomic landmark among the 3 that I've talked about, or do you generally do it by gap balancing? How many of you are gap balancers? How many of you are generally using mainly anatomic alignment methods for the rotation? So a little more on the anatomic than the gap balancing, and that would reflect pretty similar numbers to what's done in North America. I think we'll skip these 2 questions about balancing because there's several good talks coming up on the topic. How do you test flexion stability intraoperatively? Let me ask just a couple of the surgeons. First, Ashok, how do you do it?
Check stability in 30, 60, 90, and 120.
And how do you do it? You just pull the knee back and forth with trials in, or how do you do it?
Yes, so I have either my spacer blocks or my trials in place.
Okay.
And I'd like to, I want to make sure that it's about a 1 millimeter opening on the medial side, maybe 2 to 3 on the lateral side, across the range of movements.
Okay. Parag, how do you make sure the knee is not too loose in flexion? That's sort of the question here.
So the answer to that is I test it at about 90 degrees and 60 degrees, move it back and forth like a
with trials in place?
With trials.
Okay.
Yeah.
And the patella reduced?
Laterally, yes, with the patella reduced, definitely.
Any other tips from any panelists? Yes, Sanjeev.
Definitely ask very gentle lifting of the femur as well.
Okay.
So just see it,
So you'll distract the femur in flexion.
Yeah.
Rajesh, you had something to say?
I think when you assess that with the trial implants, it's a little bit late. And I like to assess it much earlier when your gaps are actually being constructed.
Sure, of course,
flexion
yeah.
and extension gaps.
Ideally, you will do it before, yes. That's an important point. And then you have to retest it again to make sure you got it right. Arun?
I use a tensioner to check this. The gaps both in extension and in flexion. Once my posterior cut has been made.
But do you trust that once you measured it, that's going to be good enough, or do you want a functional test afterwards?
Yeah, I also check it with the trials in place and put an osteotome, a curved osteotome, and try and lever it to see how much of gapping up
That's a nice technique. The other one is just reduce the patella and physically test the AP stability.
Those using a technology, I don't think so there should be any problem checking it anyways, so you can do it.
If you're using technology, you know the data as it happens, right? Are any of you doing uncemented total knee arthroplasties?
No. Not available in
It's
India.
not available, but I did a couple of femurs.
Okay. And Ashok, you're doing it? It's available?
Not all. We do it very selectively. We use the TM
Okay. So most of you are using cemented technology still. In North America, there's a lot more uncemented knees being done now than there were in the past. It now represents about 20% of the total knees done in North America. We'll see what happens with that, but I mention it for interest. I think we'll skip this question. In most primary total knee arthroplasties, do you do a cruciate retaining, a PS knee with a post, some sort of ultra congruent bearing, or the latest flavor of the month, medial stabilized. Let's go down the list quickly.
I do CR knees always, and now I do CR attune RP.
Okay, CR RP. Yep, okay.
I do PS with post, and depending upon the MRI finding and the PCL status, I can change for cruciate retaining also.
Okay, sometimes you'll do cruciate retaining, okay? Ashok?
Medial congruent always.
And you switched, is that right? Because you used to be a PS with a post.
I was CR.
Or you were CR, I'm sorry. Why did you switch from CR to medial stabilized?
Greater conformity, greater stability.
Okay, so you like the stability?
Yes, the stability is phenomenally good.
Okay, good. Raj?
PS with post, but I'll be quite happy if I get the medial stabilized.
But you can't get it yet?
I can't get it yet.
And if you get it, will you start using it?
I would
You
just give it a go and see.
And see how you like it. Arun?
PS with post.
Okay.
As of today, PS with post, but after speaking to Ashok Rajgopal last night, I might change.
Okay.
I switched from PS to a medial congruent now.
Yeah, it's interesting. In North America, there's a lot of switching going on. Most of it's from PS with a post to medial stabilized. The CR people are generally sticking with the CR. Patella resurfacing, routinely, selectively, or never? Just a single word answer because we're short on time.
Never.
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 Routinely.
Always.
Always.
Never.
You see that there was exactly a 50-50 split there, and no room for anything in between. Antimicrobial irrigation with a antimicrobial agent after or as you close the wound. Yes or no?
No.
No?
Yes.
Yes.
After you close the wound, you're saying?
No, as you're closing.
Yeah, yes.
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 No.
We use Genta in the irrigation.
Okay, so 50-50 on that one too. Drains, yes or no? How many yes?
Yes.
Yes.
Only in revisions.
Okay, so it's interesting. In North America, most people aren't using drains much anymore with tranexamic acid, but some of you are still doing it. And I have to tell you that the data still has not been proven one way or the other on drains. So we'll wait and see about that. Do you give extended, that is more than 7 days, of oral antibiotics to patients who are at high risk for infection? If so, please raise your hand, yes. So about 2/3 of the panel is yes on that. Do any of you do outpatient total knee arthroplasties in India yet?
No.
Not yet. It will probably come. Postoperative physical therapy, always? How many of you? Yes?
Always.
All of you.
Always.
Okay. Favored DVT prophylaxis. How many of you use aspirin routinely? How many of you use something else?
Debigatran.
Somebody else. Somebody, a few of you use
High-risk
something else.
patients. For high-risk patients.
High-risk patients, you'll use something else, of course. And here's our last question. Antibiotic prophylaxis. Do you recommend it for dental work or other, say, GI procedures? Yes or no? And if yes, do you do it forever or just for a limited period of time? Let's start at the end of the panel and work our way back this way.
We don't give it, and we don't have follow-up for that if they are having dental problems.
So you're not doing it, Alpesh?
Don't have a good answer, but if I have to use it for dental prophylaxis, it will be for up to 2 years maximum.
Okay.
We advise patients to have antibiotic prophylaxis.
Raj?
Advise always.
Always?
Always.
Always?
No.
No?
Always.
Always. So there was a discrepancy of opinion. What I'll tell you right now is in North America, most people, based on the data, have restricted it now to the first year or two after surgery and are not going forever. Maybe that's partly practicalities, but also some of it's based on the fact that there are not many late infections from dental procedures that you can trace for sure to lack of an antibiotic. Ladies and gentlemen, I'm going to ask the panel to stay up here so that you can ask them questions afterwards. But first we have 2 talks, and then we'll allow you to ask some questions. So while we do that, please join me in thanking the panel for an outstanding set of discussions. And you're welcome to be thinking about questions you'd like to ask the panel while we have 2 quick talks. The first talk is Robotics May Not Always Be Accurate. It's necessary to master the basics. Dr. Shah.
So good morning, friends. Thank you, ROC and PKC, for this opportunity. It's basically a case presentation that I'm going to talk about. So we have this 74-year-old retired bus driver who had pain in both the knees, right more than left for 4 to 5 years, difficulty in walking a few steps without pain. ADLs affected, medical history, hypertension on medication, and had a fracture of left proximal femur about 50 years ago, which was treated traditionally, and it healed well. These are his x-rays. AP standing, lateral, and the scanogram. and that's his clinical pictures, the gait, the way he's walking. Right knee is more symptomatic than left. So, what do we do? How do we plan his surgery?
Yes, Rajgopal sir.
So is the question, would I be using robotics? Is that your question, or is the question, how would you address this?
Yeah, so whether would you use technology or whether would you go standard method, conventional?
So the real issue here is that this patient, I'm assuming you're asking for the left side.
Right side, please. Right side is more symptomatic.
For the right side?
Right knee.
Right knee would be fairly straightforward. I would do this manually.
Right.
Yeah.
Okay. Dr. Mania, because you've been using robotics for...
Yeah, so I would use computer navigation or robotics if it is available, which center it is. I'm worried about the left hip, what is going on. At least I need to know, because that hip is in coxa vara and a severe one.
Yeah.
And I would think that it would have some implication to what I do on the right side. That means patient needs to understand that we need to probably do more procedures on the left side in future. But the right is robotics or computer navigated totally.
I think, Ashit, the real key question is the left side being more deformed is causing more stress on the right. And therefore, he's complaining of pain in the right. But I think we should explain to him and address the left one first,
okay,
rather than the right, because that's severely deformed and it's got an extra-articular deformity which needs to be corrected.
Correct.
Because even if you do the right first, the left one will still be pretty deformed and his gait's not really going to significantly improve. So I think I'd have a conversation with him and do an extra-articular correction plus intra-articular correction for the left side.
So two-stage surgery for the left side?
No, I'd do it in one go.
Okay.
One go, probably with either a plate or a locking nail to correct the deformity, a closed wedge on the femur, and at the same time do a total knee on that side. If he's fit, I'd go ahead and do the right side, use navigation on both.
Right, okay. Anyone else? Parag or Sanjeev?
I will go with the computer assisted, that is robotics. That would help into have a few degrees of varas on tibia and femur side and help in rotation of the femur. So that will help in balancing the knee, which would be very difficult when you simply go for manual.
Sure, okay.
I would...
Yes.
Yes, Amar.
Nobody's commenting on the bone deformity on the tibia. This is not a straightforward knee. So, I mean, someone has to address the bone loss on the tibia.
So this would definitely need an augment and stem extension for sure.
Some reconstruction of the proximal
Yeah,
tibia.
absolutely. I mean, you can choose between a graft or an augment or a...
But you have to convince him for the left side, yes. But if he's more symptomatic on the right, he will not accept for the right
Correct.
side.
That's what happened. He said that, he wants the right side because that was the problem. I mean, I understand the point, raised by the panel. But anyway, that's his preoperative video. The range of movement, the flexibility. And that's after exposure. He has a significant tibial defect as we expected from the pre-op x-rays. I do robotics, and I did obviously put the robot and started doing the registration as the standard method. This is an imageless robotic system. And that's what I got after registration when we did the equivalence graft. Absolutely tight on the medial side. And once, see, obviously, this is the next screen that comes as a pro adjust. And if you see, the tibial resection is almost coming to about 16 to 18 millimeters. Still, we get such a tight medial balance. So, any comments? Dr. Maniar, you've been doing this particular system, I'm aware.
I think this is no different than if you're doing it manual or otherwise. You don't cut 16 millimeters on the lateral side. So you cut less and be ready to address the defect on the medial side.
Right.
Okay. And I would normally not do this balancing. I would do it, but not pay so much attention till I make my tibial cut. In this case, it will be 6 or 8 millimeters on the lateral. And then put the tensioner, because by now you've removed all your osteophytes, extra bone on the medial side. You've got some amount of release. And now you'll see that your medial gap will open up. It will
Right.
still not equalize, because
Right.
there's a lot more to do
Correct.
with the femoral cuts. So I think that's how I would progress here.
Okay, so you would still progress with the robotic at this stage, reducing the tibial cut significantly? Yes. Okay. Right, so I tried to just cheat the robot a little bit and put the tibial registration probe slightly in middle air on the tibial medial defect, because I was really surprised with that 18-16 millimeter of the tibia that I had to cut. So I did that, and still, you know, I got that tibial resection to around 10 or 9, which we would normally like to resect, but still, if you look at the gaps, absolutely tight on the medial side. So at this stage, you know, I thought that probably this is not the right thing for me to do and continue with the robotic surgery for this particular case. I removed the robot and put the manual jigs.
Okay.
I had to do a medial epicondylar osteotomy to get the tension right, reconstruct the proximal medial tibia with bone graft, screws, full extension, stable in extension, and also inflection with good tracking. That's a post-op X-ray. Primary standard PS femur, primary tibia with a stem, reconstruction of the proximal medial tibia with 2 screws, and medial epicondylar osteotomy, 8 millimeter poly, which is the least that we have in this particular system.
Okay, thank you. Thank you.
And that's his gait. Post-op, he's still waiting to get the left side done, and obviously I'll take some wisdom from what the panel has to tell me about this patient.
Great.
Thank you.
Thank you.
Thanks, Dr. Shah. Everybody, please join me in thanking him for a nice presentation of an interesting case. I think the main point there was that the robot or computer navigation can give you a lot of information, but you can't follow it blindly. You still have to remember some of the key principles, which are you're still going to have to balance the knee in some cases, and you're still going to have to figure out where the cut should be yourself. Don't let the computer tell you it. If it tells you to cut off 2 centimeters of the tibia, it's probably wrong. So that's a few little basics to think about. Now, if we can, we're going to go to the next talk. It's by Dr. Sharma, Balancing the Collateral Ligaments and Extension Flexion. How do I do it, Dr. Sharma?
Good morning, everyone. Balancing the collateral ligaments in extension and flexion. So these are the patient details. Male 65 years, varus 14 degrees, FFD 5 degrees. This is the pre-op X-ray. You can see the varus deformity and the posterior osteophyte. Weight-bearing full-length X-rays, the valgus correction angle is 6 degrees. So the approach is the medial parapatellar approach. Proximal tibia is cut first. Posterior cruciate substituting implants. Ligament balance is checked in full extension and 90 degrees flexion. Superficial MCL is not touched. And 1 to 2 mm lateral laxity is accepted in flexion. So as you can see, it's a partially correctable varus. The first step is to release the anteromedial capsule and the deep MCL. Then the osteophyte, especially the medial ones under the MCL, are removed, which are tenting it. The ACL and the PCL are removed. The medial as well as the posteromedial osteophytes. At this point, the posteromedial osteophytes deep in the intercondylar notch are also removed. And finally, the menisci. So the tibial cut, tibial slope is kept at 3 degrees, as this design has a built-in slope of 4 degrees in the poly. At this stage, the posterior femoral osteophytes are removed after the tibial cut. The femoral cut is decided by the VCA using this jig, which allows variation in the valgus orientation. We use this tensioner from the OrthoPilot navigation system. There are 2 limbs in this tensioner, and both the limbs are independent of each other. The extension gap is measured using the tensioner. You can see 19 mm gap on both sides, which is the gap required to accommodate the thinnest poly. Then the spacer block is used to check the extension gap as well as the mediolateral stability. Now, important point, the rotation. To balance the flexion gap, the femoral component rotation is determined using the combined referencing technique, using the right side line, epicondylar axis, posterior cut level based on the soft tissue tension, anterior surface, and flexion gap using the tensioner. Posterior femoral cut level is marked using the tensioner like this. The anterior surface referencing to prevent notching. Rotation is adjusted using all the landmarks. After this, the 4-in-1 jig is put. This is a slotted jig and the slot is 3 millimeters. Its relation to the previously marked posterior cut level is checked, and the flexion gap with this slotted jig, as you can see, is 16 mm on the medial side, 17 on the lateral, and this is the final check after the cuts, 19 mm medially and 20 mm laterally. Spacer block is used to assess flexion gap and mediolateral stability. So the final ligament balance is extension, both sides same 19 millimeters, flexion is medial 19 and lateral 20. The final post-op X-ray. So the tensioner is a good device to balance the extension and flexion gap, but there is a limitation. It is essential to achieve good mediolateral balance in flexion before determining the level and performing the posterior femoral cut. If there is excessive medial tightness, then we will be putting the femoral implant in excessive external rotation. And if there is excessive lateral tightness, we may put the femoral implant in excessive internal rotation. So this is the algorithm which we use from the book Deformity Correction in TKA by Dr. Mullaji. So excision of osteophytes, release of anteromedial capsule and deep MCL, the first step. If it is fully correctable, then directly TKA. If partially, then further release the semimembranosus and the posteromedial capsule. 10 to 20 degree varus, you may need to add a reduction osteotomy, and greater than 20 degrees, a sliding medial condylar osteotomy. Thank you so much for your attention.
All right, thanks, Dr. Sharma. Dr. Shah and Dr. Sharma will invite both of you to join the panel now if you'd like. And the floor is now open for questions from the audience about any of the topics that we just discussed, either during the last two talks or during my session in which I asked the panelists about key decisions in perioperative and intraoperative management. And we'll begin with microphone number 5, and then I'll go to Amar at microphone 3. Microphone 5, yes, sir.
In the balancing that you're doing when you're using those, the tensioner or the instruments or the spacers that you use, more often than not in Indian population and in very osteoporotic bones, the spacer itself indents and then goes inside. And now it has changed your, the mechanical axis and all the cuts that you have already taken. At this stage, then what do you do? If you've already indented the bones, an osteoporotic bone with the spacer itself.
The tensioner which I showed you on the slides has very broad blades, and usually it does not indent the bone. It does not.
Yeah, you don't want spacers that are going to damage the bone, otherwise you've defeated the purpose. Amar.
Yeah, so I have two questions. One, you noted that you had, or you measured at least, an extra millimeter on the lateral side in flexion. Why not rotate the femoral component one more degree, a little more external rotation, balance that flexion gap? That's my first question. The second question is, do you agree or disagree with the statement that you want equal gaps? Because in my opinion, I think if you have an extension gap, you want your flexion gap in a PS knee to be slightly smaller. So if you have a 19 millimeter extension gap, I'd prefer to see an 18 or 17 millimeter flexion gap.
Okay, Amar, stop there, because I think that's a great question, and let's ask the panel. So panelists, those of you who sacrifice the posterior cruciate ligament routinely, okay, this doesn't apply to CR surgeons. How many of you would like to see the knee be a little tighter in flexion than extension? Hands up. Yes, most of you. Okay, so Amar, it sounds like most of them agreed with your second point. Now, the second question for everybody is, do you want the knee and extension to be, and flexion, to be equally tight on the medial side and lateral side or not? Let me just ask a couple of the senior surgeons. Ashok, I'm going to start with you.
No, I don't, Dan. I want my lateral gap to be just a little bit looser.
Okay. Yeah. And when you say just a little looser, you mean a millimeter or two?
One to max 2 millimeters.
Arun.
2 to 3 millimeters laxer on the lateral side.
Rajesh.
I think I would want them equal, but if I have to settle for something, it is laxer on the lateral side. And that's my last priority, the flexion lateral balance. The rest I want to be very accurate.
Okay, fair enough. Parag.
Yeah, I would like it to be equal. I want a well-balanced knee. You know, alignment is something we can talk about.
Fair enough. There's a lot there. Thank you for an excellent set of questions. Let's go to microphone number 5.
With regard to return to activity, what do you advise patients who ask for a kneeling prayer posture after a total knee arthroplasty?
Okay, so that's a great question. It was one of the ones I didn't have a chance to ask the panel. So after total knee arthroplasty, what are your restrictions on the patient? None. Restrictions against high impact loads or something different? Let's start with Sanjeev.
So definitely I will tell them not to sit on the floor, not to squat, but they do it, except the Indian style toileting, most of them they do it.
Okay.
I ask them not to squat and avoid high impact activities like running and jumping.
No squatting, no high activities.
Similar.
Similar?
No restriction in bending and using it, but high impact activity, yes.
Okay.
Surely no squatting, that is full flexion when they want to squat for the Indian toilet, and not to sit cross-legged on the floor. I don't mind if they sit on a bed on a height, but definitely not sitting cross-legged on the floor.
Arun, you got skipped.
Yeah, but about the same. No real restrictions except impact activities. High impact activities like running, jogging, I dissuade them.
Okay.
Sitting
and
on the floor.
What, are you worried about polyethylene wear or loosening or both?
Both.
Both, okay.
We tell them to avoid it and avoid high impact activities.
Avoid high impact activities. Last two?
Yeah, same. Avoid squatting and high impact activities.
Okay.
They can sit cross-legged, but on a higher floor above 18 inches, not to sit on the floor. On a higher surface they can sit.
What do you, go ahead.
And no kneeling, because sometimes when they kneel, they get a lot of pain along the scar of the total knee. So, that is something they are really scared. So tell them not to kneel on.
Rajesh, you want to make a comment?
Yes, I think when I say high impact activity, on a regular basis, I don't want them to run or something. But if they want to play a game, a lot of them play
something
double
brief.
standing, yeah.
You don't want prolonged high impact activities like marathon running or something crazy like that. What are you worried about with squatting? Tell me. Those of you said don't squat. What is it that you're worried about?
I don't stop them from squatting, but it is a very difficult activity for someone to do for
I
a
grant
length
you
of time.
they might not be able to, but if they can do it, what are you preventing? Parag, did you have a comment?
Yes, I worry about the polywear in deep flexion, and that is why. And they try to do it because in terminal flexion it's painful as well. So I wouldn't.
Some of them can't do it for sure. Ashok?
Squatting is not the problem, Dan. Getting up is.
Yeah. Okay. So you're worried that as they get up, they'll do something that damages the knee? Yeah. Okay. Fair enough. That's a reasonable question.
Same as Ashok.
Okay. Great. You had a comment?
So most of the knees that we've been, using are not meant for squatting. Only a few designs. And if you are putting those designs and then you let them squat, it is okay. But when they standard just right across the board, if you put any implant and tell them to squat, that's a bit
So you're just mainly worried that with super high flexion, you're going to damage the posterior aspect of polyethylene. Is that basically what you're worried about?
Yeah.
Okay. Fair enough. Yes, sir.
My question is to Parag about the pediatric surgery. He said in high BMI, you prefer the pediatric surgery, but the patient get loose, but they develop a lot of other metabolic problems, resulting in the healing of the tissue, etc.
So I'm glad you brought this up. I heard him say it, and I didn't have time to ask him about it, so I'm glad that you did. Parag,
so
bariatric surgery, it works to lose weight, but it has its own sets of problems with nutritional parameters and also with collagen stiffness and softness, if you will.
So when I suggest them bariatric surgery, I have two things in mind. One is that if he really does it and loses weight and comes back, I would do it. But let's say out of the 10 patients I suggest, only one does it. So in other words, I don't want to do a TKR for him. But that being said, if they lose weight, which, that's a morbid obesity, bariatric surgery does help. And younger the patient, better is the outcome.
Thanks, Parag. I will say that we have a fairly big experience of patients having bariatric surgery and then knee replacement. And the biggest problem is that the collagen gets lax, and there's a lot of trouble with instability in these patients for some sort of metabolic reason we don't completely understand. Microphone number 3.
Yes, sir, you told the medial pivot joints are getting more getting more popular in North America.
Yeah.
But there is some data from an Australian registry suggesting a more polywear on the posteromedial side. So some of the panelists are telling they want to get 1 millimeter more loose in flexion on the lateral side. So if you are doing a medial pivot, will you increase the external rotation to prevent this posteromedial tightness?
Okay, so it's a good question. So if you're doing a medial stabilized knee, the main question is, are you modifying your technique now to accommodate for that medial stabilized knee? So how many on the panel are doing some sort of medial stabilized implant some of the time? Okay, so let's ask the two of you, are you modifying your technique because you're doing a medial stabilized implant? Ashok.
No, I'm not.
No change?
No change at all.
Okay.
It is the articulation, it is the congruency on the medial side that's giving you a stability. It's only fixing your dwell point, taking it back posteriorly, and allowing for 1 to 2 millimeter excursion on the medial side and 7 to 8. It basically increases the rotation arc on the lateral side, fixing it on the medial side and slightly more posterior.
Ashok, you do a CR knee, is that right? So are you saving the posterior cruciate ligament when you do a medial stabilized knee or no?
I've done both, Dan, and we published this, and there seems to be no real difference between retaining or sacrificing.
And so what are you doing now?
I retain it.
You retain it, and you're not worried about the kinematic conflict problem?
No.
Okay?
So I used to use PS knee, and now since this medial pivot is available, we are using this medial stabilized knee. And the question you asked is basically is the articulation between the femur and the poly. That's what is the most important thing, as Dr. Rajgopal also mentioned, that you don't need to really change your surgical techniques. It's the articulation that gives you that excursion in the lateral side, about 5 or 6 millimeter posterior rollback. And medially, it's just 1 or 2 millimeter. So you don't have to change your surgical techniques, but it's the poly and the articulation that takes care of this particular concept.
Thanks for a good question. Microphone number 5.
My question is, how many of the panelists would send the patients routinely for a dental checkup and get asymptomatic caries?
Great question. So before surgery, how many of you routinely have every patient see a dentist? No. How many of you sort of give it the eyeball test, and if the teeth look terrible, send them to a dentist? Yes? Most of you? Okay. So it looks like not routinely, but if somebody looks like they have poor dentition, then yes.
Would you recommend to treat the asymptomatic caries before undergoing
Okay, asymptomatic caries, identify the dentist. Would you treat them? Yes? No? Or only if the dentist says yes? Let the dentist decide.
Let the dentist decide.
Okay, fair enough. I think the main thing is if they've got abscesses around their teeth, then you should get that treated for sure. Sir, I'm sorry, I couldn't see you over the top.
It's about collateral balancing. I've been using recently the buccal pepper system. That's the low contact stress LCS knee with a fixed balancing system. So I don't have any of these worries of balancing.
Yep.
And I accept that there's a massive femoral bone loss.
Okay.
So I was using a navigation, I stopped it, and all the 10 steps has become very easy for me.
Okay.
And what is the opinion of the panelists? Why do you want to complicate a simple thing?
Does somebody want to take that question? Nobody? Arun, let me give it to you.
No experience with this system, so I can't really tell you. But I mean, putting fixed blocks to get your flexion gap, I think that's what you're alluding to. Yeah. Without taking into account what's the condition of the soft tissues in flexion, whether it's tighter, looser, etc., is not something that I would readily do just because it's easy. I think you can assess it. And if the gaps are okay, then it makes sense. But I think you still need to check whether your medial lateral gap balance in flexion is appropriate. And not just...
Okay, so I'm sorry, we only have 30 seconds, so I'll let you take it up with Arun afterwards, because it's a very instrumentation-specific question. Last question, number 2.
So when you are using ultra-congruent or medial congruent, does retaining the PCL leads to kinematic conflict, as you were asking?
So that was the question that I asked Ashok. He says he doesn't think so routinely. Ashok, do you want to expand on that briefly?
So we have actually published on this, doing the medial congruent with and without retention of the PCL. The only thing that is different is range of movement is slightly better when you take down the PCL. Otherwise, kinematically, in terms of gait analysis, the results and outpatient outcomes is absolutely identical.
And one thing I think we should just mention to the audience, not all medial stabilized implants are the same. Some are very constrained on the medial side, some are modestly constrained on the medial side, and it may depend a little bit on which specific implant system you're using, how you're going to effectively balance the knee, understanding that each implant system is a little different than the other.
Dr. Naik, last question and we finish.
Okay, last question.
Thanks. Sir,
at the end of the surgery, supposing you have a flexion deformity of about 5 degrees, you end up with a flexion deformity after you thought you have done a good job. How do you proceed? Do you go down and correct that deformity, or you accept the physiotherapist to take it up?
Okay, let's give that to Parag. Parag, at the end of the surgery, the knee does not come out quite straight, but it's only a 5 degrees short of full extension.
So if it's
do you get excited or do you do something more?
So if it's an osteoarthritic knee, I would not accept it. When I am not cemented the knee, I will know it before cementing is there. I will take all the efforts to correct that flexion deformity.
So
because if
that would mean posterior capsular release, and then if absolutely necessary, a little more femoral resection?
Absolutely.
Okay, fair enough. So the answer, it sounds like, is try not to accept it, try to know about it while you have your trials in place. What if it happens at the end of the operation, Parag, and you didn't catch it with the trials and now you look at it? What do you do now?
I'll blame the physiotherapist if he doesn't correct it.
Tell him you're going to have to work really hard to get your knee straight, man, sir. All right. Okay, ladies and gentlemen, please join me in thanking the panel. I hope we had a good discussion. Now it's time for your coffee or tea break. It will reconvene at 11:30.
No coffee break. No coffee break.
Oh, no coffee break.
No coffee break.
What's going to happen?
The program's changed.
Oh, the program's changed. Well, Parag's the boss.
So we've decided no coffee breaks, a photo. And after that, before Dr. Rajgopal starts, I will request Sachin to show yesterday's x-rays, post-op x-rays. So no coffee break, please. The continuous tea coffee is available outside, those of you who want to go.
Okay, see, so these are some follow-up x-rays from yesterday's patients. Advance, please. So this was the first patient she had a varus, which was roughly around 9 degrees and had a concomitant root repair as well. Next, that was the planning. We planned for a 10 millimeter opening to bring her MPTA to 92. Next slide. And these are the post-operative x-rays. Next. And the MPTA has been restored to 91. The limb is neutral. Next. And the slope has not been altered. Next one. The next case was the one which I did, which was slope changing, valgizing high tibial osteotomy along with a concomitant PCL reconstruction and a posterolateral corner reconstruction. Next. This was the coronal plane deformity, which was roughly about 5 degrees in the coronal plane. Next. The correction that was planned was 6.9 millimeters of opening. Next. The monopedal stance view had a very low tibial slope of 3.6 degrees. Next. And these are the final outcome x-rays. You can see that the osteotomy which I have performed is quite distal because we had to accommodate the tunnel for the PCL. Next. And the MPTA has been restored to 90. The limb was neutral. Next. And we've increased the slope to 12 degrees, which is what we want to protect the PCL. Next. The last case was, the third case was a distalizing tibial tubercle osteotomy. Next. As you see, the preoperative planning showed a patella alta with a CD ratio which was 1.3. Next. And this was the post-operative outcome with a distalization osteotomy of the tibial tubercle. Next. And the CD ratio has been restored to 0.7, which is in the normal zone. Next. The last case was a varus deformity, which required a double level osteotomy. Next. This was the deformity, a 19.5 degree varus deformity on the right side with an abnormal LDFA and an abnormal MPTA. Next. This was the correction with 11 millimeter closing in the femur and an 8.6 opening in the tibia. Next. And these are the final outcome images which show next that the MPTA has been restored to normal and the limb is now straight with a closing in the femur and an opening in the tibia. Next. So this was the final outcome from yesterday's patients. I thought all of you who were there yesterday would be interested in looking what the post-operative outcomes were. Thank you so much.
May I request the panelists to come on the stage, Dr. Arora, Dan Berry, Dr. Gautam, Rajesh is already there, Mahesh, Amar, Naren Reddy, and Nandu. Right. So again, a lot of issues to be discussed. My disclosures. These are all the various points that we're going to be considering. We have limited time, so we want quick, short answers. No repetitions, please. I'll try and get through this. So let me look at the first issue. A patient with multiple incisions. We have two scenarios. Amar, a patient who has multiple incisions and has good movements. Any thoughts around that? How would you address this? Let's take the slide on your left.
Yeah, I mean, you know, we're classically told to use the most lateral incision, but 9 times out of 10, these incisions were done 10 years or more ago. And so most of the time, I will choose the medial incision, and I've not personally had a problem doing that. So I don't believe that that teaching of using the most lateral incision is appropriate unless it was a very recent incision.
Right. Anyone in the panel disagrees with that or has a different point of view? Is Dan here? We need Dan on the panel as well.
If it is a older scar, 10 to 15 years old, I don't care. But if it is a recent one, I still choose the lateral must incision.
Okay. Would your approach be different, Rajesh, if this knee was multiply scarred and it was stiff?
Yes, I think, and what you mean is that not only the knee is stiff, but the skin over the knee is also not mobile.
Yep.
That's what would worry me, and
Yep.
I would definitely involve plastic surgeon at that stage.
Okay.
It also again boils down to how long back the incision was. That is the key thing. If it is a recent one, that worries me most. If it was few years, then it worries me less.
So Nandu, would you consider tissue expanders? Would you do it? Would you have your plastic colleagues step in? How would you do that?
I think expanders is a great idea, provided you select the right patient. I think it's plastic surgeons who generally perform it. In a multiply operated, in arthroplasty after tumors, I think it's something which is very useful on a day. It can create a good pouch,
okay,
a good medial base flap.
All right.
And lateral most incision can be accessed by around 25, 30, whatever degree of recommendations.
Okay. Anybody in the panel have experience of doing what John Insel described as a sham incision? No one. Okay.
Sir, only if the patient had a previous pedicle flap, sometimes, if the planned incision is away from the margin of the pedicle flap, once you had tried with the sham incision.
Okay, so you would consider that.
Ashok,
yeah.
Many a times you think that the tissue expanders will be required, and you speak to a plastic surgeon and they would rather say that at the time of surgery I'll come and little rotate a flap.
Right.
So many a times they don't want to use a expander if they can do something else at the time of surgery.
That's exactly right. Tissue expanders have really sort of gone out of fashion now, and most times they will work around flaps and so on and be able to
So
get...
can puckered scars which are puckered and dimpled, is very useful.
Okay. Right, so in stiff incisions, stiff knees, these are the various options available. If you had a stiff knee, multiply scarred knee, you've done your incision, which of these would your exposure be? Starting with Amar? Just choose one out of these.
Yeah, I do a rectus snip routinely.
What snip?
Rectus snip?
Rectus snip, in the past I used to do VY, and you don't need it when you do rectus snip, it actually opens up.
Rectus snip little further than the tendinous part of the tendon ends.
Gautam?
Rectus snip, but at the end, after the surgery, if the range of motion is less, I would like to convert it into a PY.
Narendra?
Only experience I have is rectus snip.
Mahesh?
Majority of the cases, rectus snip is good enough only for cases which are stiff in extension that you might have to consider tubercle osteotomy.
The only point I want to make is I'll have a lot of fellows and residents, they'll go up too high. So they'll make a very long extent, and then you can't do a snip in the muscle.
Yeah.
You got to do a snip in the tendon, right?
Yes, that was the next point. So what is the site of your snip. How far up do you go, Rajesh?
So I think it'll depend on the patient's quadriceps tendon. I look at it, how far, you have all different types. Someone with a very short
So
quadriceps.
is there a landmark that you have that
I want to go at least 2 inches above, if it is possible.
Anyone do
Roughly.
anything differently? 2 inches, 1.5 inches, anyone else? Anyone do anything differently?
I mean, I think that the take-home message that I want is you want tendon to tendon healing.
Yeah,
Right. You don't want
absolutely.
muscle to muscle healing.
Right. So these are just some of the references that would, some of these very historical turndowns that were described, and there's a very nice article in BJJ in 2015 that alludes to this. Just as a point of contention, rectus snip versus TTO, some of the recent articles have actually alluded to this. They've actually recommended a TTO as a better option, but I think, as you heard, most of the panelists prefer to do a rectus snip. Right, we move on to the next post-traumatic.
Can I go back though? And,
yeah.
A well-performed TTO probably does better than a snip in a very stiff knee. However, if you get a complication from a TTO,
the results are pretty bad.
That's very bad.
Yeah.
And you don't get complications from a snip.
Yeah. Your post-operative protocol remains exactly the same. Yeah. Right, so we come to the post-traumatic arthritis, managing implants, evaluating implant stability. So let's go down the panel. Dr. Reddy, you have this issue. How do you plan your post-traumatic arthritis? Very short answers, very quick answers. Yeah.
Straightforward, I rule out infection or not.
Okay.
That's the first point. Otherwise, straightforward, remove the implants and go ahead with the total.
One stage, 2 stage. Do you have preferences?
Most of the times go with 1 stage.
Okay. Mahesh, anything you do differently?
I mean, if the ESR and CRP are normal, no infection, you could consider it doing in a 1 stage, but I prefer to do a 2-stage procedure for implant removal and TKR.
Okay, so what Jayant, what kind of problems do you anticipate in these patients?
So I think it's generally the question would be, should we retain the implants or are they going to come in the way? That's what something needs to be assessed. Stiffness associated, soft tissue contractures due to trauma, patella baja. So these are the things which would be important in this particular case.
Do you arrange for any special implants in case? Let's say take this particular patient. Would you keep something that you don't keep ordinarily?
I think for the femur, most likely a PS. I'll probably keep a LCCK type of an implant, a slightly more constrained implant.
Okay.
But just in case, yeah.
And what do, Nandu, what do you tell your patients? So what kind of results would you like to tell them?
Concerns can be infection. The high chances post-op, it can land up in an infection which was not there before.
Okay.
Smear while you open the patient is important.
Smear for?
Smear to pick up whether you have polymorph count going beyond certain limit. There are markers which have been put by the Infectious Society.
Rajesh,
Infectious Society.
would you add to that?
Are you talking about this patient?
Yeah, let's take this for
so this is non-union to me.
Yeah.
And so I think I would, and also I would be worried about infection in this patient.
Okay, we've talked about that.
Yeah. The implant-wise, I would keep sleeves ready because I think I might be able to get away using a sleeve and a stem on this with the non-union itself.
Right. So if you look at the epidemiology, it accounts for 10%. Risks of complications in this cohort is extremely high. These are the various issues, the bony issues, the soft issues, the contractures, the retained implant, risk of infection. I think you've all alluded to that. So let's take this for example. This patient had arthritis. So Amar, very quick, what would you do? 1 stage, 2 stage? What would be your choice of implants?
My choice would probably be to take it all out in a first stage. The patient has to agree to that, and the problem is the lateral plate. The medial plate you can deal with in the time of surgery. The lateral plate's challenging. So one of the decision-making points is, do I take out all the hardware or selective hardware? If the patient elected to do it in 1 stage, I would take out the medial hardware and I would leave the lateral plate and probably take out just some proximal screws using some small pinhole incisions.
Okay. Mahesh, anything specific you have in terms of the implants?
For the implant removal, you mean?
Yeah. Would you do this in one stage, two stage?
I would definitely do it in two stage. It depends on what approach has been used previously.
Yeah.
And also you probably need to have the broken screw removal kit, and sometimes I rely on my trauma colleague to remove that plate for me.
So that's exactly what we did. We did this in a two-stage. This is the post-operative X-ray, fairly uneventful.
Ashok, can I ask you something?
Yeah.
Where you've used a long stem with a cement, is that correct or?
No, that's not cement, no. We've used a hybrid fixation there because there was a considerable amount of bone loss. So these are very, very old. We didn't have access to sleeves and cones at that point of time.
And amazing that you've not had a cement extrusion from any of the screw holes. With so many screw holes were there.
We actually
Did you do anything special there?
Yeah, we plugged it with bone debris. Yeah. So the outcomes, as I said, results of post-traumatic arthritis is not particularly good. Lots of complications. Worse outcomes when there are both defects on the femur and the tibial side. And again, the common denominator is outcomes are poor, risks of complications, infection, and stiffness. And these are some of the more recent articles, including one from the Dutch registry. In terms of stress fractures, let's start from the far end. Narendra, very quick, how would you address this? What investigations would you do? Blood work, radiology, anything?
At this stage, once a patient presents like this, even if you get vitamin D deficiency also, I'm not bothered about this at this point of time. I'll go ahead with the surgery and supplement post-operatively with whatever deficiency is.
Mahesh, would you fix the fracture first and then address it, or would you do everything together?
No, this is everything together job. This is a mechanical failure, stress fracture of proximal tibia, intramedullary instrumentation for the tibial cut using a stem.
Would you consider using some sort of a technology here, Rajesh?
Yes, I would. And I think the non-unions are not a problem.
All right.
It's the mal-unions which are the problem.
Okay.
But in both, I would use technology to get my...
So this is really what was done. Dan, would you agree with this? Would this be acceptable for you?
Apologies, I came in a minute late, so I didn't get to see the very start of the case. So I don't want to take you back through it.
No, so this was the preoperative patient, preoperative X-ray, and this is really what was done. Your comments on this?
Yeah, I mean, this is one way of approaching the problem. The other way of approaching the problem would be to use an intramedullary approach and fix the entire thing from the intramedullary side without putting a plate on there.
Yeah.
Probably I'd prefer the former rather than the latter, but you know, there's different ways to do it.
Yeah, so this patient actually, you're exactly right, it collapsed into varus, had subluxation dislocation. This was a PS implant, and this is really how we addressed it. With a revision system. A maluniting, ununited, again, stress fracture. Again, I'm not going to dwell on this. We used a long stem, exactly what you said, Dan. Bone grafted this with the material that we had. High tibial osteotomy, that went terribly wrong, again with the same type of an option.
Ashok, can I just, I will say though, having come to India for several years now, the incidence of this problem in India is much, much higher than, in North America and in the rest of the world. So it really shows that the bone metabolic problems in India are very real.
Yeah.
There's no doubt about it. And by the way, I just make the added emphasis. You showed a number of cases successfully with the intramedullary device. And I think that's really the favored technique because it's more biologically friendly than putting an intramedullary device in and an extramedullary device. And it also does a little better job of guaranteeing your alignment. So there's a lot of advantages to it, so long as you can get sufficient fixation.
Yeah. Right. Coming to the severe varus deformity, and there's several classifications. This is by far one of the more recent classifications. So in terms of balancing, let's start with you, Dan. Your go-to, the structures that you always release,
So I will start with just only talking about the varus knee and the knee that needs releases. And it's important to point out not everybody needs releases. But if you're going to do releases, the way I generally do it is I start by working from the front. I work around the medial side of the knee, make sure that I've taken off the deep medial collateral but preserved the superficial medial collateral. I'll take off the osteophytes. I will work around to the semimembranosus and take off a little bit of the top of the semimembranosus. And then at that point, if the knee's balanced, I'm done. If the knee's not balanced, I will slide down the superficial medial collateral ligament just a little, not nearly as far as we used to do it, and particularly not in women.
Right.
And then if that doesn't do it, what I like to do is tension it with a lamina spreader and use an 18-gauge needle, and I pie crust it. And to be honest, the pie crusting for me was a game changer. I didn't think it would be that good. I thought it would be dangerous. I was worried about it. But at least in my experience, it's been a very good way to manage this sort of medium to medium severe varus knee, excuse me.
Right.
A really severe varus knee is a different game, but we'll talk about that later probably.
Naren,
Little bit lateralizing the tibial plate.
so you do a reduction osteotomy. Mahesh?
Exactly the same reduction osteotomy, and also depends on what structures to release depending on whether it's tight in flexion or extension.
Right.
If it's tight in extension, maybe posterior osteophyte removal and semimembranosus. Tight in flexion, I would do the anterior fibers of MCL.
Right. Rajesh, there's a lot of talk these days about not releasing soft tissues. And you use technology.
Well, I think, and that is true. 15 years back, we would release MCL distal
So
part.
you reduce it less.
Reduced it, but it has not become zero in our patients. I still have 15-20% of the patient where I will have to some extent.
So let's go down the panel. Just your preferred alignment. Amar, at the end of a varus knee, where do you leave your knee?
So, I'll start off with a 90-degree tibia. I'll talk about the tibia.
No, your alignment. I just want your alignment. Zero, neutral, valgus. Jan?
A degree or two of varus I'm ready to take.
Just go down the panel.
I err on the side of little varus, never on the side of valgus.
If I'm doing manual surgery, I like to get it zero. What I think I want to get zero, but technology 2 or 3 degrees of far.
Zero.
Dan?
Yeah, aim for zero, but if after I've aimed for zero and I still think that I can solve the problem by avoiding a big release with a tiny bit of varus, yes, a tiny bit of varus, but I'd be a boundary of about 3 degrees.
Right, so these are the releases we talked about. The real issue is what you raised, Dan, pie crusting the medial collateral or medial epicondylar osteotomy. I know Arun has done a lot of work on this. There are some adverse reports of both pie crusting and medial epicondylar osteotomy 2016 and 19. These are some of the articles where you get what they call a stair-step failure at the joint line and the need for additional constraint in these type of options. This was one of Leo's works, one of his articles. Okay, we move on to the valgus knees. Our course chairman, Dr. Ranawat's fabled classification for valgus knees. So here is does anybody go away from their conventional? Do you go to a lateral approach when you're dealing with valgus knees? Anybody in the panel do a valgus exposure? Okay, nobody does that. Jayant, how do you address rotation on the femoral side?
Nowadays, I think we have the luxury of technology, so a CT scan would tell us.
No, tell me intraoperatively, how would you do? Let's not talk about CT scans. You have the patient on the table. What landmarks do you use, and what?
So in a patient who doesn't have significant valgus, I would look at PCA, but in a valgus knee, it would be epicondylar axis and right side line. That will help me guide the rotation.
All right. And do you use anterior or posterior referencing?
So I use anterior referencing most of the time.
Okay. Does anybody do anything to the lateral popliteal nerve? Do you explore in a fixed severe valgus of 20 degrees? Amar?
No, never explore it, but we have gotten more comfortable with exploring the nerve if there is a post-operative problem.
Okay. Nandu? No, anybody in the panel? Dan? Okay. How do you assess the adequacy of your release? Dan, let's start with you. You're starting with your release. At what point of time do you know that I've done enough?
So it's a good question. And what I like to do is under-release a little bit, because most of the time on the lateral side, most of the release for me is a pie crusting technique. So what I found is if you under-release a little bit and then continue with your operation and then recheck it, oftentimes it is stretched out a little bit more. The times I've made an error is when I've forced a lot of release at the start, and then eventually you see the patient back later and you say, you know what, I overdid that release a little bit. So I think under-release a little bit and realize that it will stretch a little with time if you're using the pie crusting technique as your primary way of releasing the lateral side of the knee. That's different than a case like that, though.
Right. Now, if you have a situation where you have a valgus and a hyperextension, which is not uncommon, how do you address the deficient lateral condyle, Gautam? Typically, in a hyperextension, you distalize your distal cut.
Less cut of the distal condyle. And
you have a situation like this, how do you address that?
I'll see after the cuts, after the tibial cut. First, I'll do the tibial cut, and I'll believe my tibial cut to make the base for the femoral cut of the posterior, and for the distal, if required, I'll have wedges in my backup.
Rajesh, how would you address this?
If there is, I'm taking hardly anything on the lateral condyle, then I would still accept it and use a primary component. But if there is a little gap, I would put a cement there and put a stem.
Okay. Right. And of course, I don't think this is rocket science. Severe valgus, unstable. Everybody agrees on a hinge here? Right, that's really what we did.
So, Ashok, can I just ask you a question? How do you make the decision in the older patient whether you're going straight to a hinge or whether you're going to try to balance it with a VVC type implant?
So, great question, Dan. In most patients, we keep pretty much all our options. A knee that is as deformed as this with almost 60 degrees of valgus.
That one nobody's going to argue about. But
yeah.
what about the one that's 25 degrees and the patient's 75 years old? Do you start with a VVC and then only go to a hinge if you have to, or how do you make your decision?
So we look at the integrity of the medial collateral ligament. I think if that is intact, then we try a less constrained type of an option. If the MCL is really, really stretched and the anatomy is all over the place, then we go straight to a hinge. Yeah. In terms of flexion contracture, what routine distal cuts does the panel take, Amar?
So I think we've done a poor job of teaching this. I don't think you should cut extra bone. I mean, if it's a huge deformity, there's sometimes that's something you should consider, but it's become too routine. This is a posterior capsular problem that you need to release.
Right, yeah.
After anesthesia, most of them get corrected for some extent. And after that only, I will decide my extra cut or not.
How would you decide how much bone is safe for you?
Sir, up to 6 millimeter, it is safer.
Does 6
But after that, I will change my component to the PS.
Does 6 millimeter worry you about flexion instability? Raising the joint line?
Not much, sir.
No?
No.
Mahesh?
Yeah, anything beyond 4 to 6 millimeter, you will get mid-flexion instability than flexion
You
instability.
almost always get mid-flexion and you elevate the joint line. Looking at extra-articular deformity, I think I'm going to skip this for want of time. We've had an excellent talk on this. So again, the options of extra-articular, simultaneous, or staged. And I think we have a wonderful presentation from Anup, I believe. So we're going to really sort of skip on this. So this is the criteria that we have laid out, and we published this a while ago. These were our coronal plane deformities and sagittal planes that we were able to correct with intra-articular corrections. Just some examples of these very, very difficult clinical situations that we did. We were able to restore the mechanical axis, and again, some references. For the stiff knee, again, topic that I'm personally very, very fond of. We've published extensively on this in terms of the in terms of getting the articulation. Just a quick comment on patelectomized patients. Dan, just your choice of implant in patelectomized patients.
Yeah, I mean, the problem with patelectomized patients historically has been the risk of flexion instability. And so I think that in patelectomized patient, you should be thinking of an implant that provides some stability and flexion. In most cases, that's going to be a PS implant, but there's other obvious choices now with very stable medial side.
Naren?
Nothing more to add, sir.
Anybody use anything other than PS? No.
Constraint inserts all the time in this.
Constraint, okay. So we have used CR for some of these. It stood the test of time. And very recently there is an article in the ACTA Orthopaedic and 2015 in CORR that CR is an option. This is Merrill Ritter's group.
Yeah, but to be fair, all these CR now, they're not CR, they're not round on flat. These are all highly conforming CRDs, so it's kind of a BS statement.
Right.
And to be honest, maybe the best answer is going to turn out to be the ultra-congruent knee for that type of patient,
congruent.
to be honest with you. Because a post doesn't really give you that much flexion stability. So maybe an ultra-congruent knee is really the best answer for those patients.
So we are out of time, but just one very interesting topic. Someone with a quadriceps deficiency, we're going to be talking only about patellar tendon. Let's just go down the panel. Your choice of graft, Amar, for a patellar tendon disruption following total knee replacement.
I mean, I would use a hamstring and do a reconstruction that way. And to be honest, I would have my brother do it, right? Like that's what he does, right? So I wouldn't even do it.
Right.
Semiti.
Rajesh? Semiti?
Yeah, tendon plus mesh repair is probably the best thing to do. Augmentation with a tendon.
I have no experience with it.
Dan?
So for acute would be primary repair with semitendinosus augmentation. Yeah. Chronic, we use Marlex mesh instead of allograft.
Yeah. So these are the options. Again, we published our outcomes with autografts using the quadriceps tendon and a patellar bone block. And we had reasonably good results with this. So on that, I'd like to thank the panel. It's been a great discussion that we have had. And we'd like to throw this open to the audience. So I encourage you to come up to the mic. Oh, I'm sorry. We have the cases now. Yeah. So the first presenter is Anup. Oh, Dhanshekar is first. Okay.
So,
good morning, everybody. Thank you for the opportunity, Dr. Amar, Anil, and Parag and Sachin. So I'm going to talk about severe valgus knee. We already had the discussion. So this patient is an 81-year-old gentleman who had a fall, had a trochanteric fracture, had a fixation with a PFN-A2. Post-op, he was unable to walk. So he was referred to me with this type of knee deformity. So bilateral valgus deformity, right side is severe. These are the supine radiographs. We can see the right side, he has a severe valgus with a nail in situ. Left side also, he has a valgus deformity. So I did a valgus varus test. Valgus, it is going to 25 degrees, varus it correcting to 10 degrees. This is partially correctable. There is bone loss in the femur and the tibia. And the skyline V, we can see the type 3 patella with the lateral bone-on-bone patella. These are the preoperative radiographs. Do you want to discuss or should I proceed?
Yeah. Let's stop there. Rajesh?
So I think the standard approach really, when you have a defect on the tibia like this, the medial collateral is not too stretched. And I don't think the medial collateral here is very unstable. I would do my standard tibial cut and start building up from there. The extra bone on the lateral side will be resected. The femoral cuts will be made. And then if there is a posterior capsule release is done and still there is a tightness, I would do either a pie crusting or joint line release or the IT bend. And if I, before I do that, the assessment would tell me that that's going to suffice. If the requirement is only 4 or 5 degrees, I would do that. Otherwise, a lateral epicondyle osteotomy.
Amar, would the hip status worry you?
I mean, as long as the hip healed and there's a union there, I don't think the hardware is an issue. My question was, what value did the stress views, offer you? I mean, you can do an exam and you can see if it's correctable on exam, but I don't understand why you got to do stress X-rays.
So what we call is a surgical valgus. The valgus which can be corrected with we need to correct it with the surgery. So you have an idea about how much it is getting corrected and what is the bone defect and what type of constraint you need to use. If you have a medial opening, you can document it. And generally more than 10 degrees of surgical valgus, I use a lateral arthrotomy. So I have a pre-op plan to how to go about it.
So
a little bit additional data.
You change your approach depending on the correctability of the deformity. Is that what you say?
Yes. For a rigid fixed valgus, I go lateral.
Okay.
And patients with the lateral patellar subluxation, I go lateral.
Okay. All right. So show us what you did over here.
So this patient, as we discussed, there is some stretching of the medial collateral ligament, which is important to understand.
So, Dhanashekhar, just for the audience, how do you assess when you say stretched? At what point does it start worrying you? Is there a number? Is there a degree of opening, millimeters? How do you decide that this much is enough and I can manage with primary implants, I need something beyond that? What's your number?
So when you do a valgus stress, two things can happen. The valgus deformity can be exaggerated because of the collapse into the bone defect, or it can be exaggerated due to the stretching of the MCL. If there is a firm endpoint, I think the MCL is good. We can use a standard implant, but if it's a very soft endpoint or there is gross opening, MCL is insufficient. Yeah. That's more of a physical...
I think that's a great point because you can get this exposure or the laxity on account of two issues. One is ligament laxity and one is because of the condyle actually collapsing into the defect. Right, great. Yeah, so tell us what you did.
Other thing we see is the metaphyseal bowing. We can see both in the femoral and tibial side when you're doing a valgus knee, so you need to take it into consideration. Here the valgus correction angle was 3.5 degrees, better to individualize for each patient. And this is a introp stress thing Amar was talking. It's partially correctable and laterally it's opening up. The huge osteophytes. I have done a lateral arthrotomy. And I have used robotic for this patient because we have the robotic system. And it is also good to teach. I can show the gaps, how it is changing. So I used it for this case. But you can use a short intramedullary jig to use the distal femur cut. So this is a 28-degree valgus. And on varus stress, it is corrected to 11 degrees. The flexion is now 118. We can see the lateral gaps are very tight. The difference is 10 mm. So we start with the lateral release. The exposure itself, we release the IT band and the lateral capsule we release. That is the initial release we did. Then we start the planning. I'm planning to undercorrect by 3 degrees. So valgus 1 degree in the femur, valgus 1 degree in the tibia. On the lateral side, there is no bone resection as you can see on the computer. This is the tibial cut. So we check it and then I use a sensor tensor, stretch the soft tissues to see whether there is a correction achieved. Then I do the distal femur cut. There is the resection only on the medial side. So the lateral side there is sclerosed bone. Generally you don't cement the a process on a sclerosed bone. So I removed additional 4 mm from the lateral side. I use a distal femur augment on the lateral side. I'm using a PS type of processes. This is the alignment and we can see there is 2 mm difference in flexion and extension. But the problem is there is a mid-flexion laxity. As we flex, you can see there is a mid-flexion laxity. So for this, I need to lengthen the lateral side and stretch the posterior capsule. For that, I opted for a lateral epicondyle osteotomy. This is you can see that attachment of the lateral collateral ligament. So distal to the lateral collateral ligament attachment, we can remove the bone and then slide it down and release the posterior capsule to get the extension gap better. So I used from 5, I moved to 10 mm insert. Now the difference is only 2 mm. This is the final alignment correction. I use a lateral augment and fixation for the lateral epicondyle osteotomy. Post-op, we keep the knee in flexion for 24 to 48 hours. This is the 1-month follow-up X-ray.
Then,
yeah, please go ahead.
Then, do you think in this case you would have rather gone laterally? Because from what all you described, would have been better seen laterally.
Better?
You went laterally, sorry.
Yes, I went laterally, yes. So just a few more take-home points. Dr. Ashok showed this.
Ashok, can I?
Yeah, yes.
Sure. You know, I think the point I was making that when you have a lateral tibial condyle defect like this, the medial collateral does not stretch beyond that. And he's used a standard implant here.
Yeah.
That medial collateral to me did not appear stretched. And the standard implant sufficed.
Yeah. You're exactly right. The deformity was on account of the condyle actually collapsing into the defect on the tibial side. Yeah.
So for a type 1 correctable valgus, Amar and Ranavat has described inside-out technique, posterior capsulotomy and IT band pike resting. So it is can be done with the standard processes. For a type 2 partially correctable valgus, again you can do a sliding osteotomy, which we have published our experience of 28 patients. Or we can do a slightly constrained implant like this, a TC3 or LCCK. Metaphysio-diaphyseal remodeling, again Dr. Amar and Ranavat has published. We have published our experience in Journal of Orthopaedic Surgery. You need to have a more medial reference when you're using an extramedullary jig. So your alignment of the tibial component is perfectly placed. And lateral retinocular release, it might be necessary in subluxed knees. This also we published in Indian Journal of Orthopaedics. And we already discussed severe valgus, post-HTO, we use a hinge type of processes. And severe stiff valgus, we have our experience of common peroneal nerve release. We do a isolated lateral incision, release the peroneal nerve from the fibroosseous tunnel around the fibula and avoids the lateral peroneal palsy. Bone loss has to be managed. Sequential release is helpful and use of constraint process may be useful in severe valgus deformity. Thank you.
Thank you very much, Dhanashekar. May I now ask Anup to come and present his case on correction of extra-articular deformity.
So good morning to all of you. Let's see if we can do, let's see if we can do kinematic alignment in extra-articular deformity. Where did this, so this is the case. This patient, 65-year-old man, had a bilateral femur fracture. We're talking of the left side, which is severely malunited, and in the distal third. And as you can see, we're talking in the morning, if the other side is normal or near normal, we can calculate the MDFA and MPTA pretty accurately and try and restore that, even in extra-articular deformities. So you can see that this patient also had a recurvatum deformity, so we have to analyze the sagittal plane of the deformity as well. So this patient had a 15-degree varus deformity and a recurvatum deformity as well. So the principles of kinematic alignment are that you cut equal distal medial and distal lateral considering the cartilage loss. So 8 and 6 or 9 and 7 is the distal medial and distal lateral cut, and the posterior medial and the posterior lateral cut are also equal, 9 and 9 or 10 and 10. So the interepicondylar axis, the insole boot, the grand piano are of not much relevance in kinematic alignment. What is of relevance is to create the pre-arthritic joint line by cutting equal distal medial, equal distal lateral, equal posterior lateral, and equal posterior medial. So femur is not negotiable, so you got to do the femur first. So when you do that, you can see that the femur is in valgus 1 or 2 degrees, the tibia is in varus 2 or 3 degrees. So you can see that the varus on the tibia is 3 degrees, the valgus on the femur is 2 degrees, the distal lateral extension gap and the flexion gap is more. So that's what you want. The flexion gap in the lateral side has to be 2 or 3 millimeter more. And the final alignment is about 1 degree varus without doing much soft tissue release. That's the verification of the cut. And it's interesting that you don't need to do much soft tissue release even in extra-articular deformity. So we don't go to the posterior medial corner, we don't release the semimembranosis, we don't pie crust, and we don't do anything including downsizing. And in this case, the PCL was intact, but because of the recurvatum deformity, we were suspect of the PCL. So ideally in kinematic alignment, the PCL needs to be preserved. So that's the final alignment without doing any soft tissue release, without doing any pie crusting or downsizing. Flexion 3, varus 2. And that's the final assessment of the gap balancing. Now let's analyze critically the X-rays. So we are horrified of putting varus on the tibia. We should not be. 2 to 3 degree varus on the tibia is normal, and you can see there the x-rays don't look bad. 1 or 1.5 degree valgus on the femur, 3 degree varus on the tibia. The critical point is that the gap in extension has to be absolutely well balanced. That's not negotiable. Lateral laxity is not acceptable. And in sagittal plane also you can see we have given 5 degree flexion to the femoral component, which is parallel to the normal sagittal plane of the femur in this particular patient. We give overemphasis to this line that we keep drawing, and we aim for a 0. 0 is not the goal. The goal is to recreate the pre-arthritic joint line. 2 or 3 degree varus is very well acceptable, provided you are well balanced in extension and trapezoidal gap in flexion. And we are not always in bipedal stance. We are mostly in single leg stance. So this bipedal stance X-ray that we keep analyzing is overemphasized because we are seldom in bipedal stance. We are usually in single leg stance, and in single leg stance you can see that the joint line is parallel to the ground because of knee adduction arm. More important than these X-ray evaluation is the evaluation analysis of the gait. The gait, there should be no lateral thrust, and in the sagittal plane, the knee should hyperextend 1 or 2 degrees because we need hyperextension 1 or 2 degrees in foot flat of the stance phase of the gait. And the knee should hyperextend a couple of degrees to ensure that you can propel forward. We can also allow deep flexion once you don't release any ligaments and you do kinematic alignment. You can also allow deep flexion. It's interesting to observe that when you do a fluoroscopic analysis of this patient, there is no condylar liftoff and there is nice femoral rollback because you have preserved the lateral flexion space little looser than the medial space. So those are the 10 commandments of kinematic alignment, which if followed religiously, you can get good results even in extra-articular deformity. Thank you very much.
Thank you, Anup. Can you join us on the podium?
No, it's all right.
There's one chair there. Yeah. I think you made a case for kinematic alignment, and this interest will carry on in the panel discussion as well. Dr. Lokanathan is going to present management of stress fractures, lessons learned.
Good morning, everyone. This is about a 59-year-old female, short-statured, obese, presented with both knee pain, more on the left side, and was diagnosed as osteoarthritis both knee. And as usual, patient refused surgery. So she came after 1 month to me, presenting more pain on the left side. Now at present, the pain is more just below the knee. So we took a full leg X-ray, and we don't find anything suspicious. So she was treated conservatively and she was sent back. So 15 days later, so there was a severe pain and not able to walk. There was no fall, but there was one history of a click followed by a severe pain. So she presented to us with this situation. So we diagnosed as a pathological fracture because there was no fall or any injury. So what is the further course of action?
So the first question is, Amar, how would you investigate this patient?
So as I mentioned before, this problem is so common here in India that, she needs a metabolic bone workup for sure. Yeah. She obviously probably needs vitamin D, I agree with that, and maybe even bisphosphonate treatment. But yeah, listen, you can decide based on the severity of your knee problem whether you do this with a primary knee and a long stem, or whether you just treat the fracture first and come back later and do the total knee. That's a decision that you can make, but you could do it either way.
Yeah. Mahesh, how would you approach this?
Looks a little bit unusual for a stress fracture. The stress fracture that we commonly see is failure in varus on the tibial side. Yeah. Here the failure seems to be on the anterior cortex, so I'll be a little bit suspicious to make that diagnosis of a stress fracture without further investigations.
What investigations would you want?
Definitely would consider an MRI scan to understand if there is a lesion in the tibial shaft area.
Would you get a BMD done?
No, not normally.
Not normally. Dan, Anything that you would...
No, I agree with the points. You see more stress fractures than we do of the tibia. I agree with Amar about that. Having said that, the ones I've seen do not usually follow this pattern. It's a short oblique one. It looks like the anterior cortex. So I'd image the patient, have a metabolic workup. If that all comes back negative, then you can manage the fracture.
Right. So tell us what you did.
So
Ashok,
we staged all the parameters were blood.
Rajesh, you have a point?
Yeah, so for us also, this is a very unusual.
It is unusual,
very
for
unusual
sure.
stress fracture.
Yeah.
And I'm just thinking whether there's something in the hip or what else is going on here.
Yeah, exactly.
So
Did you get a scanogram done for this patient?
So no, so we did a CT scan to know, but
No, did you get a scanogram, a full-length X-ray for the hips?
We didn't have an option of having a scanogram.
All right.
But we did a CT scan to know whether there is any pathological lesions at that site because the MR was not accessible to my hospital.
Right. So what is the BMI of the patient? That causes a lot of issues. Short patient with a varus deformity, they can have a lower fracture. I have seen fractures like this.
Okay.
Walking with a varus deformity, short fractures.
Yeah,
I mean short ladies.
But typically it is a lot higher. You don't, and it's basically a medial transverse. This is an oblique, it's an anterior. It's an incomplete fracture. The posterior cortex looks kind of intact. It's the anterior one that snapped.
Yes, sir. We don't want to agree with the stress fracture, but we still wanted to do
Sure.
CT scan. We ruled out any pathological lesions. And this one advantage of doing a CT scan, it gave me the distance from the joint line. So I can be prepared for what, if I'm going for a long stem, what kind of the length of the long stem I can go for it.
Yeah.
So it was 13 centimeter from the joint line. So we have an option of 75 mm,
Sure.
115 and 150 mm was the length which was available. So we went for a staged bilateral at a gap of 3 days. First I did the left. So this was the immediate post-op. So what we were able to use is the 10 mm diameter and the length was 115 mm. Beyond that it was not negotiable because of the narrow cortex in the distal femur.
Was this a 12 millimeter stem?
It's a 10 mm diameter,
10.
115 mm length.
Okay, all right. Did you graft it or?
No, sir, I've never grafted. I never opened that site.
Okay, you didn't. All right.
You should have plated it, I think.
How many on
It's
the
too
panel
short.
would have plated this along with the TKR? Anyone on the panel would have done it differently? Just plate it. It's a low fracture, unusual. Anyone?
After I saw the X-ray, I would.
It's right on the edge, right? I mean,
it is.
You'd like a little more fixation down the
Yes.
tibia, for sure, another couple centimeters.
Yeah, okay.
So I allowed the patient for a toe touch. This is 15 days post-op. Patient came for suture removal. And 3 weeks later, it failed and it collapsed in varus.
Yeah.
Patient was walking on toe touch, but I was not sure whether she was obedient following the toe touch. So this is the situation which I encountered 3 weeks post-surgery.
Yeah. I guess, you know, with the kind of fixation, the very point that we've been discussing, it's a very low fracture. The purchase that you have on the distal fragment is really not adequate enough. Maybe, or if you have to choose this as your option, delaying weight bearing on this would definitely be on the cards. 2 weeks toe touch. When you say toe touch, you don't really know what they're doing.
Yeah.
You don't know how much weight she is putting. And so what did you do after this?
So we are, of course,
You
I
put
involved
it-
my trauma team to go for a dual plating. They went
Okay.
for a dual plating, rigid fixation.
Okay.
And this is 2 months post-op. Patients were made to weight bear. 6 months post-op, weight united.
Okay.
And this is 1 year, the patient is walking comfortably.
Right, okay.
So what are the lessons we learned is we have to strictly follow the principles of fracture fixations, even though we are replacement surgeons. Longer stem would have been always possible, if at all. It is always use a longer stems. Additional plating could have prevented this failure.
Right. Yes, Rajesh.
Here is that, sorry, the shorter stem, you would say keep non-weight bearing and allow it to collapse, but in that case you'll have to do a fibular osteotomy. If you had kept a shorter stem, a fibular osteotomy, non-weight bearing, it had a chance.
In this case, a fibular osteotomy, you're saying?
When you had only a short stem with you, ideal would have been a longer stem. Ideal would have been a longer stem. And even if you had to ream and put a longer stem, I would have gone for that.
Yeah,
But if not, then I think keeping the patient non-weight bearing and doing that fibular osteotomy, because that is the only way you can win. You have to compress
But
that
wouldn't
fracture.
that it make more unstable being a fibular osteotomy shorter
Rajesh,
stem?
I guess he used the longest stem that was available. That is like 150, I think. Right, okay. I think in the interest of time, we've got to move on. We come to the last case. Thank you very much. That was a lovely. Please join us on the table. The last is...
So there's no last case. The person has not come, so we can go ahead with the
we can go
question answers.
Right. So the floor is open. You can come up to one of the mics and address your questions. You can tell us who you want these questions answered by.
Remove that.
Yeah, mic 3.
That was a very interesting panel discussion. I'm Dr. Raval from Indore. I guess that most of the panel for severe lateral valgus or even valgus deformities use medial parapatellar approach. I just wanted to know what is the hesitation from the panel. Why don't we use, what is the concern? Because I've used a lot of patients with lateral parapatellar approach without any problems.
Wound closure.
I think in a line, you're used to medial parapatellar. You do that all the time.
Yeah.
And it just comes naturally. And doing a valgus knee from the medial side is not that much of a challenge. I mean, if you're brought up on a diet of a lateral exposure, that's absolutely fine. There's no sort of arguments. But the majority of people go back to what they're familiar with, what they're comfortable with. And the majority of surgeons use medial parapatellar incision. You can still do lateral releases. You can get to the posterolateral corner. So I think it's really, there's no must-dos or not-dos. It's just familiarity and comfort that each surgeon has in their mind.
Ashok, can I say something? I did lateral approach in some of the cases and I came back doing the medial. I didn't think that there was a particular advantage of the lateral approach, and the downsides were there. One is that you're looking at the tibia from a different angle.
Absolutely, yeah.
Your patellar, like what you described, banana peel, maybe you may have to do a little bit when you are doing from a lateral side exposure. And the worst, to me, I do a lateral retinacular release from outside so that my synovium remains intact, which doesn't happen with the lateral exposure. And at times that can remain open. You can close it by turning a flap of the fat pad and etc., but it's an extra work.
Yeah. Anup, can I ask you a question? Sorry, I'll just come back. On great case, wonderful sort of demonstration of managing that extra-articular deformity. Was the slope on the tibia anterior? One of the couple of your views, I seem to have got the impression that it is possibly neutral or a little bit on the anterior side. Or have I got that wrong?
No, the slope was 3 degrees.
No, I mean on the sagittal plane, was the slope anterior?
No, sir.
It wasn't. Okay.
Yeah.
Yeah, Mike 2.
This is Dr. Shetty from Mumbai. My question is to Dr. Rajesh Manyar. So you've been using navigation all throughout, and still you're using navigation as well as robotic in one of the hospitals. So in primary complex cases where the MCL is very tight now, have you found any difference with the robotic, and is there any paper coming out to show that your soft tissue release with navigation and robotic has changed?
I don't think so it's going to change, because the robotic still uses navigation for alignment. And the rest of the, what you do, balancing, doesn't change with robotics. All what changes is that your cuts are very accurate now. And the placement, particularly in the sagittal plane or the femur, I really like it. I think but it doesn't change anything else. I don't think it suddenly is going to make your medial collateral much more easier. Maybe what you're achieving is easier, but I don't think it changes.
I think what Rajesh is really trying to say is that robotics is just one step further from navigation. So robotics is not really into its element. Right.
Robotics is great if you don't like holding the saw.
Mike 5.
If there is a malunited stress fracture which is already united, is it important to correct the deformity at the stress fracture site, or we can just pass the stem with the deformity there?
So the question is, it is already malunited. Yes. I think it would depend on the site of the fracture, first of all, and the kind of deformity that you have. You're really talking about now an extra-articular deformity. So in that case, you would deal with all the philosophies of managing it, arthritic knee with an extra-articular deformity, and there are sort of very clear dimensions on that. If it is closer to the joint, you need to do a corrective osteotomy. The further away you are from the joint, it's easier to do intra-articular corrections. Does that answer your question? Yeah.
And
Anyone on the panel to?
So one more thing.
It is all.
There was a thing like we should add a fibular osteotomy in a stress fracture. Should we add it to every stress fracture, or there's some particular indication to add a fibular osteotomy?
So Rajesh, you mentioned about stress fracture.
Not in every stress fracture. I think here is a situation where fibula was intact and you want that tibia to collapse. You probably, in every malunion of the stress fracture, if you are correcting that, yes, probably you will need to add a fibular osteotomy. Okay, but an acute fracture, not every acute stress fracture will need a fibular osteotomy, no.
Okay, Anup.
I just want to clear my doubt about the approach of in the valgus knee. Suppose we have used a medial peripatellar approach, and if the patella is not subluxate, tracking normally, then you have to do the lateral release. In this situation, you may lose the blood supply of the patella unless and until you follow the Dr. Maniar's approach. So I want to clear my doubts.
So Dan, do you want to take that?
Yeah, I mean, we're used to doing lateral releases and preserving the lateral superior retinacular vessels. It's not so hard to do. You'll find them at basically the superior border of the patella. Once you identify them under the synovium, you spread with the scissors above and below, slide underneath. You can do a lateral retinacular release and completely preserve the vessels. So whether they stay patent after they get stretched, I can't tell you, but the point is you can preserve them.
Yes, Amar.
I will say, though, that the amount of lateral release that has been done
has come down.
Yeah, you don't need to do it.
Yeah, has come down significantly.
Agreed. I mean, with good rotation and good implants, you probably don't need it that often, but if you do need it, the point is there's a good way to do it safely.
Right.
There's another thing, Ashok, that even if you release both, and it does happen that sometimes you have to do extensive release, the patella does go through a phase of less vascularity, rarely complete avascularity. What is the reason? We don't know. There are isotope bone scans and the studies that have taken place, and the patella revascularizes. All that happens in the 6 months to 1 year.
Right. Mic 5, please.
In extreme varus deformity, even after correction of the varus deformity, there is some residual lateral laxity. That there is no varus, but there is lateral laxity. So I would like to know from the panel how to handle that, and if lateral epicondylar advancement osteotomy is an option.
So let me ask the panel a show of hands. How many of you encourage osteotomy of the medial epicondyle?
He's asking about the lateral epicondylar advancement.
You're talking of lateral or medial?
So, see, varus deformity is corrected,
Okay.
but there is residual lateral laxity.
Okay.
So, what should be done?
Okay.
So, I think what you're saying that the alignment is corrected, but your ligament balance is not corrected.
That's right.
When there is a lateral, if it is only a degree or two more than the medial side, I wouldn't mind. But if it is more, that means you have got correct alignment, but you've not got correct balance.
Soft tissue balance lax.
You still need to do soft tissue balance.
I think you need to do some sort of a release on the medial side. You can do it by soft tissue release. You can do it by pie crusting. So how many on the panel have at one point of time or the other done a medial epicondylar osteotomy? Show of hands. So 4 out of 11. How many of you have done pie crusting of the medial collateral ligament? That's your answer. Does that answer you?
Thank you.
Yeah. Mic 1.
I'm Dr. Pandey from Jalandhar. So my question is about that last stress fracture that we saw. In the presentation, it was said that CT scan was done for the pathological fracture. I want to know the opinion of the panel, like how many would do a CT scan to rule out the pathological fracture, and how many would depend upon MRI rather than CT scan? Well, if you have to choose between the two, is it MRI or the CT scan?
It is always the MRI, but in that situations, we had a no CT scan, so we did a CT scan.
Dr. Loganathan, can I ask you, why did you get a scan done in the first place? Were you suspecting something? Was there some pathology that...
I was damn sure that the fracture is quite distal.
Yeah.
The one reason is I want to know the distance from the joint line so that I can have my inventory on table.
Okay.
Rather
So
than
it
X-ray.
was more a technical point, not a diagnostic point.
Yeah, one
You're
thing.
not suspecting anything.
And of course, there was no fall, and I was not suspecting as a pathological fracture.
Okay.
So I just wanted to, any CT scan could throw some light. If there is a light occlusion inside the bone, maybe I would have gone for an MRI.
Basically you did an alignment or a scanogram, CT scanogram. Is that
CT scan of the leg.
Yeah, okay.
Ashok, there is one more point I wanted to make. 15 days before the fracture patient had come, and that has happened to me many times, and I have done a MR or even isotope bone scan in such patients and picked up the stress fractures at that stage. Yeah. So I would make a point of that.
Isotope scans will show up an impending stress fracture.
Even the MRI does show up, but
Okay.
isotope scan would be better.
Yeah. Right.
The point would be that we should do the MRI, even if it's not available in house.
Rather send him to the other hospital or nearby MRI center and get it done.
So how many on the panel would have done a CT scan or an MRI scan for this particular patient if they had come to you?
After the fracture?
No, this presented to you, how many of you would have done a scan, CT or MRI or both?
Well, I think with the history what he was giving, I might have done.
Okay, so the majority. Yeah, Mike too.
Extending for the same question to Dr. Loganathan, that since we know with the CT scan that the fracture is down up to 16 centimeters from the joint line and the longest stem will not adequately fix it, why not to do with the standard implant without a stem and fix it with a plate? Why to violate the canal in a primary T care?
It is always better to go for a load sharing device of a long stem in such kind of cases. The point we learned from that particular case is we should have augmented an extra derotation plate at the site, could have always salvaged the complications.
Yeah.
Will anybody go for a plate alone and a standard plant?
That is always an option. That is always an option that can be done.
It was an option. I think it's a very illustrative case because, I mean, the learning from this was low fracture, possibly stress, possibly traumatic, not adequate fixation on the distal side, early mobilization, weight bearing. I think the lesson, very elegantly presented is, on hindsight, maybe putting a plate would have been a safer option. Delaying mobilization would have been a safer option. So I think that's what these meetings are all about, presenting these cases and actually getting those.
So my question is, how many people in India are getting routine bone metabolic workups prior to their knee replacements? Because from what I see, it should be everybody.
It should be, but it isn't.
I get every patient's vitamin D done. If there is a doubt, even BMD, and try and correct it before. Yeah. It's very easy and quick way of correcting that.
But do you have a, do you deny surgery if somebody is very low on vitamin D?
Vitamin D levels come up really fast. I mean, you give them 2 shots of calcidol D2 sachets, 100,000
so
units or whatever.
If you give oral vitamin D,
600,000.
6 lakhs,
Yep.
on third day vitamin D level goes up.
Yeah.
Yeah, and so it's a very quick way of
It's
correcting
a really
it.
quick result.
The question here, whether I would deny the surgery, I mostly no, but I'll be prepared with various things that I would need to get to fix.
Right.
As he mentioned that he did a CT scan, probably I would have kept even a longer road ready for that.
Okay, last 3 questions. So,
To Dr. Raja
no,
and
I think you had your turn. Sorry.
To Dr. Raja and everyone.
Yeah.
So now that we have an extreme valgus case and we know that the nerve is at risk, so is there a short way to prevent the nerve injury, or is the consent only way?
So the fixed valgus, like more than 20 degrees, we do a peroneal nerve release. It's done through a separate lateral incision. We release the nerve from the fibroosseous tunnel around the fibula. We have reported 4 cases and
there is a very nice article that Dhanashekhar has published.
That's a good way, short way.
Yes, severe fixed valgus.
Right, Sanjeev?
Yeah. Hello.
And one more question out of
So my
this.
question to Dr. Dan and Amar, that is posterior offset femoral is important in total knee replacement surgery. One, because I couldn't see it's maintained by the technology in first 2 cases presented.
So is posterior condylar offset relevant? Was it maintained by technology? That's the question. Amar? Quick answers.
It's very relevant. I think that, not reproducing the posterior condylar offset will lead to flexion instability.
Yeah. Dan?
I completely agree, Sanjeev. So posterior femoral condylar offset is very important. It's important.
Okay.
Probably the most common reason not to get a happy knee is flexion instability.
Yeah.
So pay attention to it.
Yeah, so that was the 2 cases, first 2 cases.
Yeah, last point, last question. We're just running out of time. Last question.
Sir, I would like to ask, in every stress fracture, first should we get the stress fracture healed and then go for the joint replacement? or you can do it simultaneously and hope that the stress fracture will heal. What is the policy of the panel?
I think we have addressed that at length. It should be addressed simultaneously. Simultaneously, address it in a methodology that addresses your arthritis, gets a fixation. There are different ways to do it. Augment, support, intramedullary stems are usually the way to go.
Thank you.
Well, on that note, we are just on time. I'd like to thank the panel for a wonderful discussion, great cases. Give them a big round of applause.
Thank you, Ashok sir, and may I request all the panelists and Ashok sir for a group picture, please. Meanwhile, for the next panel discussion session for the periprosthetic joint infection knee arthroplasty, I'd be requesting our moderator, Dr. Alberto Cali, to head the session, and I'd be requesting the panelists for the next session. That would be Dr. Thorsten, Dr. Michael, Dr. Kaushal, Dr. Edward J. McPherson, Dr. Arun Mullaji, Dr. Ashok Rajgopal sir, Dr. Gurava Reddy sir, Dr. Santosh Shetty, and Dr. Hemant Wakankar to kindly go up the stage and take the seats.
All right, hello and good morning, everybody. My name is Alberto Carli. I'm an associate professor at Hospital for Special Surgery. It's my first time in India. It's an extraordinary privilege to be here with you. I was fortunate to be trained by Dr. Chitranjan Ranawat, my fellowship, and also Dr. Amar Ranawat. And it's just amazing to be asked to come and moderate this very important session on a subject which we all sort of have to deal with, unfortunately, in our primary arthroplasty practice, which is periprosthetic joint infection. These are my conflicts, not necessarily relevant. I do some consulting for Horaeus Medical that makes antibiotic cement. So as you can see here, we have a panel of really amazing people, really experts who come from across the world, obviously here in India and beyond. And I'll be asking them for the next 40 minutes some very important questions. We want to learn what these experts do and what they do in their institutions. So the three sort of subjects are how to prevent infections, preoperative optimization, how to prevent infections, what they do in the operating room, and then finally how to diagnose infection. And we'll hopefully have less consensus. Less consensus means more discussion. Again, this is in the context of an uncomplicated primary knee replacement, so no sort of hidden tricks here. And really what I want to know from these experts are, do you do this, or what exactly do you do, and what does your institution do? And of course, I have one or two slides for the audience just to dig in terms of literature and what's necessary now. So let's talk about preoperative prevention. A little bit of this has an overlap from Dr. Berry's really amazing talk this morning, but I think it's good that we have new panelists and hopefully less agreement on what to do. So let's talk about body mass index. Because we've got a lot of topics to go through, we'll just have a simple raise of hands here. Does anybody in the panel have a strict body mass index cutoff? Raise your hands if you do. Go ahead, Ashok. What's your number? I think you said it this morning. Remind us.
40.
So that means that when they come into your institution, they come to your clinic, you put them on the scale, and you tell them, not for me, sorry, or you have to go lose weight. What do you tell these people?
I tell them that 40 could extend to 42, but not grossly over that. I tell them that that's my cutoff. If I was to perform surgery, the risk of complications is going to be higher. It'd be better for them to look at alternative measures to cut down on the weight, whatever they want to do. If they still insist, then I would go, but my cutoff is 40, 42.
But Ashok, what if it's all in the belly and the knee is normal?
Great question. Great question, Ed. So the question was, if the body habitus is actually quite large, but the knee itself looks quite slim, will you reconsider?
No, because the weight is still going through that same knee.
Okay, so you're worried about mechanical wear.
You believe in the mechanical. It's a mechanical load.
It is a mechanical load, and the risk of loosening. I think there is enough evidence that heavy patients have a higher incidence of loosening.
So before we get into the entire mechanical complications, I want to steer us towards infection prevention. Thorsten, you also put your hand up. What's your cutoff?
Yeah, my cutoff is also 40. And independently how the knee looks, I mean,
most of the patients are suffering from a metabolic syndrome, and this is weaken your the situation maximally.
Very good. So then, in the event, does anybody on the panel have specific specialists or individuals that you commonly refer your patients to? Do you have access to a weight loss clinic or internal medicine or endocrinologist? Anybody here have that specific pathway in their institution? Michael, go ahead. What are our infectious disease specialists from HSS, Dr. Henry?
We do have a program set up at HSS to assess people preoperatively for obesity. Unfortunately, it is very, very oversubscribed, so only a small fraction of patients actually manage to get through the program. And it's made up of dietitians, physiatry, and internal medicine.
Go ahead. I think someone else had their hand up. Any specialized referral centers?
We have a center we refer our patients who have a high BMI to.
Great.
But then the question always is that you have to balance it with the amount of discomfort the patient is having in their knees, and that's often a challenge. How far do you go with these patients? But yeah, we do take a call, taking our colleagues in.
Yeah, so I do have a question about bariatric surgery. We actually answered it this morning, and I think there was a lot of enthusiasm in North America, especially to refer patients to bariatric surgeons probably about 10, 15 years ago. That seems to have decreased just because of the concern of weight gain and then, of course, disturbance in the actual metabolic pathway. What about GLP-1 agonists or Ozempic? In the United States, we've really seen an explosion of this medication. For our panelists from India, have you seen this as well in your patient population? Is this accessible to you?
We have no experience with that.
Okay, so I think the main experience from HSS, where we've had a lot of patients use it, is that it does work. It's actually been quite tremendous in seeing how patients have lost weight. The only main concerns, at least from a perioperative point of view, is that it does cause some gastric paralysis. So usually we actually counsel patients to be NPO even earlier. And then sometimes we'll even do an ultrasound of their stomach to make sure they don't have food in the stomach. It can be a bit of a nasty surprise. We touched briefly on albumin. I know we talked about vitamin D in the previous session. I think some panelists from this morning do get preoperative albumin. Who on the panel here gets routinely a preoperative albumin on all of their patients? So we have 2 hands, 3 hands going up, 4 hands going up. Okay, guys, so I always hear this at the talks. I get the albumin. If it's low, I then go ahead and give them a supplementation. For the people who have their hands up, I think, Ashok, you're here first. What do you tell patients to do? Go see a nutritionist? Do you give them a specific supplement? What do you do?
It depends on what the level of the albumin is. If it is just borderline low, we go ahead with it. But if it's really low, I think there is enough evidence even from the MSIS criteria that these are patients who are at risk of problems and infections. So we will actually supplement that albumin. At times we'd send them back home, put them onto our medical colleagues, get it up to speed, and then go ahead with the surgery.
Perfect. I think that's a pretty reasonable thing. Anybody have anything else to add with that? Yes, I think the main cutoff just to go ahead.
Protein supplements, prescribe them, and then wait for it to come back to normal.
Yeah, I think the only difference with vitamin D is that albumin does take quite a while to come back up. So I think that's the main challenge that we have in terms of when to know when to correct it. And then just one more thing. For your obese patients, for those who do end up taking those patients above BMI 40 to the operating room and to do a primary knee, how does it change in terms of your wound management? Does anybody change their method of closure for a body mass index over 40, over 45? Anybody change strategies from what you usually do? Use of wound vacs, use of drains? Go ahead.
Statafix in such patients when I'm doing the closure, but other than that, nothing beyond Statafix for my closure.
Anybody have any experience with negative pressure dressings in these patients? No? You will see in our institution, some people do like to use wound vacs on these patients because of the concern of increased drainage. How about implants? Stemmed components, briefly, yes or no? Will people tend to put a longer stem on the tibia in obese patients? Anyone raise their hands?
Stem extension in all the patients.
Okay, so we do have some people who like to do that. Just for the sake of time, of course, if you look at the literature, it seems like a BMI over 45 reproducibly has been found to be the inflection point for a really significant increase in risk. I think all the panelists are completely correct. And then, of course, as you can see here from these multiple publications, patients cannot lose weight by themselves, but even with our help.
Can I make
Go
a
ahead.
point? There was a recent article, I think, in the February edition of JOA, which actually alludes to the fact that patients with stems in the 35 to 40 actually have a higher incidence of loosening, which really didn't sort of sit comfortably with me. I just wonder if the panel has a view on that. Over 40, they say yes. 35 to 40, they say it has a higher incidence of aseptic loosening. It's in the recent edition of JOA.
Anybody else familiar with those findings from the articles? Want to comment on that? So I can tell you personally, I guess it depends on the type of implant that you utilize. I tend to utilize an implant that actually has intrinsically a very short keel and stem, so I find myself putting a stem extension on everybody. But I think your point is well taken. A lot of these has to do with where exactly the obesity lies, perhaps bone density as well, and then method of fixation. So I think these are all comments. Aaron, you want to make a point?
I think it also depends on what alignment that patient has been put in, because if you're going to keep a very obese patient in significant malalignment or in severe varus, for example, your stem may not be adequate for the purpose.
Good points, all good points. Go ahead, Thorsten.
To be honest, there are some randomized studies which show that the stem extension has no benefit at all. So it means the most crucial point is the bone quality. I agree, the bone quality is quite weak in many obese patients, but if the bone quality is quite good, you don't need stem extensions.
Fair enough. Just for the sake of time, I do have some comments about smokers, diabetics. We covered a lot of that this morning. I don't think there's really anything else to add apart from your own institutional variants, dental health as well. I think Dr. Berry's talk covered that very nicely. How about intra-articular injections? The patients come to you in clinic, they've just had a cortisone shot, they just went to see another practitioner, gave them a shot or give them a viscosupplementation shot. They now want a total knee because it didn't help them. It's been a week later, they're still in as much pain. Anybody here, who here on the panel will do a knee replacement right away? Who here will delay? People who will do the knee replacement right away, it doesn't matter about the injection, it doesn't affect me. Ed, your hand's up there. What's your evidence?
Pearl diver, 13,000 patients, 2 weeks. Anything after that makes no difference. Within 2 weeks you stop, but anything after that is good. Pearl diver.
Anybody else? 3 months. We got 3 months. Who else does 3 months?
3 months.
3 months. 3 months. Okay, fair enough. So we don't have a complete consensus, and actually it's quite interesting. The literature would tend to support this lack of consensus, because here I've got two things on the left, clear increase in PGI, and I do have the Pearl Diver study, at least a reference to it that Ed was talking about. So there's not complete consensus in the literature, but still at HSS, I'll tell you the majority of people will probably wait 3 months. Also has to do with the logistics of scheduling, but at the same time, I think we could definitely continue to ask this question. In terms of MRSA, we talked a little bit about this morning about how to deal with this. What exactly are your institutional guidelines for dealing with MRSA? Who here in their institution decolonizes everybody for MRSA, all primary knee patients? Anybody put their hands up? Anybody who has a history of MRSA? The patient comes in, I had a previous MRSA infection, we'll go ahead and decolonize. Okay, it seems to be the majority. Anybody else? The last two, what do you guys do in your institution?
All our patients are screened for MRSA before surgery.
So you screen everybody?
We screen everyone, yeah.
Okay, perfect. Ed, how about you?
Ironic, we screen on admission and don't treat. So I don't treat any of my MRSA. And you gotta ask yourself, if you're colonized with MRSA, how did you get it? What does it make a difference to get an infection if you have something in your nose? It's your gut causing your change. It's your diet. It's everything that Thorsten has talked about. Changing your gut, changing your diet makes the difference. Getting rid of it out of your nose is not going to change your infection risk. It's everything else in your body.
So Mike Henry, you're our infectious disease specialist. What do you think the literature shows about this? What should we be doing in terms of what the literature tells us? If you could steer the reins at HSS and tell us all what to do, what should we be doing which makes the most sense in the literature?
Well, one thing I just want to point out is that it's not just MRSA, but it's MSS. It's all Staph aureus, which puts people at increased risk for postoperative orthopedic infections. And we screen people only with a history, reported history of Staph aureus infection or colonization, which is albeit a very imperfect way, and we'll be moving towards sort of universal decolonization with no screening. And in terms of, it's an interesting question. What is it? Why clearing out the nose? Why does that help? People will, most of the staph does live in our nose, warm, dark places. With staph there, it's very easy for patients to then auto-inoculate themselves all over the place, which is why you like to reduce the staph load. So it's not simply just the staph that's traveling through the blood from the nose or through the air through the nose, but the patient actually can spread it to themselves.
Yes, that's great. Thanks so much, Mike, for giving us insight. It never really made much sense to me until you explained it to me. And Ed, I think at that point, if your institution right now screens but doesn't treat, you've got the perfect setup for a wonderful study. Now just screen and treat everybody, and then you can actually tell us what the answer is in a few years. Anyways, obviously there's a little bit of variation here. The next thing that's more interesting, if you do know your patient is an MRSA carrier, who here will modify their intraoperative antibiotic prophylaxis because of the MRSA status? Thorsten, your hand's up. What do you do then? So first of all, what's your routine prophylaxis if a patient is not an MRSA carrier?
Our routine prophylaxis is cefazoline, as it mentioned before here. And if a patient has some kind of a history of MRSA infection, we give vancomycin 1 hour before.
Anybody else do the same? Mike? Dr. Malalji, why don't you tell us, are you doing the exact same thing? You were also telling us that you don't have access to their first generation cephalosporins.
Yeah, we use cefuroxime and Vanco.
And that's it, so that's what you add on. And then do you, in terms of the two of you, do you then try to get that into the patient a few hours before surgery? Does that alter your scheduling? Do you not schedule them first case in the day?
We'd already have treated them with mupirocin initially.
Okay, but you obviously want to make sure that vent goes in before obviously the tourniquet goes up. Okay, great. And this is obviously some good data. Definitely a lot of discordances you can see among the panel. But it seems like there is some good data, especially from NYU down the road from us, that universal decolonization seems to be quite cost effective. It is institution variant. And definitely, as you can see here, there are some really compelling results that if you do treat it, the institutional rates, which can be high, actually do tend to come down. Let's switch to now intraoperative. I think this is kind of interesting because we did touch a little bit upon this morning, but I would dig into it a little bit deeper. So let's talk about types of anesthesia. On the panel, in your institution, general anesthesia is the main technique for my total knee replacements. Put your hands up if that's true. Okay, so we got one. How about spinal neuraxial anesthesia for everybody else? Would this be the overwhelming majority? What do you think your institutional percentage? Just going down the panel over the last year, the number of patients, percentage of patients who had general anesthesia in your institution.
2 to 3%.
2 to 3%. Please go ahead.
Very low.
Thorsten.
80 to 20%.
80 to 20. 80% neuraxial.
Spinal, 80% spinal, 20%.
Very low. Only if the anesthetist feels that a spine surgery has been done or some contraindication for that. Otherwise, it's always spinal.
Okay. Anything else to add?
Less than 5% would be general anesthesia.
Okay, so Ed, let's have some. I have to single you out here. Let's talk a little bit about this. Is that because your anesthesiologists don't want to do it? Is there a push for the surgeons that prefer general anesthesia? Take us through this.
Or slow anesthesia general is fast. We're at a teaching institution. If you have a lot of residents and they got a couple pokes, it takes time. You lose time in the OR. It's efficiency. If I have a good anesthesiologist, great, but it's week by week. It's different.
Great. I mean, it's a great question to ask because obviously anesthesia technique has been shown to have helped not only recovery but also blood loss. So it's interesting to see we do have some institutions. Just tourniquet real quickly. People, put your hands up if you use a tourniquet during your primary knee replacement. And on the panel, put your hands up if you use a tourniquet. Okay. So again, we do have not complete discordance. We talked about that this morning. Tranexamic acid. Who here does not utilize tranexamic acid routinely in their total knee arthroplasty? Okay. Number of doses. Who gives just one dose? The majority of patients. 2 doses. Okay, so again, not complete discordance here. Who gives it to pretty much everyone, as we heard from Dr. Berry? There's some good evidence to show that most people can take it. Would you say over 90% of your patients get tranexamic acid? Put your hands up if that's correct. Great, so see, at least we do know that there are different, at least at HSS, my anesthesiologist tends to get nervous if there are stents, recent cardiac issues, but on the fence sometimes, but that's really probably more institutional specific. In terms of donating blood, do any institutions from the panel, do your patients routinely give blood before surgery? So just to make sure, that seems to have been completely abandoned in North America, just wanted to make sure that was the case across the world. And then how about a transfusion protocol post-operatively? In terms of how you find your rate of transfusion now versus previously, obviously we know tranexamic acid is a game changer. Do you actually have codified protocols in your institution to try and decrease the use of actual blood donation? Yes, so Thorsten, you're nodding your head. Give us some explanation there.
Yeah, of course, we have a quite strict protocol. It's depending on the clinical symptoms, on the clinical situation. So if a patient has less than 7 and shows some kind of clinical symptoms, we give some blood. Mm-hmm. If not, we wait.
And then if they have a cardiac history, obviously the numbers are different a little bit?
There's no difference, no.
Okay. Anybody else have anything that's vastly different? Please,
7 in cardiac.
7 in cardiac. Arun, is that the
Anyone
same?
with symptoms of dizziness, giddiness, etc., and a cardiac history, we'd be more careful and give them blood. But otherwise, our cutoff is around 8.
Fair enough.
Less than 8, we transfuse.
Does anybody not have a protocol? No plan whatsoever? So I think that's the important thing. If you don't have one at your institution, please develop one, especially with your internists, to make sure that you're all on the same page. In terms of the environment, at HSS we have our hallowed panels, our plexiglass panels that we know and love to make sure the laminar flow works properly. Who here on the panel utilizes laminar flow routinely in their primary total knee arthroplasty? Okay, so it seems like the majority of people do. Ed, you didn't put your hand up. Tell us a little bit about your setup. Do you have any, how do you maintain sort of a different position as to not having outsiders come into your surgical field? Are you quite militant about that? Is it
standard flow? Everybody comes in through the core, not on the outside. The doors are taped shut, and exhaust hoods only, and that's it, and minimal traffic flow. And we just don't have the rooms for laminar flow.
Fair enough. It would be interesting to sort of know what the actual setup is across countries. We definitely have conflicting evidence in the different international registries. At HSS, we've been having some rooms on the other floors which don't have laminar flow, and we're doing some joints now. We've installed laminar flow. But the matter of fact is that it still seems to be the preference among a lot of institutions.
But if you go to outpatient ambulatory care centers, they do just as well, and they have no laminar flow, they have no core, they have no nothing, and they do just as well.
Yeah, we're going to talk about outpatients in a second, but you're absolutely right, Ed. I think now the switch to ASCs in North America has been a huge game changer. It'll be quite interesting to try and figure out how many of them have the same environmental setup as a hospital. How about skin prep? Let's go down. Go down. Starting with Ashok here. What type of skin prep do you use for your?
We use chlorhexidine preps. We have chlorhexidine washes, baths, and we prep with chlorhexidine as well. So we.
Chlorhexidine, betadine, and alcohol.
And is it in that order specifically?
Yeah.
Okay. Thorsten?
Betadine and alcohol.
Same like Dr. Arun Mullaji, and no shaving, only trimmers to be used.
Okay. Please continue. Everybody else.
Betadine scrub followed by chlorhexidine alcohol prep.
Ed?
Alcohol, then DuraPrep and IOBAN.
Alberto, why don't you say what we do at HSS?
So at HSS, what we typically do, or at least historically, there was a little bit of a divide. We actually were a bit chlorhexidine, a bit povidone iodine. Now the service has really switched more over to a complete chlorhexidine utilization. A little bit of povidone iodine on the foot, which will then hold up, and then a chlorhexidine. First a pre-scrub, and then a proper 3% prep with chlorhexidine, which we then wait. I think the main thing is that an alcohol-based prep has really been shown to be superior over and over again. Povidone iodine is quite effective, but I think chlorhexidine has been seen to be superior and very reliable. In terms of these adhesive incised drapes, you can see I've made a picture up there to show these are these iodine impregnated incised drapes. Just for the panel, please put your hands up if you utilize these in your operating room for your primary total knee replacements. Okay, so it seems like we actually have did we actually have universal consensus there for once? Seems like we may have. Everyone seems to use it. In terms of the literature, is anyone convinced that this makes a compelling difference from what you know about the literature? Put your hands up if you think it makes a compelling difference. Okay, let's talk a little bit about that. Okay, so Dr. Mullaji, talk to me a little bit about why you think it makes a difference. Where's your data coming from for that opinion?
I think there was a study from Germany actually which measured the area of the skin that was exposed and correlated it with the infection post-op. So if you had skin uncovered with the drape, you had a higher rate of infection. That's the only study that I came across.
Yeah, and this was a really weak study, to be honest, and we had this question during the consensus meeting, the ICM, and where the answer was quite clear based on the whole literature. There's no need for incise drapings, except probably the ioanized, the povidone was.
Right. Ed, go ahead. You put your hand up.
Back to Maurice Mueller, though, but Maurice said thousands and thousands of hibs, and he always claimed it was his covering that kept his infection rate low. Yes? Yeah?
Well, I think we can certainly agree that apart from some registry-based studies, especially one that actually showed that not having the iodine was dangerous, I don't really think we have very well-controlled or well-designed studies to answer that. But we'll keep on using it anyways because it does make us feel better. Anyways, in terms of just small things, changing your blade from the skin to the arthrotomy. Does anyone here not change the blade? Uses the same blade to go through the skin and then through the arthrotomy? Anybody? Okay, so one person who does that, that's important to understand. How about changing your gloves? How often do you change your gloves? Let's just go, Ed, starting with Ed. Do you change your gloves? How often? Do you have a time limit?
1 hour.
1 hour, so the timer goes off, everyone change their gloves?
As well as the suction.
And the suction. Just keep on going, let's go down the panel. Anybody else?
Before cementing.
Before cementing.
Yeah, change before cementing.
Me too.
So just So when that happens, and when the cement sticks to your glove, what's the rationale for doing that?
You should change it after cementing because the cement is destroying the glass.
Okay.
And, that's a problem. But I change them before touching the implant. That's my.
And so for the people who change it when you cement, so you change it before you cement, then you change it after because all the cement's on the gloves?
I should change it after cement. I don't do it.
Okay, let's keep going, please.
I change it just before I open the implant and cement it in, and then I don't have the problem of having to remove it because I'm washing out after that.
Fair enough. Aishak, please.
I don't change my cement. I don't change the glove.
Fair enough. So I actually go ahead and cement, and then when I'm using my antiseptic solution, I change it right after that. We'll talk about that. Thank you for that. In terms of antiseptics and antibiotics, we'll talk about it. I think Dr. Berry summarized it very nicely. Antibiotics in the cement, all the time, high risk, or really never. Who here goes ahead and does it all the time in all patients? And how about just for high risk? And Ed, I see you didn't put your hand up. Go ahead.
Never.
Never. Rationale for that?
I believe that antibiotics create resistance, and I believe that less antibiotics are better. I do 1 dose of preoperative antibiotics and no antibiotics in the cement.
So the infectious disease physician has applauded you right there.
It is absolutely true because the more antibiotics we do, the more resistance we get.
Great, that's wonderful. I'm happy Dr. Henry is happy about that statement here. In terms of the people who do add antibiotics, are you using commercially available antibiotics, your aminoglycoside that's been pre-mixed? Or does anybody go ahead and add it manually and stir it in, whether it be for elution properties or cost?
We have to differentiate between primary implantations and revisions due to BGI.
Sure, so we're talking about primaries here.
Yeah, primary pre-mixed.
And then quickly, if you have a MRSA carrier, does anybody go ahead and add vancomycin, whether it be pre-mixed or not? There are some antibiotic cements that now have dual.
Actually, I do.
So you do. Okay, I know that's specifically available in Europe. And then in terms of vancomycin powder, interesting literature from the spine now beginning to creep into the orthopedic practices of joint replacement surgeons. Does anybody here in a primary setting or an aseptic revision setting sprinkle in a little bit of the magic powder before they close the incision? Anyone do that?
I don't sprinkle it, but we keep irrigating with vancomycin solution throughout the surgery.
And is that something you do in all of your cases? You had
all cases.
Any concerns about vancomycin resistance?
No.
No. Okay. So it's interesting how we have very different opinions in terms of antibiotic stewardship for that use. Okay.
So Alberto, I'll just point out in the spine literature, the development of resistance has not been a problem for whatever it's worth.
Whatever it's worth. Good, at least as far as we know. Let's talk about something that I'm very passionate about, antiseptic solution. So interesting data now about 12 years ago from Rush showing that dilute povidone iodine decreases the risk of infection when you put it after you cement and put your implants in before you close. Who on the panel utilizes some form? So I think we do have Dr. Malalji utilizes his vancomycin. That is an intra-wound antiseptic or antibiotic. Does anybody else utilize an antiseptic or antibiotic solution prior to closure? Put up your hand if that's the case. Okay, tell us about what your formulations are. Go ahead.
We use 10% betadine.
10% betadine, okay.
0.5% betadine.
0.5%. Now, is that something you have to actually dilute yourself on the back table with some saline? And then Dr. Malalji, do you have to use anything else?
The same, diluted. And the real question is it sterile? So our lab actually tests it frequently to make sure that it is sterile, the betadine that we get commercially.
Great, so I think that's an excellent point. So you do bring up an importance as to that the CDC in the United States did detect in 2003 some concerns for antiseptic solutions that actually contain water-based organisms that were not removed at the time when the actual water was mixed with the antiseptic solution. That's why now in the United States they recommend that if they have an antiseptic solution, it says the word sterile on it. At least in the US, the main hack for many years was to utilize what was in the Foley packs because that was sterile povidone iodine. Just in terms of antibiotic cement, real quick, there's this really lovely paper which actually highlights what we call the transatlantic paradox, which describes how in Europe antibiotic cement does have pretty conclusive results that it is protective, but in North America we've never really been able to show such an effect, and I think perhaps this is why we have this maybe disparity in us using it. What's interesting is this really large NJR study from England which actually did show some effect, but still I think if you panel a lot of surgeons in the United States, you will not get concordance. One thing that we've been doing at HSS is looking at these antiseptic solutions. So in my hands, 10% povidone iodine with or without peroxide has been shown in our lab to kill absolutely everything. I use it in all of my primaries, so I applaud the panel member who does the same thing as I do. But the matter of fact is that the literature does suggest you should think about doing this, especially in your high-risk patients, and of course, irrigating it out. This is some nice data showing that the 10% really works on all orthopedic surfaces. There are a lot of new solutions on the market that are very expensive. Whether they're really going to be helpful still has to be worked out. Our in vitro data wasn't so reassuring. In terms of wound closures, primary, uncomplicated, non-obese patients, who here uses staples? Who here uses sutures? So let's talk about staples. Anybody using staples? Primary, non-obese patient for total knee. Okay, we have one person. How about sutures? So absorbable stitches. Okay, does anybody use something else I didn't describe? Not really, okay.
So I use a combination of absorbable, subcuticular, and a few staples, just about 4 or 5, just to hold the wound together for early rehab.
For early rehab, so allow early bending in case you're worried about it splitting. Thorsten, talk to us about why you like to use staples.
It's quicker.
And then have you had any issues? So let's talk about the sutures.
No issues. There's no evidence that staples are more tending to infections than anything else. So we don't have any problems with staples.
And for the people who use sutures, who here is using an additional adhesive, some sort of glue that goes on top of the sutures? Anybody? So I'll tell you, in HSS, now the actual service standard that we've adopted is to utilize 3O monocryl as well as some Dermabond, which is a glue, and then a hydrocolloid dressing on top. So that's made a few people like me who love doing staples have to try and convert to a suture format. Just quickly about dressings. What do you do now with your dressings? You put a dressing on. Are you putting a gauze? Are you putting bandages and putting a dressing later? Or are you putting some sort of dressing and then you leave it and you ask the patient not to touch it? Who here actually leaves the dressing on and has the patient not touch it for a week or 10 days? Anybody? And so, Arun, let's just talk about what do you do for your primary needs in terms of your dressings?
So we actually just inspect the dressing before they go home once, but we don't leave the innermost gauze. We're not checking the wound as such, but we're just looking for any leakage because we wrap it up in a bandage and keep it for 4 or 5 days. So we just want to make sure that before the patient goes home, it's fine.
And then after 4 or 5 days, that bandage...
Nobody touches it.
And then after 4 or 5 days, that dressing comes down, bandage comes off, the wound is exposed?
Only the outer bandage comes out, and then we have this inner dressing like this.
Okay, fair enough. In our institution, we're really using these, what we call hydrocolloid or waterproof dressings, so the patients can shower. So we tend to put it on and then leave it on for about 10 days, 7 to 10 days, and then we pull it off. So it's interesting to see it. And then in terms of the dosing of IV antibiotics, so I'm not talking about your high-risk patient. I'm talking about routine total knee replacement. How many doses? If you're giving a dose before we cut the skin, that's 1 dose. And then, of course, there's a possibility for 2 doses or maybe even 24 hours. So let's talk about this. In your primary knees, patients going home or staying overnight, who only gives a single dose of antibiotics routinely? And now what about 2 or 3 doses? Anybody giving additional post-operative doses? Okay, so then for the people who are doing additional post-operative doses, as we begin to move to outpatient joints, Ashok, let's talk about you. Now you have patients who want to go home pretty quickly, or you get them done late in the day, and they're going to be going home the next day at 8 o'clock, they're ready to go, their family members are ready to pick them up, but they're going to miss that 3rd dose or 2nd dose of antibiotics. Do you keep them in the hospital until they complete their 16 or 24-hour dosing? What do you do?
So we don't have that problem at all. Surgery for us is a social occasion. They like to stay for 4 or 5 days, so we don't have that challenge at all.
So then as we talk about antibiotic stewardship, do you think there's any concern about giving them more antibiotics when you don't need to?
Not necessarily. If you're doing it in a clean, safe environment, we administer 3 doses, 1 pre-op, 3 post-op, and that's it.
So Dr. Henry, you're an infectious disease specialist. You don't want us to give any antibiotics at all when not necessary. What do you think about this in terms of literature for 1 dose or more than 1 dose? What should we do?
Well, there is some recent evidence showing that just that single dose has actually always been shown to be by far the most important dose. And we do use a 3-dose, well, for using a Q8 drug like Ancef, we do give the 3 doses. For the patients going home in the ambulatory setting, the surgeons have been sending people home with oral cephalosporins in its place. Mm-hmm. You know, that's sort of a jerry-rigged solution, and it's most likely we're riding on the coattails of that first single dose more than anything.
So just for the sake of time, because I want to touch on PGI, obviously, who here does give extended or 7-day oral antibiotics in high-risk patients? Okay, so for the sake of time, because we can get into this, we'll just say that there isn't complete consensus. There are 2 papers that came out from a specific group that did show significant reductions. The issue is that other institutions have not been able to show this. I want to touch on PGI diagnosis. We'll go through a little bit rapid fire. You can see the literature on this is exploding, and unfortunately, as you can see, even our 2018 criteria in 2018 have now been completely overwhelmed by the amount of evidence. Now we've got 50% of the literature was published after the 2018 criteria, so it's really quite interesting to see what the relevance of the criteria are. Obviously, everyone here is thinking about ESR and CRP. Does anyone here get something else, like IL-6, in terms of serum blood work? Anybody use any of these alternative markers from ESR and CRP? But okay, so go ahead, Ishak.
We use D-dimers and leukocyte esterase.
Anybody else using D-dimer routinely to work up their PJIs? Thorsten, go ahead.
No, we don't use D-dimer, but we use IL-6 only in one situation, if the patient is pre-septic.
Okay.
Just to see how much he's in danger at the moment.
Fair enough, interesting. And then in terms of the aspiration, we have to go quickly because we're running out of time here. How long, when you're taking some fluid out of the knee, you're worried about infection, you're sending off cultures, who, in their institution, who here routinely keeps all cultures for 3 weeks? You can put your hands up as my dates go down. 2 weeks. 1 week. 5 days. 3 days. Well, what's the answer?
They don't culture.
Would it just be less than a week? What do you guys typically do? Go ahead.
We would normally keep it for 5 days, but then in cases where you haven't grown anything and there's a problem getting some data on what is going on inside, then we keep it for 14 days, but not as a routine.
Fair enough. So I mean, in our institution, we typically routinely keep it for 2 weeks just because of the concern of slow-growing organisms. There's some good literature there. In terms of surgery, you're worried about infection. You're taking samples. You're going to take tissue samples. We'll talk about the rest after. We'll talk about the number of samples that you would take when you're suspecting an infection. I'm going to start with a higher number and go down. 5 or more. 3 or more. And less than 3. Okay, so anybody have any strong opinions on this in terms of how many you should take? Ed, how many cultures should we be taking? Is 3 enough?
If it's infected, I take them everywhere, so you want to know, including medullary canal. If you just suspect infection in the knee, it's synovium is your best bang for your buck, then metaphyseal edges, patella, femur, tibia.
So do you get any pushback from your pathologists if you send them, or microbiologists send them 15 samples? Do they get a little bit upset?
Of course they do.
Okay.
Yeah.
Good to know. So at least there are lots of good evidence here. You obviously have now with modern implants, if you do have early loosening, you should be worried about an infection. Metal on metal can certainly interfere with your counts. You think about specific differentiations. In our institution, we're now moving towards 5 cultures, as really just because we can remind the surgeons, and usually taking it with separate rongeurs or separate specimens. Swabs have not necessarily been helpful. And now, very appropriately, since we're running out of time, you do the aspiration. You haven't taken the patient to the OR. It's negative. There are all of these different technologies that are out there, ranging in their complexity and also their need for use of things like data informatics. If you're not in an academic institution, you may not have access to quantitative PCR. Let's just run down the panel. You have a culture negative infection. We'll start with Ashok here. What are you doing next? Are you simply re-aspirating the patient, or are you using any of these other technologies that I've listed here below? Go ahead.
This is a very difficult situation. We re-aspirate, oftentimes that comes out negative as well. We keep the cultures, like I said, for 2 weeks. Sometimes even at the end of that, you don't get a... So we rely more on the serology, the synovial CRP.
But then you're not doing any of these other techniques routinely?
No, we are not.
Not right. Just going down the line. Arun, what are you doing? Any of these techniques?
The first 3, generally. And now we've got some newer equipment for doing one of these more fancy tests, which gives you within an hour an analysis of about 20-odd organisms.
Has that been a game changer for you? Do you find that that's been really helpful?
Yeah, I think it's been really helpful. BioFire.
BioFire joint panel care is one thing. And has that been a specific expense? Is that quite an expensive thing that your patients have indicated about, your institutions thought about?
Yeah, it is expensive, but I think it's in the earlier phase, so it's getting subsidized a bit.
Mike, what do we do here at HSS?
Well, we will re-aspirate, and on some occasions, we don't routinely send our synovial fluid cultures and blood culture bottles, but we can, when we request the lab, that they do it. We just don't have the infrastructure to do it for everybody. So we'll do those two. However, if the patient is clearly clinically has a PJI and the initial workup is culture negative, we'll often just proceed with the surgery, thinking we're going to get better cultures at the time of the OR. Even if you re-aspirate a second time, it's probably not MRSA, staph, Pseudomonas, any of the biggies. Those will grow out.
Great. So I want to ask about reimplantation. So Thorsten, quickly, I know we're talking about alpha defensin, but any of these technologies you use?
First, reaspiration. Second, open biopsy. We send only blood culture bottles if you have a longer transport time to the lab. Usually we use native material. Sondication you can only use if you have an implant, if you take the implant out. Molecular techniques we use, multiplex PCR, and sometimes next-gen sequencing.
Why not just use next-gen sequencing and everybody else? Why bother all this?
It's much more difficult to get it in Germany than in US. In US it's easy, but
down the panel. Anybody else? Anybody else?
So
Tell us the rest of it.
BioFire is available now for us, so we are using more of that.
Perfect. Go ahead.
So all our aspirates go in blood culture bottles in the first place, and if that doesn't work, then we use NGS.
Great. Ed, briefly. I know it's a huge topic you're very passionate
Next generation, because BioFire only gets 75 organisms. Next generation gets 57,000 organisms.
And you treat for all the organisms that are positive, they come back with 23 organisms, and you get 4 antibiotics, so you're going to use all 4?
You pick a regimen that treats a broad spectrum.
Great, good answer. Just for the sake of time, this is really exciting. We could talk about this for a long time. Just quickly, because we can go a little bit over time. We're getting ready to reimplant. This is what the incision looks like. The patient feels good. That's a beautiful spacer you put in. We put some metal in there, but it's okay. How do you work up your aspiration? Who here in this regular patient with a primary knee you've now revised, they've completed their antibiotics, whether it be oral or intravenous, who here will use an antibiotic holiday? Put your hands up. Okay, so Thorsten's the only one who does not. And then for those people who do use an antibiotic holiday, let's talk about duration, okay? So you can put your hands up, I'll give you time. So 2 weeks, I'm gonna go up in time. 2 weeks, 6 weeks, 3 months, 6 months. Anybody else that didn't put their hands up? Okay, so Arun, for you it's 6 months?
6 months to a year, yeah.
And that's all comers regardless of the pathogen?
Almost all.
Okay, and Ashok, just over here, because you put up your hand for 6 weeks. What about fungal infection? You do anything different? You go longer?
If it's fungal, we would typically do it 3 months.
Perfect. And then in terms of that, we now have an antibiotic holiday. Who then gets an aspiration? Or do you do ESR? So after you do it, and we're not going to include Thorsten here, unfortunately, he doesn't do a holiday, but people get blood work. If the blood work's normal, or do you get an aspiration as well? Who here is doing an aspiration prior to reimplantation? Okay, so Ed, you put up your hand pretty quickly. What's your criteria for a normal aspiration? Is it MSIS criteria? Is that where you're using 3,000 cells, 80%
Yeah,
neutrophils?
3,000 cells, DNA negative.
So you're saying it off for DNA. You're using your next-gen sequencing on that aspirate?
Absolutely.
Okay. And then, Mike, what do we typically utilize here at HSS, our institution?
Well, we do re-aspirate, and we do follow MSIS criteria. We're 3,000 white cells, positive cultures. Though I will say we do the aspiration and the antibiotic holiday, a lot of it out of tradition and inertia. There is a body of evidence out there that shows that you can proceed without these if the patient is clinically well and the joint is functioning well and the incision is well healed. And I've seen that just in practice over the years. I've never accidentally uncovered an infection in an aspiration.
And then for our surgeons, you've done your 2-stage, you're finished, everything looked clean. Who is continuing to give the patient antibiotics after the reimplantation? You've put in some antibiotic cement. Who's going to treat with some antibiotics longer post-operatively after the reimplantation? Anybody? All right, so for Ashok and Arun, how long? Are we talking oral, intravenous? How long?
So we give oral intravenous during hospitalization. Post-operatively, we continue antibiotics for 6 months.
Okay. And then Arun, quickly?
2 weeks IV and then 3 months of oral.
And then Thorsten, finally.
6 weeks oral.
So thank you very much to our panel for these incredible responses, a huge amount of different topics that we covered. Thank you very much for your attention. Dr. Henry now is going to present to us about the utility of antibiotics. He's the only thing separating us from lunch, so let's please be kind to him and pay attention. Thank you very much. Thank you to our panelists.
Hello. So my name is Michael Henry. I'm an infectious disease doctor at HSS, and I'm very happy to have been invited here to speak to you all. I was asked to speak briefly about our approach at HSS to the treatment of prosthetic joint infections. So our approach basically is based on whether there's retained hardware or not. When all the hardware is removed, either the 2-stage, the 1-stage, or the 1.5 exchange, or otherwise sometimes called a destination spacer, where the spacer is planned to be left in, we treat with 6 weeks of high-dose antibiotics. And by high dose, generally it's IV, but it can be oral using antibiotics with high oral bioavailability, such as the fluoroquinolones, linezolid, and clindamycin. In the setting of retained infected hardware, we again treat with 6 weeks of high-dose antibiotics, and that is then followed by anywhere from 3 to 6 months, usually 3 months for a hip, 6 months for a knee, of appropriate oral antibiotics, which is something that does vary. That is a practice that is certainly not standardized throughout the world or even in the United States. We do occasionally have patients in which surgery is not an option, and in those patients we will just do antibiotic salvage, basically with, again, sort of mimicking the same protocols we do for a DARE. Obviously the outcomes are less than ideal in that situation. The antibiotics we use when it comes to the sensitive staph, MSSA, MSSEs, the methicillin sensitive staph epidermidis and other coagulase negative staph, we use cefazolin or oxacillin, and I'll get to rifampin in a second. And for MRSA, MRSE, traditionally we've been using lots and lots of vancomycin. Over the past 10 years or so, we've increased our use of daptomycin as the cost has come way down. It's also a much easier drug to give to patients. It's QD, has an excellent safety profile. Very, very rarely have to stop it in anybody for any sort of problems in the long term. We use rifampin we give in the setting of retained infected hardware only, not when all the hardware is removed. For the strep viridins, we use ceftriaxone versus continuous intravenous penicillin G. And for the enterococcus, our standard is intravenous penicillin G, or Zosyn. There are other narrower spectrum IV antibiotics which work for enterococcus, but they're not at least for outpatient home intravenous therapy, which is what most of our patients do. The medications are shipped to them and they're taught to self-administer. Most drugs are not stable enough for that other than penicillin G and Zosyn. For QD bacterium, which is not something you see often in hips and knees, but we do see it, usually several a year. Our drugs of choice are ceftriaxone versus vancomycin or clindamycin. Gram negatives, which is of course an incredibly broad array of organisms, but we use fluoroquinolones whenever we can, given their excellent bone penetration, bioavailability, and excellent track record. I should go back to say that not in the U.S. so much, but increasing in the U.S., but especially throughout Europe, the first-line treatment for staph, either Staph aureus, Staph epidermidis, coagulation of staph, or fluoroquinolones plus rifampin, allowing the patient to take an entire oral regimen, and the literature supports it shows an excellent track record, which makes me wonder why we don't use it more in the U.S. For Candida, our first-line drug is fluconazole when sensitive. Fluconazole also has excellent bioavailability and can be given orally. Thank you. So in terms of suppressive antibiotic therapy, which is, again, sort of a very not controversial, but a very difficult area to navigate in terms of treating patients with retained infected hardware. This past summer, I was part of a group that published a review of the literature looking through what literature exists to support the use of suppressive antibiotic therapy. And this is treatment basically after the standard, anywhere from 3 to 6 months of treatment. That is not considered suppressive antibiotic. This is post 6 months. And our basic takeaway was that the literature is very poor and does not really give any support to any sort of treatment. And this mostly is due to the vast majority of studies are very small, heterogeneous, and with limited follow-up. And the studies are done, there's really been no standard approach to this. So it's very hard, even meta-analyses are not very valuable when crunching these numbers together. There have been 2 other recent reviews, taking a similar approach to us, and they as well found similar findings that the literature, there is just no good literature either way really to support suppressive antibiotic therapy, though many of us do it in practice, and it is part of some of the guidelines, the IDSA guidelines. One drug which is changing our practice is a relatively new drug, dalbavancin. I don't know if it's available in India. It's a lipoglycopeptide, a long-acting glycopeptide similar to vancomycin. It has a half-life of 14 days, which allows it to be given standardly given in a two-dose regimen, one dose on day 1 and the second dose on day 8. And that is it. That provides adequate MICs for all staff. It has very low MICs for staff. And this replaces the 6-week therapy of IV antibiotics or oral antibiotics. Dalbavancin, though it is a glycopeptide, actually has an excellent toxicity profile. What limits our use of it has been the cost. It has been extremely expensive, though insurance companies are now beginning to wake up to the fact that giving this drug obviates the need for 6 weeks of intravenous antibiotic care. And there is now a role, the last slide, then you can all go eat. Dalbavancin is also not so much in orthopedics, but it is an excellent option for salvage of chronically infected patients with Staph aureus for long-term suppression, where there have been multiple studies looking at it in vascular infections, intravascular infections, LVADs, stents, where dalbavancin has been given for months or upwards over a year on end on a Q2-week, Q4-week basis to suppress infection. And I will leave you with that. Thank you very much.
Thank you, sir. Yeah, would request the moderator and all the panelists to come together for a group picture. And meanwhile, I would inform all the delegates that the lunch has been arranged at pool deck, 2nd floor, driveway, the PBC area, and the pre-conference area, 1st floor. The lunch will be served between 1:10 to 2:10 p.m. and we shall be resuming the next set of discussions at 2:10. And for all the faculty who have been here, the lunch has been organized at restaurant Alto Vino, 1st floor. So kindly go there, help yourself, and we shall see you all at 2:10 right here.
Good.
एक्चुअली मैंने पहले सब खत्म हो रहा है
घेऊ का फोटो फोटो घ्या इथे इकडे इथे खाली पूरा आवाज है जल्दी करो तर जल्दी ले दादा 1 मिनट टिकट फोटो 1 मिनट सर 1 मिनट फोटो ले रहे उधर ले रहे फोटो ले रहा है 1 सेकंड इधर कैमरे में
One second. Just take a picture and
check. Hello. हो गया जो सर check. Hello. Check. हाँ सर check 1 2 check 1 2 हाँ सर check hello check hello check हाँ सर हाँ check hello next है check ಇದು ಜಾಸ್ತಿ ಇದೆ ಅದರಿಂದನೇ ಬರ್ತಾ ಇರೋದು ಇದು ಹೌದು ಚೆಕ್ ಹೌದು ಚೆಕ್ ಹೌದು ಸಾಕ್ಬಿಡಿ ಚೆಕ್ ಹೌದು ಚೆಕ್ ಹೌದು ಇದು ಸರ್ ಹಿಂದುಗಡೆ ಇದು ಬರ್ತಾ ಕಮ್ಮಿ ಇದೆ ಹೌದು ಓಕೆ ಚೆಕ್ ಹೌದು ಓಕೆ ಇದು ಹಾಂ ಚೆಕ್ Hello. Check. Hello. Check. Hello. ತಿಳ್ಕೊಂಡ್ರೆ ಅಲ್ಲ ಚೆಕ್ ಹಲೋ ಚೆಕ್ 1 2
ಅಯ್ಯೋ
9 ಹಾಂ ಬರ್ತಾ ಇದೆ ಅಲ್ಲಿ ಬರ್ತಾ ಇಲ್ವಾ ಇಲ್ಲಿ ಬರ್ತಾ ಇದೆ Hello, check. Hello, check. 1, 2, check, check. B. B, Michael. Sir. Ah. Check, check. Check, check. 1, 2, check, check. Check. Oh, check, check. 1, 2. Check, check. Check. 1, 2. Check, check, check.
had his lunch, he's talking. We would be starting the session in next 5 minutes. I would request all the delegates who have had their lunch, or if your friends who are out there, please call them so that we could stay back in time. Let's start our post-lunch session. The first session, that's periprosthetic joint infection panel discussion of knee arthroplasty. I would request our moderator, Dr. Edward J. McPherson, and the panelists. So I request Dr. Daniel J. Berry, Dr. Alberto Kali, Dr. Michael Henry, Dr. Rohit Luthra, Dr. Dilbans, Dr. Amar S. Ranawat, Dr. Taylor, Dr. Sachin Tapaswi, and Dr. Hemant Wakankar to kindly come up on stage and help us with the panel discussion.
All right, good afternoon, everybody. As we have our panel members come up to the stage, I'd like to talk to you about infected total knees. I'd like to say first that it's unfair that I get less time than Dr. Carley does about preoperative prevention of infections. So maybe next time I get 5 more minutes and be equal with Alberto.
McPherson, so 1 second, I'll just invite the panelists again.
But we give you 5 minutes more right now.
On that note, can I have Dr. Daniel, Dr. Alberto Kali, Dr. Michael Henry, Dr. Rohit Luthra, Dr. Dilbans?
Alberto's here.
Dr.
Taylor's walking up. Amar, I need you. Okay. So our topics that we're going to do are open to discussion. Treatment of infection is continuing to evolve. It's a very expensive proposition. It's difficult. These are kind of the topics we're going to talk over. I'm going to talk over some cases. So I don't have much time, so let me know when I can stop, okay? Should we proceed with, as right now? We'll start right now. Okay. First topic is DARE. This is initially started by Dr. Adrian Taylor at Oxford. DARE is debridement antibiotic implant retention. He did not mandate at the time modular bearing exchange, or DECRA, whereas debridement, exchange of the components, retention of antibiotics is what I consider a true DARE. Is this important for the panel, yes or no?
Yes. Yes.
Yeah.
Yes.
Yes?
Like if you can
explain.
If you can remove the insert without breaking the locks,
all right.
Then you try to clean it thoroughly and put it back in.
All right, so we'll go on to the next question. If it's if no modular parts available, your implant has been retired, you have a late infection, do you do a DARE, yes or no? Alberto, go down the line. You want to do a DARE, but you don't have the parts.
Yeah, so in this case, I'd still take out the actual modular component, as you said, and try and debride it as much as possible and then put it back in. So yes.
What if you do that, you lose the locking mechanism?
Well, then in that case, you have to be ready to revise the implant. So if you have a retired mechanism, you got to be ready that may be completely worn away, and then you may have to revise it. So you got to come prepared.
So you'd be prepared for a revision every single time with a DARE. That's the most important part. You need to understand that sometimes a DARE is, you break things, you got to do it.
Yeah, especially if you don't have part of your implants available, you definitely need to be prepared to take everything out.
Sachin, you ready? You agree with that?
Yes, I do.
Everybody?
Yep, agree.
So everybody, it seems like there's a consensus. If you're going to do a DARE, every single part's got to be opened and removed. Yes? Correct? All right. What is the time cutoff between the symptoms of infection and doing the DARE? What's the cutoff? Everybody? Panel?
It depends actually on etiology. Like if it is acute infection after the surgery, then it is 6 weeks. But like I believe that there can be done even if a patient comes to you with acute homogeneous infection, might be 5 years after the surgery. If you have a specific factor, like I have once had a patient who had a wound on the leg.
What's your cutoff?
6 weeks.
6 weeks. 6 weeks and then post-op is 3?
Yeah.
Why? What's the difference?
Actually, if it is happening in the post-op scenario, then the cause has to be somewhere in the surgery if it is happening in the acute stage.
I think that's confusing between the two scenarios, which are completely different. We're talking about
Why? An infection is
hematogens.
an infection. It's a sterile implant. It gets infected. Post-op, it's 3 weeks. Late, it's 6 weeks. Organism's an organism. It sticks to metal. What's the difference?
So the actual pushback I'm going to have here is that if you look at so the idea of a cutoff is the idea that somehow you think that there's going to be a specific time and space where that biofilm is going to be immature or somehow not spatially distributed enough where you can't debride it.
Okay, so what's your definition? Let's go down the panel. When do you think that an infection in a joint becomes a biofilm? What?
3 hours, and therefore there's no cutoff.
The classic description is between 5 to 10 days is the window period, beyond 10 days, generally considered that biofilm will become more and more mature and the chances of success go down.
So do you think that you're curing a biofilm infection with an acute washout with a DARE? Anybody?
I think you are curing some of them. Not everybody relapses after a DARE, but it's hard to know who is who.
If you cure somebody with a DARE, are you curing an acute infection without a biofilm, or are you curing some of the people with biofilm?
The biofilm is like known to be setting up a forming within 24 to 48 hours, and it actually matures over time. So even if you are doing it within 5 to 7 days, you are otherwise dealing with the biofilm, but it's not mature yet.
Michael, do you think you can cure a biofilm?
I would say some people are cured with biofilm.
Really?
The literature has, counts acute sometimes out to 6 weeks, 3 months, and by then a mature biofilm has developed. But the literature then also shows that, the numbers aren't great, and depending on the organism, but failure rates are, or success rates are 50%, 70% with less pathogenic organisms. So it's not an impossibility.
So Ed, what's confusing about here is that there are the discovery of these non-culturable but viable bacteria that are on probably every sterile implant. So my approach with this is that in every case, in every operation we do, there is some level of contamination that occurs, and our host immune system, which is different due to a multitude of factors, has a certain threshold whereby if there are more bacteria than that threshold, there's an infection. So I think a DARE is not when you necessarily get complete bacterial eradication, it's when you get enough bacterial eradication below that threshold so your immune system can control whatever is left, or you turn off that virulence factor that promotes propagation. We don't know when that is temporally, and we don't really know when all the host factors are. That's why I think this idea of a cutoff, you get so many different answers.
So a quick question then is, on this panel across the board, starting with Amar, do you think that every knee joint that you put in is contaminated with the bacteria? Come on, across the board, quick.
Probably.
Yeah?
I would say yes.
Yes. Yes. Yeah.
I can't escape it.
Can't say no.
Dan?
Yes, to a very low level, hopefully most of the time.
Very scary. All right. So DARE procedure, this goes more to Michael. Intravenous antibiotics duration, how long should we do it?
Well, there's how long should we do it, how long we do it at HSS.
How long should you do it?
6 weeks.
Why?
And I would argue
why?
that it doesn't
And
have to
why?
be intravenous. 6 weeks, it's mostly based on just historical tradition, what we've been doing. That 6-week protocol was developed out of HSS, is what we followed. Now, I know the IDSA recommends between 2 to 6. However, trying to talk a surgeon into treating for less is sometimes very difficult.
Yeah.
We usually 6 months. 6 months of some sort of antibiotic use. IV for however long Dr. Henry, the infectious disease doctor, say we should, then switch over to an oral option if it's available.
I just want to point out, I always find it difficult when people say intravenous, because it's a bit disingenuous. I mean, it's really, there are plenty of oral antibiotics. So you should be saying high dose.
So, yes, I understand that point. All right, we're short on time. Long-term repeat dares. Adrian Taylor used to talk about the survival curve of infected total knees with repeated dares is better than exchange protocols. Do the panel members agree with that across the board? Starting with Dan.
Generally not, but I do think that there is a role for repeat dares in specific situations with hard to extract implants.
And that would be with what indication?
Extremely hard to extract implants where the treatment is worse than the cure effectively.
There you go. Okay, good. Across the board?
Same.
It would be infrequent to do repeat dares, but at the same time, you got to see what the organism is and what your prognosis is, what you're looking at. I mean, if you're looking at a two-stage revision for a multiply resistant organism or a difficult organism, say gram-negative, you are looking at two-stage revision rather than repeat dares.
Sachin.
So I think in my hands, repeated dare is reserved probably for the not so medically fit patient who has probably got a well-fixed hinge prosthesis with long stems up in the femur and the tibia. And the whole morbidity of extracting the component is going to be far more higher than doing multiple.
So here you're saying if the treatment is worse than the cure, treatment is better. Okay, moving on. Single-stage exchange, we've talked about this a lot. Criteria for single-stage exchange for you, starting Amar across the board. Everybody chooses single-stage exchange for hips or for knees.
I mean, as you mentioned, when I do cementless knees now, that's what I'm aiming for.
Yep.
I'm doing a lot more cementless knees, which I know are not available yet in India. But if it's a cemented knee, I generally will do a dare, and then later on I'll take it out.
Okay.
So my criteria for single stage, if I'm doing it in an acute setting, cementless implants within the first 6 weeks, take them out, I'll do a single stage right there. In a chronic setting, I use pretty much what the endo clinic is. You know what the bug is, a good host, a possible suppression, and then favorable results. I would use cement.
Good host, easy bug, yes?
Yeah,
that's what I agree. Good soft tissue envelope as well.
All right.
Yeah, everything has to be going for you.
For the panel, what's a good bug?
Coag negative staph.
Coag, negative staph. Anything else that's good?
Not Staph aureus.
Not Staph aureus. Gram negatives, all out? All out? Okay.
I disagree with that. I have not found, in my practice anyway, to have that much trouble with non-Pseudomonas gram negatives.
Not fungal.
I agree with that. I mean, the ones that we know are bad actors are, of course, fungals. We know that the enterococci are bad actors, and to be honest, coag negative staph are often bad actors. Even though we think they're weak, they're not that weak.
They just persist. They don't
persist. That's the problem.
Yeah, right. So if you're doing a single stage exchange, whoever does it, do you use a cone where it's porous coated? Anybody? Or do you fill it all with cement?
So my idea really with the single stage is that you're doing such a radical debridement that you've got clear margins. So in essence, it should be okay. It should be okay to use a cone fixation. Otherwise, if you're worried about that, why are you putting metal in at all? So to me, I think it makes sense.
Okay. Anybody else?
I agree with that. I think if you're going to go for it, go for it. And if now and then you fail, okay, you got to take it out. So it's the same as a two-stage.
Okay.
I think, sorry, Ed, I'm interested to see what Amar thinks, because then I think all of us may be talking about still using some antibiotic cement hybrid fixation to fix, obviously, the tibia with the cone. Amar, you're really thinking about all cementless if you're going to do that, correct? For a single stage, you're comfortable with that? No need for antibiotic cement?
I mean, that's why I love using the sleeves and doing cementless fixation, because if you get early infection, it shouldn't grow in and it comes right out. And
then start over.
Then start over, exactly. So that's, and then I just have to find some gaps where I can put in some antibiotic cement just to,
I think the idea that you have to have antibiotic cement in a one stage is being challenged a little bit by the data from North Carolina, where they are doing the one stage versus two stage protocol, and at least in the hip, they're doing all uncemented implants.
Yeah, but their antibiotic durations are up to 1 year.
No, they're giving a lot of antibiotics. We got to wait and see. But the point is that I'm not sure we know right now how much the cement, antibiotics in the cement matter. I mean, we all do it, but whether it matters, I'm not sure.
Okay. 1.5 exchange. For a description, generally treat like a single stage exchange, definitive total knee implants, maybe destination spacers, as Michael has talked about, post-op antibiotics for surveillance. Is high-dose antibiotics and cement useful or not for an infection? Yes or no?
So I do it, and I haven't had a problem with fixation failure yet.
Yep.
So I'm just falling more and more in love with this protocol every day.
Are you going higher and higher doses of antibiotics?
I'm doing about 6 grams. I usually use, for reimplantation, it'll probably be 2 bags, maybe 3 bags of cement, and it'll be somewhere between 6 and 8 total grams of antibiotic in there.
So our lab studies in animals show that the spacer with cement is really, really good at protecting itself. It does not necessarily leach out and sterilize the soft tissues, so I am not really convinced that it really is a big game changer. That being said, I still used, but I won't put 4 or 5 grams. I think the Mayo Clinic's published several studies showing the concern about acute kidney injury. You have to be careful about putting in a lot of antibiotics that can elute quite quickly, so you have to just be aware of that, and you should look at that literature.
Taylor, you agree with him?
Yeah, I've been putting in 4 to 6 grams per bag.
Rest of the panel?
Yeah, I think that putting high-dose antibiotics in there makes sense if you're going to do it. But I would actually say that the idea of the 1.5 spacer, where you're putting in kind of a poorly fixed implant, is a fallacy. I think that's just a completely crazy idea. It's the worst of both worlds. So in my opinion, if you want to do something, do it one stage, but do it with higher dose antibiotics if you want to do that.
All right. Why are you saying it's poorly fixed? It's not poorly fixed.
Well, they're not revision implants for the most part.
And then that goes on to the discussion, what is really, truly a 1.5 exchange?
Isn't that just a spacer where the patient's happy and doesn't want to come back for reimplantation? Then you go ahead and call it a 1.5? Right. I mean, at the end of the day,
let's go through this case really quick. Okay, gentleman, BMI 27, knee didn't do very well, swollen, aspiration by local orthopedist, grows staph. He has possible erosion, swollen knee, continues to be swollen. Here's his numbers on his aspirations. His first numbers, culture's negative, DNA negative, numbers are elevated, repeated, still a little bit elevated. What do you do with this situation? Treatment this is real life orthopedics. How do you approach this? Across the panel, how are you going to do this?
Yeah, I'm taking this knee out and I'm going to put in a 1.5 spacer.
2-stage.
Yeah, I would lean towards 2-stage.
This will be a 1.5.
I think this will be 2-stage.
Yeah, kind of 2-stage because there is osteolysis.
Dan?
2-stage.
Okay, so this is what I did. Remember incisions, like a whole panel talked about large incisions around the world, go around and debride it, techniques to tap it out however you want to do it, to tap the implants out, and then was stabilized with a 1.5 exchange. Again, high doses of antibiotic cement. I use a lot higher, more like 7 grams, but to do that, I add 11 cc's, I just figured it out, 11 cc's of saline, then mix the monomer, and then put him off. And then he goes home on postoperative day 5, oral antibiotics only for 4 weeks. So this is where we differ from the East Coast, from the West Coast, antibiotic brachytherapy, which is treatment of antibiotics in the hospital only, no PICC lines. I haven't used a PICC line since 2019. I send them home with oral antibiotics for 4 weeks. And in 1.5 exchange, not all 1.5 implants need revisions. They can last a long time if you use cement technique like Amar has talked about. Allows that patient to return to work, maintain their financial stability, maintain their insurance for subsequent reconstruction.
But Ed, isn't that really a one-stage with just high-dose antibiotics and the cement? I mean, you used revision implants, you had stems, you had good, well-fixed implants, you had good cement interfaces. That's a one-stage.
So if you add antibiotics, you reduce the cement fatigue strength.
But that's a pretty minor effect. So I would just say that's a one-stage with high-dose antibiotics, not a 1.5 stage.
Is that where we should go, where the cement's going to get loose at 7 years and then change it?
I don't know. We don't have any data that says that.
Well, what's your gut say?
My gut says that probably the effect of the high-dose antibiotics on cement strength is not going to be a critical factor in how well they hold up.
So you think high doses of antibiotics, 7 or 8 grams, will last 8 years?
As far as I can tell, I haven't seen any data that says it won't.
Okay.
With respect, though, Ed, I mean, you have extremely good experience. You know how to do a very thorough, meticulous debridement. I guess the question I have here is that we're putting all these high-dose antibiotic cement here. The idea then is that the tissue you are leaving in, the bone that you are leaving in, is not getting any blood supply. It's not being reached by the intravenous antibiotics, so you need local antibiotics to kill it all. This is what's so confusing about me, because obviously that's not the case. The bone that you have in there is still alive. So all the antibiotics you're going to be giving intravenously is still going there. You've done an incredible debridement. Isn't the debridement more important than the antibiotics? I'm just pushing back here. I love the reconstruction.
100%. 100%. But if you have dead bone and tissues that don't have perfusion, what is better to treat the infection? Local diffusion and elution, or is it IV antibiotics that don't necessarily get into the envelope? And that's why I'm going to local therapy, and that's my thoughts with that. Next question, or next topic, native knee bone infection with arthritis. Septic arthritis progresses to active osteomyelitis. What's the best treatment? Take it out, debride it, try to cure it. Anybody?
So I've done a lot of these now. If you try to wash it out, these knees get super stiff, and you've just ruined this person.
They
So
do. Remember that. Remember what Amar just said. They get ruined.
Yeah, they get ruined. So I put in the 1.5 spacer, like a high dose antibiotic knee replacement, and they've done well. They don't get reinfected, and they have a functioning knee.
Taylor, what do you think?
Yeah, I think it's case to case, but I mean, that sounds reasonable given.
Okay, let's go through this case. Antibiotic therapy, well, I don't know where I missed the antibiotic brachytherapy. We touched on that 1.5 exchange. Whoops, I'm going the wrong way. Forward. Let's go.
Say you, Michael Henry.
Forward. Here we go. Here's a patient, Coxey in the knee. He's had 4 surgeries on his right knee, continues to have an infection. This is what his knee looks like. He has end-stage arthritis. This is what his MRI looks like, active infection. Remember, fungal infections go through the ligaments and into the bone. I was only get a little bit of fluid. Microgen DNA is negative on posaconazole. What's the treatment on this? Active.
Two-stage?
I would say two-stage.
Two-stage.
Okay, moving on. This is what I did, a 1.5 exchange. I use antibiotic-loaded calcium sulfate beads in the canal, in and around the joint. I believe that local therapy is the way to treat it. So in this case, I treated him with oral posaconazole for lifetime. This is all the surveillance data is all normal. He's pain-free, continuous, and this is the whole point that Dan was talking about. Destination spacer, high-dose antibiotics. Here he is at 3 years. He's working as a rancher, continues to be pain-free. This is with a modern cement technique. Okay.
Sorry, and then chronic antifungal suppression.
Because he has pulmonary coccidiomucosis that they can't cure. He has a lung abscess and they don't want to take it out.
So then if he didn't have that, would you be still giving him lifelong suppression?
No, I would stop. But the question with fungal infections in the lungs, did they ever reactivate? That pertains to a lot of cases in India as well. Okay, native knee infection. Native knee after fracture-related infection becoming more of a problem we see in the United States. More seen with polymicrobial and fungal organisms. How do we address the treated fracture-related infection when a total knee is required? So do we do those with single stage or we do those with 2-stage? What is your protocol across the panel? Start with Amar.
Yeah, again, I'm going 1.5 nowadays. In the past, I would have done 2.
1.5 and leave it if it's okay. Yeah.
I would say this varies on the organism for sure.
What organisms do you
I would
not?
worry about MRSA. I would be doing that instead.
MRSA 2. What else? All the gram negatives?
Certainly Pseudomonas or ESBLs, things that don't have.
ESBL, yep.
2-stage for me.
Yeah, generally 2-stage still, but.
2-stage for sure.
Yeah, 2-stage definite.
2-stage for sure.
One of the things
Two-stage
I've
except
noticed-
extenuating circumstances.
The extenuated circumstance being the host?
Yeah, the host.
Yeah.
One of the things I've noticed, which I don't think the literature is necessarily borne out, but my hip infections tend to be younger.
Yeah, isn't that interesting?
The knee infections tend to be older people.
Isn't that interesting?
That's why I'm into the 1.5, right? Because they're 75 and plus. I'm like, they can't tolerate.
Yeah. Right. Case, here we are, unstable knee. She's on faculty, prior OIF of the tibia. Here for you, Michael, Lamentasporia prolificans, 20% mortality.
Not good.
Not good. What do you do? 2-stage or 1-stage? Whoops, sorry, wrong way. Unstable knee, hyperextension. This is a fracture-related infection treated with that experimental CDC antifungal, voriconazole and beads. And now she comes to me, unstable knee, soft tissue loss. You do this single stage versus 2-stage. All the numbers are normal, 5 months off of treatment.
I would, just because there's zero literature with that particular fungus
By the way, Limentis sporia, a bad, bad bug.
I would do this in 2-stage and very slowly.
Anybody else?
I don't disagree.
I would send it to Alberto.
All right. So here we are, single stage reconstruction. I use what Alberto talks about. I do a radical debridement, take the cone reamers, ream all of that bone out that was in there, and then I lavage it, full strength peroxide, betadine. I'll show that a little bit later on in a couple minutes. And she was treated with a single stage, no cones, with standard dose antibiotic loaded cement and antibiotic beads. Complex stabilization, large segmental resections. How do you stabilize? With these large multi-failed implants, multi-revised implants, is an amputation better, do you think? Taylor?
Yeah, I'll say, you know, you can use an X-Fix. It's uncomfortable. It's the full leg. You can rarely talk a patient into an amputation if they're not ready to have it yet, though. So I think a lot of people would rather wear the fixator for a while, try to treat it. You know, sometimes that is a helpful realization to them, you know, where their life and leg is headed.
How long does it take to talk somebody into an amputation, electively?
3 to 6 months.
Easily 6
Panel?
months plus.
6 months?
A long time, surely a long time.
Depends how long it takes to see Taylor.
If the distal limb is functional, we should always try to keep the limb, because amputation has its own complications, as we have seen in previous presentations.
Yeah.
I think it's also important to say that I felt comfortable using distal femoral replacements as spacers. They're expensive, trust me.
They're expensive, and
Your
your administrator is going to be right all over you, just like me.
The internal external fixator works really well, though. I don't know if you guys are familiar with that. We put an external fixator inside, coat it all with antibiotics,
and then let 'em-
and then you know that'll hold up for a number of months while you're making your decisions.
Yep. All right. So here's the case, failed reimplant number 2. 2 flaps, lateral gastroc, vastus lateralis, extensor deficient, refuses amputation. This is what he looks like right there. He's got staph epi and Klebsiella, as you know, bad bugs. What's the treatment, gentlemen?
Yeah, I'm trying to talk this patient into an amputation usually. Can you show me since I want to see the rest of that femur. So yeah, there's enough femur to do an osseointegration there. And maybe she's never heard of it. You know, maybe that helps her change her mind and make her decision.
Do you really find it's more the function of the foot? They always look down at their foot and the foot's normal. And they say, I don't want to lose that foot.
See, that's the problem with these cases. Their foot works, they have normal sensation, they have normal circulation. It's just the knee. Why can't you just fix it?
Yeah, I say, yes, I know your foot works, and everything up until your hip doesn't work anymore. You know, this entire segment of your leg has failed you now. And I mean, look at this. This is, yeah.
All right, so treatment here, endoprosthetic fusion. This is where I use the modular endofusion device. It uses a stabilizer. Sometimes it's permanent. Antibiotic beads, you know, that's the West Coast side of local treatment. I cut the stems to what I call the Gerke 125. He taught me 125 millimeters with a fat stem, keeps everything stable and is just the right length to take out and debride the cement. So again, antibiotic beads are in there. Why do I use antibiotic beads? Because antibiotic elution efficiency from cement is only 5 to 8%. Beads completely dissolve within 4 to 6 weeks. Beads always dissolve within the canal. They never form bone. This is showing the leach effect from cement. It's only 1.5 centimeters. So that's why Amar.
Have you, my experience with beads is that it just causes a weepy drainage, and just, I got away from them because of that.
Everybody about beads across the board, really quick.
Drainage, whenever it's left in the joint.
So, yep.
Yeah, certainly for more like osteomyelitis bone infections, I've headed more towards like Cerament G, which doesn't drain as much.
So what I say with beads is that it's leak, aspiration, post-op, get it controlled. And it's not, the bead leak comes from the acidity from vancomycin when you add to it. Tobramycin buffers it. Vancomycin has a pH that's down around 4. That's why you leak. All right. These are aspiration studies, and this is what I want to show to Alberto with DNA studies. So I'm aspirating, get the beta fusion down. DNA is positive post-op. Why? Because bugs are still being killed. DNA picks up live organisms for up to 24 hours, showing that even 10 days after that resection, it still has positive organisms by DNA, which are going to be culture negative. That's a learning point for me. So lavage agents, we're almost done here. What do the panel members recommend in terms of lavage for infection? Across the board.
I use betadine peroxide.
Full strength?
No, diluted.
Diluted.
Full strength betadine peroxide.
Yep.
Diluted betadine and peroxide.
Normal saline with vancomycin.
Normal saline with betadine.
That's betadine and peroxide.
Dan?
Dilute povidone iodine.
Povidone iodine only. All right. Irrigants?
I have done these like double, triple dares where I've used like Dakin solution.
Yep.
It's crazy, but yeah, I've done it.
This is mimicking what Alberto said. This is from our lab. It's in the middle of being written up. We tested everything across the board, not in vivo, but in vitro to see what is the best agent. You can see Surgiphor is not good about planktonic cells. If you look at biofilm, not all of these agents, including Dakin's, kill biofilm. And if you take the finalists, which is the hydrogen peroxide, betadine, tested against Bactissure, which is the most manufactured one, tested against Staph and Canada together, you find out that the only winner in this is full-strength hydrogen peroxide and betadine, which is a radical debridement, thinning lavage, and then you put it in, mix it in, fizz it up. And remember that betadine and hydrogen peroxide will kill your own cells, including your own immune cells, so you put it in for a couple minutes, 3 minutes, and then lavage it out and make sure it's absolutely spotless before you go. So with that, for successful treated total knee PJI, how long should patients be treated with oral antibiotics? Preset, ID specialist, based on surveillance or lifetime. We're out of time across the board.
ID specialist.
Lifetime.
ID.
What's that? Who said lifetime? Why?
I mean, I think the risk of a reinfection, if it were me, I would take it forever.
I would say your biome in your gut is going to create a resistance gene within days.
That's true, but I don't know how clinically important that is. When patients fail DARES, it's rarely
You get a
resistant
plasmid,
organism.
you get in there, and you get a resistance to that organism.
But you rarely get a relapse with the resistance of that infecting organism to begin with. Most of the time, it's just from another bacteria, which is why I don't worry about that as much. Whether or not long-term or...
Should it be lifetime?
It is with us. Should it be? I don't know.
Okay. Good. I think that's it for this. We move on to our next panel speaker.
We have 3 cases, which is a part of the panel discussion.
Yep, let's bring them up. Our first one.
Yes. Can I have Dr. B.D. Chatterjee? Yes.
Okay.
Yes, please.
And I guess we'll stay up here until these are done, and then we'll take our pictures.
Okay, I see, all right. So wait, this one? Thank you very much for the opportunity. It's a real privilege to speak in this forum. No, how do you move it? Left. Okay. No. Okay, the first slide, please. Yeah. So the literature says that the two-stage revision has a fairly good outcomes and a reasonable rate of patient satisfaction. There are some of the other papers which have today established two-stage as, I would say, the gold standard as of now. Now, the central to this technique is the use of the cement spacer, and it has important functions such as antibiotic delivery, patient comfort and mobility, and you can actually space out your reimplantation, and it keeps the soft tissues under tension so that it gives better soft tissue health. So this was traditionally used, the non-articulating spacer, but this had problems of joint stiffness, muscle wasting, bone erosion, mobility, and it made second stage revision very difficult. So our case is a 68-year-old female bilateral TKR done some time back, developed infection, treated with debridement and poly change, and then followed by antibiotics, and has been on a rather haphazard regime for the last year and a half. And she was ambulant and walker. The right knee was swollen, and there was a discharging sinus. The culture grew methicillin-sensitive Staph aureus, but there was no signs of systemic sepsis, and she had some comorbidities. Now, the first stage of a planned two-stage revision was performed. There was a fairly massive bone destruction encountered. However, the collaterals were found intact, and we made articulating spacers from a mold, and they were put in place with 2 grams of vancomycin, and stimulant pellets were used. This is the joint on exposure, and on removal, there was a pretty bad situation with a lot of bone destruction. These are the molds which we used to make the implants. These are the antibiotic-loaded PMMA inserts which were put in place. And this is a post-operative X-ray with the stimulant beads, as you can see. This patient was ambulated on the first post-operative day and started on exercises, transferred to a tripod stick in about 6 weeks. The sinuses healed. The CRP and ESR returned gradually. Knee bending started, improved to 120 degrees, and she was able to walk independently with the tripod stick 6 weeks after the surgery. And the second stage was planned 4 months after the first. The surgical findings, the second stage, the knee bending was pretty good, and this is what I want to emphasize. The condition of the knee treated with articulating spacers is infinitely better than the one with static spacers. There was no collateral instability. The soft tissues were supple and not contracted, and the infection was controlled. However, there were massive cavitary defects which needed to be addressed. This is the knee before the start of the second surgery, full extension, as you can see. This was the defect, and this was the plan, the surgical plan, the MBT tibial revision tray with a sleeve, and on the femoral side too, because of the defects, it necessitated the use of a sleeve. So this is the trial sleeve in the tibia in place, the trial femoral sleeve in place. These are the trial implants. This is the definitive implants before being inserted. And this is the post-operative X-ray after the second stage implantation. This is the bending she was getting at the end of about 6 weeks after surgery. So there was a study about 10 cases undergoing two-stage revision. The articulating spacers were used in all cases with 4 grams of vancomycin. Unfortunately, actually, we had just one trial mold size, so they were all of the same size, so that needed a bit of adjustments. Bacteriology was established in 5 of those cases, and the average time interval between the stages was about 3.5 months. So all patients were mobilized with walker support, and they were relatively pain-free after 3 weeks. The average range of movement was pretty good, and after definitive implantation, it improved further. One patient required a second stage debridement and reimplantation. So in summary, infected TKR is of course a serious challenge, as we've seen in this panel discussion to the surgeon, due to bone loss and soft tissue contractures. Two-stage revision is still the gold standard in most places, although a lot of people may not agree to that. The conventional monoblock antibiotic impregnated spacer led to problems of soft tissue fibrosis and muscle atrophy. An articulating antibiotic spacer allows better mobilization and importantly permits knee flexion, maintains elasticity of muscle, and massive femoral and tibial bone defects can be effectively managed today with metaphyseal sleeves and obviates the needs of use of wedges and augments. I thank you for a patient hearing.
All right. And next we'll have Dr. Marathi talking about gram-negative infection, my worst fear.
Thank you. Good afternoon, everyone. Thanks to organizing committee for inviting me again. That's my case. History is 75-year-old female, OA with old proximal tibial plate was there. Primary surgeon did the total knee with the tibial plate removal 1 year back. After 3 months, patient had fall, injured patellar tendon, which was operated by semi-T augmentation. She started walking at around 2 months, but little bit pain after patellar tendon injury. So presented to us, chief complaint was redness, instability, pain, swelling. She stopped walking since last 2 months. So we sent infection marker and aspiration done, and all infection markers, shed rate, CRP, and WBC count was high. And unfortunately, Klebsiella MDR, resistant to carbapenems. So choice of antibiotic was only colistin or polymyxin. These were the culture report. So surgeon's dilemma, MDR Klebsiella, which is such resistant organism, what could be a prognosis of the treatment? If I think for the spacer, or should my strategy to change my, based on the organism, orthodesis or amputation? Case is open for the discussion panel.
Treatment.
So I'll tell you my preference. Just like you saw with the metaphyseal sleeves, I would do that with a hinge. I would think of it more as a spacer. More
like a 1.5 exchange, permanent.
Yeah, you know, as I said, if it gets infected early, they're easy to take out. If it gets infected later, it's harder to take out. The way I mitigate that is the sleeves come in fully porous coated and partially porous coated. I would probably put in a partially porous coated femoral component on that side. And on the tibial side, I would use a partially porous coated sleeve and a very long 14 millimeter diameter stem that I can take out through the sleeve. So it just allows for easier removal of the device.
Since the extension is deficient, why not do a endofusion, cure the infection, come back, and then reconstruct it with an allograft or a mesh? Yes? No?
Yeah, so I would tend to, I mean, because the extensor is out, obviously I would switch more, and because this is a big, there are a lot of R's on that piece of paper you showed us, too many R's, no S's. If Dr. Henry is quite scared, then I would probably do static spacer with a little bit of cement in front so it doesn't actually involve the patella, and then come back later with a reconstruction and a mesh.
And maybe even a flap in the meantime, right? Just because that area has been devascularized from debridement, yes? All right.
Anything else? So what I did, opening arthrotomy after thoroughly debridement, we found that there is a intact MCL as well as that patellar tendon was lengthened, but it was intact. So we removed everything. We put the articulating cement spacer. We tried to build up with the tibial wedges as well. So 35 mm construct on the tibial side and femoral side. So that was my intra-op pictures. Got the stability and everything was fine. These are my intra-op videos that we checked the stability. These are my post-op X-ray.
Was the patient able, to actively extend the leg and the knee before, but when she had the infection?
Yeah. So, septicemia treated by colistin at the age of 75, went in ARF, tried with the polymyxin, ARF continued, dialysis, stopped antibiotic and multi-organ failure, died on fifth post-op day. So despite of doing all best surgical and medical management, so discussion with the panel that should the treatment based on the organism profile and patient profile, MDR Klebsiella resistant, retrospectively, according to literature, that definitive treatment and amputation could have saved patient's life? Just the question with the panel.
So obviously an amputation is going to help save the life. The question is, if a patient has a foot that works and there's neurovascular exam, Taylor, would you treat this like a tumor and just go excise wide and cut out the entire infection? Or do you treat like this locally? Because
joint surgeons want to just focus on the joint. Maybe we just need to go
Yeah,
big.
I would have gone well above the previously infected area and treated it like a
Like
tumor.
10 centimeters above, 5 centimeters.
Maybe, yeah, more like
Alberto?
4 to 5, but.
No, so in all honesty, this is the first that I've heard of this problem with this specific bug, and that's the entire reason why we have conferences like this, so we can all be aware of something like this, because I can tell you, this is not an outcome I would have expected, based on what you told me. So now, however, even knowing the situation, I would then reference this article, I would have a chat with my infectious disease specialist, have a rigorous preoperative optimization strategy. Now that you've told me that this could kill the patient, obviously keep the patient under monitored setting, and have a plan to make sure this doesn't happen. I would not still have jumped to an amputation right away.
Michael, can I get colistin in the United States?
Colistin?
Yeah.
That's a good, I've never used it. So
Yeah, it's a polymyxin family.
No, I've used polymyxin B.
Yeah.
Part of the problem here was the toxicity, you know, that may have pushed this over the edge. Once
Yeah.
you get to dialysis,
I think it's a combination.
all bets are off.
It's a combination of hemodynamics, add the antibiotics and the toxicity, right? Maybe it's better we just go big. Sachin, your thoughts?
I think polymyxin B probably is the culprit here because
Yeah.
it's extremely nephrotoxic, especially in someone who's 75 and has got comorbidities. And probably multi-organ failure, polymyxin B was the tipping point where I think the AKI that happened just sort of tipped it off.
Dan, would you cut big, cut long?
You know, I don't know enough about this particular organism's sensitivity
Forget the
profile,
organism,
but
would you go big?
Yeah, I think in this situation, more debridement is better than less.
All right.
Yeah, but if I can just say, I mean, if the patient's, if we ignore this thank you again for bringing up this really incredible case, but if, for example, we had a patient who's already in kidney failure or is on dialysis, and we need to go ahead and put in a high-dose antibiotic spacer, I mean, do we have to have a different consideration?
And I think the consensus from the panel is 1.5 well-fixed cement, like Amar has talked about, put in a big resection and endo hinge. Then, if that doesn't work, then you go to Taylor and put in an osteointegration stem. And I think that's kind of where everybody's kind of going to, yeah?
As I understand, the problem in this case is that the patient is not tolerating the IV antibiotics because of the toxicity. So there are reports in literature even that people have used the infusion pumps to deliver the drug into the joint. And they believe that actually we achieve that concentration that can effectively kill the organism. And personally speaking, I have faced this situation twice where only one antibiotic was sensitive and patient had allergic reaction to that. So we were using this infusion pump, given that antibiotic for 2 weeks through that infusion pump, and it somehow healed.
All right, really quick across the board, because I don't have time. What's the best way to get antimicrobial agents to the tissues and bone in an infection? Local or IV across the board? Your gut.
IV.
IV.
If it's a live IV.
Local.
Both.
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 That's cheating.
So, both. We have consensus. All right. Thank you very much for a nice presentation.
We have another case discussion, sir.
One more, or we have a
another
discussion?
small case discussion added up
All right.
by Dr. Suhas.
Good afternoon, everyone. This will be a quick one. This was a very unassuming case, 61-year-old male, diabetic, hypertensive, not immunocompromised in any way. None of the parameters were a red flag except that he got a bilateral intra-articular injection 4 months before the procedure, which was the left knee. And then once I open the joint, underneath the patellar tendon, I see this black synovium. And I was at that point thinking that this probably might be some hemosiderin because of the hematoma. And then after I take the tibial cut, you can see that there is a big lesion on the lateral aspect. And then it occurred to me that this gentleman took an intra-articular injection. So was there an inoculum of something that went into the joint? Surely enough, I went ahead and had to do the surgery. I had put a stem because I saw the tibia was not good enough. And then the first histopathology that came out was Aspergillus species. And then we immediately started him on voriconazole. In the urine, he had Pseudomonas with high markers, so we had to give him meropenem. And we had to put a WAC dressing because there was a lot of ooze. The only reason we went ahead was we waited for 3 weeks to see if there is any subsidence of discharge. but there was none. Since he was not immunocompromised and it was less than 3 weeks, we attempted a DARE procedure. You can see here, this is the patellar tendon, and this is from where the inoculum went in. So there was this yellow discoloration, which at that point we thought was biofilm. And right underneath the patellar tendon, you can see this black discoloration, which looks like a fungal infection. And then immediately we shifted him to Anidula fungin as well as Zavicefta, because there was gram-negative bacilli also on the gram stain. But there's no luck. Even after this, the patient still had a lot of ooze. And then this is him at 5 weeks after DARE, where we also put some antibiotic beads with amphotericin. Nothing worked. And then the next report in the histopathology on DARE, which we sent, came out as mucormycosis infection. And I think I've gone through literature. Probably this is the first instance that I'm seeing that there is a documentation of mucormycosis PGI post-inoculum. And now we've shifted him to liposomal amphotericin, posaconazole, stage 1 region. We've removed the implants. And here you can see that this is the lesion. This is him after the debridement stage 1, and you can see how the infection is still persisting. On the femoral side, there is nothing much. So he's just 2 days post-op, so I've left him with an antibiotic spacer. I've put around 300 milligrams of liposomal amphotericin. So my question is, will this work? If it doesn't work, do I repeat a stage 1? And if it subsides, is this a precedence for a stage 2 revision? Or do we do something like a salvage, like an arthrodesis?
Let me paraphrase that for the panel. Was that debridement good enough, yes or no, across the board?
Yeah, it seems a little under.
I see aspergillus in that bone. Is that good enough?
As long as you can see all that terrible looking bone there, it wasn't enough.
Yes, right?
I think it's also important to understand, is this PJI? This is osteomyelitis. So I think it's very important to distinguish those two things. And I think you've taken these beautiful pictures which really help us understand what you're going through. It's difficult because you have all of that tibia that has to come out. It's a little bit nauseating to see that all that bone's going to have to come out. But ultimately, I think you've done your due diligence. In my opinion, this requires a massive debridement and then likely a spacer or something you can easily take out.
This is basically a tumor, right? I mean, it's so bad that you're going to have to cut till you get rid of the dead bone and the infected bone.
The black bone's got to go. What's your margins? How far down do you got to go down on that?
That's the question, right?
Right? How far? Anybody across?
Yeah, I mean, all the way,
probably to the diaphysis.
Yeah, a centimeter or two beyond that.
So a lot of the lesion was underneath the patellar tendon. Right?
Yeah, but the bone is black,
Yes.
right?
So
what are you
this is
gonna do?
after all the scraping that I could do. So you would suggest that I would just take a tibial cut and then remove as much.
The tendon itself was black, right?
The bone is black. That means God bless you for taking care of infection. But aspergillus, I've lost probably more. I've lost 70% of my patients in terms of recurrent infection requiring amputation with aspergillus. Unless you go big, you're not going to cure it.
This is mucormycosis now.
Yeah, I mean,
that's even worse.
Right.
So just for clarification, based on the photos, if you just go one more slide, I wouldn't necessarily, I mean, I'm not sure where your variability is for the tendon, but if you go one more slide forward, I would resect as much of that metaphyseal spongy bone as you can, preserve as much cortex as you can, and go down to the, I think it's the other way. And yeah, so all that cancellous bone anterior to that tibial sort of drill hole, that all has to come out.
It looks about 4 centimeters deep. You go back to that, right?
I mean, obviously try and preserve the cortex. For the patellar tendon, you can obviously scrape and scrape and scrape until all the black comes out. You could try that first, and then if that doesn't work, you have to start thinking about resecting the tendon. I wouldn't necessarily resect the tendon right away, but you've got to get rid of all that bone, all the cancellous bone. Eddie Schwartz has got nice paper showing that the bacteria can squeeze in the canaliculi, the organisms can. That's what's going on here. So remove everything inside, leave a cortical shell, leave the patellar tendon, fill it all with antifungal cement, whatever you can. Keep the patient straight, let that soft tissue close. You probably need a plastic surgeon now to help you with soft tissue closure and get a flap and let them completely heal, and then keep them on antifungals for 3 months, probably 6 months, and then wait to see what happens. And then a long antifungal holiday, and then an aspiration. But if any time during this time they fail, you got to go back in, resect the patellar tendon, resect the patella, and then, or maybe, yeah, resect the patella, and then again do the same thing with the spacer, and then get a flap to expand the tissues. Otherwise, it'll contract.
Or tailor as an endofusion better now.
Yeah, I think this is headed towards a fusion at the very least.
Yeah, if the tendon comes out, it's a fusion for sure.
Yeah, because we can't, do you foresee giving amphotericin for 3 months to 6 months, given the toxicity?
I would just tell you with Mucor, I mean, the chances of you curing this, that I look at most tumor-like of all the infections. I mean, you're going to be very lucky with any amount of months of amphotericin. I've never used amphotericin for that long, just in terms of the toxicity.
Which goes back to the point for all infection societies, Europe, wherever, as Alberto has talked about, it's the debridement, and that's the first take-home message. Everything else, we all have our styles, but it's got to be a major debridement.
I just also wanted to make a quick point here. Infection treatment is a team treatment. It's a multidisciplinary treatment. At HSS, when we have something like this that is really challenging and anxiety-provoking, I don't go in the case alone. I've got one of my colleagues there to help me out, someone else who can help me when I'm a bit apprehensive, maybe make decisions. Does this bone look bad to you? Yeah, it's dead. We got to take it out. I'm a bit hesitant. No, we need to take it out. So that other person in the OR that can help you make that decision, and then you know that you've done really what's right for the patient. The patient will feel better knowing that there are two of you in there, and then obviously having an infectious disease specialist who's there with you. So for us, we have a multidisciplinary group of people who are interested, but don't be afraid to call a partner to come in. It's the best decision you'll make. You'll feel so much better when you've done it.
And for those who take care of infection, may God bless all of you, because it's hard work and it's not always rewarding.
Thank you so much.
All right.
Thank you for the case.
Yep. Do we have time for questions? Yes?
The floor is open for questions now. Delegates, feel free to ask the questions with the moderator and the panelists as well.
Now that the infection has gone in 2 stages and we are ready for the second stage, what is the best marker to decide that, yes, you are ready and we can go ahead with the second stage?
So if you're going to go without an aspiration or with an aspiration?
That's the question, because many people told that they are against the aspiration or they would not like to do. Because many times when you go inside, do a second stage, you take the tissues out and they again turn positive.
All right, pre-op. Infection looks cured. What are your markers before you go for reimplantation across the board? What are your top 2 that you use? What do you rely on?
The ESR, CRP, and aspiration.
Okay.
I use aspiration and frankly, clinical exam. I don't worry about ESR, CRP at all.
Not at all. Not at all.
They create more anxiety than anything.
Okay.
Get as much evidence as you can. ESR and CRP could be elevated if you have a mobile, non-fixed spacer. For me, it's an aspiration. It's the cell count and differential, which are the most important.
DNA, yes or no?
No.
Okay.
Yeah, I think you'd need an aspiration for sure.
And what do you use on your aspiration?
I mean, still the white cell count. And,
I go white count, but culture negative is culture negative. So I go white count, and do you use neutrophil percentage?
yeah, we look at it.
Sachin?
Yeah, it's falling acute phase reactants. You want the ESR and the CRP to be falling, and aspiration, cell count, differential, no DNA.
Use ESR CRP. The problem is if somebody's inflammatory arthritis patients, the ESR CRP doesn't really come down to bottom, and you're just wondering. So aspiration has pivotal value there.
All right.
CRP and the cell count, because most of the times the joint is dry, you just can't aspirate anything.
Yep. Dan?
Sed-rate CRP clinical scenario and aspiration only in exceptional circumstances when we can't sort it out.
Okay.
CRP, ESR, and aspiration.
Does everybody believe that ESR is accurate? So why are we using ESRs? Anybody?
Lack of something much, much better.
All right. Okay.
One more point.
One more question.
Have you ever came across like aspirations are negative and the on-table tissue cultures on the 48 hours after the revision TKR which you have done turns out to be again positive with the same?
So you're talking about an aseptic revision with positive?
No, the septic revision with the same organism, now that everything is cured, aspiration is negative, which we normally do.
Yep.
Holiday period, aspiration negative, ESR, CRP okay. You go ahead with your surgery and then you routinely take your cultures, which you have to. and then that turns out to be positive.
So what's the incidence, what's the percentage in your practice you have a positive culture at reimplant?
So then you want to go ahead with a frozen section or something? You want to do that?
Yeah, so I just want to be a little bit careful about what you're saying. So I think at HSS, we looked at the last 99 reimplantations that we did. We had a 9% positive culture. So 91% of the time, no positive cultures. In my experience, I have had some patients where all of my aspiration, all that stuff, completely negative. I get 2 or 3 positive cultures, and usually it'll be something like a coagulase negative staph, something else that wasn't necessarily there. Rarely it's the original bug.
Probably in the metaphysis of the bone.
I think it is important to distinguish. I don't necessarily utilize frozen section. I don't really find it so useful, but I do take definitive pathology sections or pathology at the time of explant and reimplant. Definitive pathology is more useful. But you bring up a good point. That's why for me in my reimplantations, I still give patients about 3 or 4 days of intravenous antibiotics just to cover in case something grows in those first 2 or 3 days.
Okay, a quick question across the panel. Does anybody use frozen sections anymore? Yes? Raise a hand. Who uses frozen sections?
For tumor cases.
Okay. I think that's being done less and less, I would think, because of the pathology differences, right? Okay. Number 2.
Yeah, suppose we have done a successful 2-stage revision and we have removed the stitches. My question is, how long you are supposed to give the antibiotics and what is the criteria? Number 2, if the CRP suddenly increases, it could be because of urine infection also.
So
what to do?
So first question, Michael, everybody's relying on you. How long antibiotics?
I usually give antibiotics sort of as treatment to guard against the scenario that was just
reimplant.
Reimplant, exactly, waiting for cultures. But I know there's a small amount of literature to show that continuing, upwards of 3 months after reimplantation is in some places becoming a standard. I don't use that at all.
Is your organism a factor in your duration of antibiotics?
No, not at all.
All right, there you go.
My feeling is you've cured it at that point or you've not.
There is a Coventry award-winning paper showing 3 months of additional antibiotics was successful. That's got an average follow-up of 1 year, and they said we'll do a midterm follow-up. That was over 6 years ago, and they haven't done it yet, so we're waiting.
Yep.
And there have been follow-up papers too, retrospective, showing that maybe as little, looking at 3 months versus 2 weeks. 2 weeks was at least just as effective. So if nothing else, in terms of antibiotic stewardship, if people insist on treating, you could treat for less.
But you bring up a good point about wound healing. So I think it's important that whenever you're dealing with patients who have explants or reimplants, I tend to see them back pretty early at 2 weeks. Make sure that wound's healing. Don't let the nurse or someone else take those sutures out. Have them come back in clinic, and they're not an aseptic revision. Keep a close eye on the wound.
Number 1.
What antibiotics do you add to the cement and culture negatives when you do a first-stage debridement?
Amar, what do you use culture negative? Or
Usually it'd be Vanc and Tobra.
Tobra. Why is that, by the way?
I just have the most experience with it.
Yeah. I think it was broad spectrum, but I also think synergy. Yes, Michael?
Yeah, I would say broad spectrum and synergy. I'm not sure what else. I would not add antifungals or anything like that.
I agree.
I would use vancomycin in higher doses. So if you give a sufficiently high dose, even if it's not directly sensitive, the MIC will be high enough to kill those bacteria.
We don't have tobramycin powder available in this country, so we use Genta cement and add vancomycin.
Sure, any mycin.
Do the same.
Right. Number 1.
One second. Mike 7, we have a delegate who's been...
Oh, hi, I'm here.
Where? Oh,
Yeah.
I'm so sorry.
So I just wanted to
I
know...
wear glasses.
We in India do a lot of bilateral knees, and the number has increased extensively over the past few years. So how often do you encounter bilateral simultaneous infection draining person? If yes, how do you manage and plan? If you can just briefly write maybe.
Good question.
We've had a few.
Simultaneous or staged?
So, interestingly, in the U.S., at least I think our rate of bilaterals has gone dramatically down.
So I think so. There are 2 points here. Number one is, and we could open up a whole discussion about this. A person has multiple joint replacements. One joint's infected. Do you aspirate all the other joints or not to make sure they're not infected? The Endo Clinic has actually published a few papers showing the incidence of other joints being infected is actually quite frequent. That being said, in my experience, when I've had patients with bilateral knee infections and they're reasonably good hosts, what I will actually do is I will actually take out the first knee, put in a spacer, a reasonably good 1.5, whatever you want to call it, good spacer. Then I'll go ahead and do a one stage on the other side. So then I'll come back and re-implant the first side. I'll end up having 3 surgeries. That's what I've done recently with those bilaterals. If, however, they're bad infections, they're both bad, spacers in both of them. But I would not do one stages in both.
Your interval in between is 1 week, 2 weeks, 3 weeks?
Usually it's about 1 to 2 weeks so that they've actually recovered from the surgery, the insult of the antibiotics.
Yeah, okay.
Thank you. Thank you.
Number 2.
Hi, my question is, if you screen for MRSA in patients and you find it that the patient is MRA positive, and it's a primary setup, how long do you give antibiotics post-operatively? And secondly, if it's a revision stage and you're trying to put a spacer, so in what stage of the cement setting stage do you add antibiotics to it, if it's an antibiotics?
Sorry, so your first question had to do with MRSA screening, and if we give additional antibiotics. So if a patient's MRSA positive and they get the mupirocin swabs, that doesn't affect. I don't give them additional antibiotics post-operatively.
No.
Does anybody give additional antibiotics for MRSA patients?
I'll give Bank an answer.
And then,
Right, periop.
Well, no, what about duration though? He's saying, do you do a longer
No,
duration?
nothing.
Nothing else, okay.
And then in terms of adding antibiotics, when you should add it to the cement, I've been to a few infection meetings over the years. I've seen lots of symposiums about how to add antibiotics. I remember at one conference in the morning, the surgeon added antibiotics to the powder and then mixed the liquid. And then in the afternoon, the second surgeon mixed antibiotics with the liquid and then added it to the powder. And then if I asked my colleagues at the Mayo Clinic, well, we add the liquid and the powder and we add the antibiotics after. So we've just finished a nice, elegant in vitro study in our lab. We're writing it up now for publication. There's no difference whatsoever. So to me, keep it simple. Crush the powder into fine granules, add it into the powder of the cement, homogeneously mix it so you don't have big clumping, and then add the liquid after.
More your point?
There is a difference with regards to allowing the polymerization process to start. So if you're adding 6 to 8 grams of antibiotics like I might do, I'll usually allow the cement to get wet and then I'll start adding antibiotics because I have seen the process get halted if you put too much antibiotics.
Or you can add just saline and get it a little wet and then add the monomer, and it actually works. Dr. Chowdhury is going to be testing that in his lab up in Aligarh probably next month, I hope. You better, at least. Number 1.
Good afternoon. So I want to know the panel's take on subclinical tuberculosis. Like, for example, a patient, we have got 2-3 patients who came with a valgus knee for knee replacement, and on evaluation was found to have some synovial hypertrophy, got MRI done, there was synovial uptake, increased uptake. We did an arthroscopic biopsy and CBNet was sent, and rest everything was within normal limits, CSR, everything, culture, etc. So we started the patient on ATT. Now, since ESR CRP to start with was normal, there was no clinical symptoms, so I could not assess the effect of the ATT on the patient. So in such cases, when should I offer the patient a knee replacement? And when I'm doing the final placement of the implants, is there any other investigation which I should send intraoperative sample or anything? In India, subclinical tuberculosis, at least in my little practice, I feel that it is there.
Your definition of subclinical tuberculosis, positive by tests, but no clinical infection.
Yes, sir.
You're talking latent tuberculosis.
If the patient is on antituberculous medication, I would rather that the antibiotic was stopped completely and then go ahead with the total knee. For the simple reason that most of the patients have rifampicin on, and rifampicin is fairly toxic in the long-term usage. So, they do have this nausea and other symptoms as well. So I would, if antibiotics or ATT is going to stop in 9 months' time, I would have that stopped and then go ahead with the total knee.
Sachin?
So I think from what I hear, right, you did a biopsy, the biopsy showed it was tuberculosis, correct?
Yes, sir. But no symptoms. Patient was planned by residents.
So I think if you have a biopsy that shows that there are, the Langhans cells and the histology is positive, then you have to treat it, at least wait for 3 months and then go ahead and do your total knee. And as per the guidelines which are published now, you have to continue treatment for osteoarticular tuberculosis for anywhere between 12 to 18 months.
18 months.
I think it's 18 months duration now, isn't it, Michael?
Yes, yes.
And is it three drug regimen?
I honestly don't, at some point it drops down to 2. I forget,
Yeah.
I don't know the regimen,
All right.
off the top of my head.
We're short on time, but I want to ask one academic question for the panel. Why are we seeing more fungal infections in joints in the last 5 years across the board? Why?
I don't know if we are.
I don't think we are.
I'm seeing it.
I think we're getting better at culturing and being more aware of our culture durations and looking for things, and therefore we may identify these topics. The problem is when you look at a lot of the cross-sectional studies, comparing this time versus 10 years ago, the actual demographics and the populations across the United States especially are changing dramatically. I don't know if that has something to do with it. But at the same time, atypical organisms we have to be more aware of, for sure.
Is it better diagnostics, or is it metabolic syndrome with bad immunity, or are we taking too many antibiotics in our food?
Or are you operating on many more immunosuppressed patients, BMT history, organ
With
transplant
all
history?
the antibody inhibitors?
Yeah.
But there's also a paper showing, I don't remember where it was published, I think it was this year, showing that taking fungal cultures is a waste of time in routine infection cases over a series of 150. Mayo Clinic, there you go. So,
Dan, your thoughts?
I think it's probably some combination of better diagnostics and probably the fact that we're more willing to operate on sicker hosts. And so
There
the
you
sicker
go.
hosts are the ones that are more likely to get them, and that's probably what's happening. So
So
some
what,
combination of the two.
what should we do in C hosts?
Well, it's a numbers game, right? It's an absolute numbers versus a relative risk.
Economic value.
Relative risk is high, but absolute numbers still low. So
Yeah.
probably no change.
All right, with that, we got to stop. I want to thank the panel members for a wonderful discussion. We'll get there for a quick picture and move on to our next topic. Again, thank you very much.
Thank you, Dr. McPherson and all the panelists. Can I have all of them for a group picture? And for the next session on alignment controversy in knee arthroplasty, I would request Dr. Rajesh Maniar sir, who would be the moderator for the panel discussion, and the panelists for the next session, that would be Dr. Harish sir, Dr. Mudit, Dr. Suhas, Dr. Edward J. McPherson, Dr. Arun Mullaji sir, Dr. Hemant Wakankar sir, and Dr. C.S. Yadav. Thank you again, the moderator and all the panelists. Up next, we have the session on alignment controversy in knee arthroplasty. Once again, I call upon Dr. Rajesh Maniar sir, who will be moderating the session. And on panelists, we have Dr. Harish Bende, Dr. Mudit Khanna, Dr. Suhas, Dr. Edward McPherson, Dr. Arun Mullaji, Dr. Hemant Wakankar, and Dr. C.S. Yadav. Over to you, Rajesh sir.
Thank you. Good afternoon. And I think this is really going to be a very stimulating session, because in the last decade, we've seen that the alignment controversy has come along in big way. And we have an eminent panel here using different technologies, different alignment philosophy to understand from them. So let's get on. There's lots to discuss here. I think 5 decades back, or maybe more, when we started with total knee, most of the surgeons started with mechanical alignment philosophy. Few, Townley and others, put the tibia in 2-degree varus as it should be, but soon realized that that's not achievable every time, and it is complicating the post-op x-rays if it further goes into varus. So I think most of the people adopted mechanical alignment as their goal. And over the 4 and 5 decades, that is what was used. However, about a decade and a half before, kinematic alignment was coined mainly by Howell and few others. And that really took off. A lot of people started taking to this alignment. And not only that, there were many offshoots, many other alignment philosophies came along. And I think we need to understand the concept behind this and then really formulate what you're going to do. So mechanical alignment, let me first ask on the panel, how many people use mechanical alignment as their alignment goal today? So 4 or 5 of them. And
Mechanical with slight modification.
Yes, yes. So I think
slight modification, measured resection.
It's adjusted mechanical, isn't it?
Right. So I think I will come to that, but overall some form of mechanical alignment and maybe a little bit of tweaking here and there. Edward, what is it that you use?
So I always believe that the tibia is the source of most mechanical loosening, so I want that perpendicular to the mechanical axis. And if you want to tweak it, I'll go slight kinematic if needed for my alignment. So I tweak it just a little bit.
Right. So you do tweak. So most of the people use, Arun, what is your...
It's essentially started off with mechanical alignment, and gradually we've been trying to reduce it to a little bit of adjusted mechanical or adjusted anatomical alignment, depending on whether it's a varus or a valgus knee.
Right. So I think most of the panel member here uses mechanical alignment, but in the recent days they've started tweaking it, and that is because of this controversy on the alignment philosophy. So let's understand more about that. The mechanical alignment is a concept where equal load sharing of the medial and lateral compartment is the aim. By keeping the mechanical axis at 0 degrees, achieving rectangular flexion and extension gaps, and then do the sequential releases as needed. It is the gold standard technique because the long-term data supports it. But why this controversy is because of some of the pitfalls. And so we'll start from here. Mudit, tell me, what do you think is the downside? Why people started thinking of alternate philosophy?
So I think it's very clear that the concept of mechanical alignment was based on survivorship. And the concept was that if we place components along the mechanical axis, then we'll have a much longer survivorship. The problem, however, was that we were changing the natural kinematics of the knee. So we were altering the soft tissue envelope around the components. And as we were searching for causes of dissatisfaction, and we looked at many, and after looking at all those, we finally probably thought that maybe it has to do with a change in the natural alignment of the knee, which is probably contributing to this dissatisfaction. And that's why we started looking for alternative alignment strategies.
Harish, what do you think?
I think each human being has a different alignment, a native alignment when they are young and they don't have any obvious deformity in the bones. And when we try to make it mechanically straight, which is logically right because we want to make equal load. So to reduce the wear, that was the logic. But with a better, the component system and better plastic, the wear is not necessarily a very big problem in the knee today. So functionally, if the knee is not too much away from the alignment in which the patient is used to, maybe they will feel better. This is just a thought. That is one of the reasons why those 15 or 20% people are unhappy. I don't think that's the only reason, but sometimes it is projected like that.
Arun, what is your...
The question is why kinematic alignment or...
Yeah, so why, the question is, why did people start thinking of alternate alignment philosophy? What was downside of mechanical axis alignment? Or what was the perceived...
I think Stephen Howell basically was inspired by unis. In unis, you leave it without any soft tissue release, and that's what he was intending to do. He said, why not try it for total knees? And that's how he started using the concept of no releases for total knees. And the idea was to really respect the joint line and the plane of the joint line to try and restore it to what it was in the pre-arthritic condition. And the only way to do that, perhaps, he thought, was don't do any releases and put the implants where he thought they would have been placed had there been no bone or cartilage loss on either side. So if you presume that that's where the joint was to start with, or the joint line, you place the implants over there. Now the whole question, and that's what everyone keeps asking, is how do you know where it was before arthritis if you don't have the opposite side to compare with?
So we'll come to that in a minute. Edward, what you wanted to say something?
So it's my belief, and this all starts with HSS. If you are not experienced with the nuances of ligament balance and you don't get it right, the knee goes bad. And if you're not doing a fellowship with Chip Roundwater or John Insall or any of the great people, and you don't do a lot of them, even myself, if I shoot for mechanical alignment and I have over-release, I have a patient that is unhappy. So the thought is, if you go more towards kinematic alignment, everybody says, yeah, that's more native, but what are they doing? They're not doing big releases, and they're not making big mistakes, and more patients are happier. And that's the way I think about it. Now the question becomes, is mechanical alignment good? And I was always taught that cement can't take a joke. The problem there is if you do kinematic alignment and you make a mistake towards varus, that cement gets overloaded, and you're going to break the cement, and then you're going to have a revision. That's the positive and negatives of the two.
Right.
And that's how I see it.
So I think, okay, Suhas, you go first.
So it stems from two facts. One, the Bellman's paper, where he's shown that none of us are actually straight. There is a slight amount of varus, and Dr. Mullaji and rest of them have shown in Asians, it's much further than 2 degrees. It's around 2 to 3 degrees.
So that same point, yeah?
That, number one. Number two, in mechanical alignment, we all know that we are systematically changing the biomechanics. We're elevating the medial joint line and distalizing the lateral joint line, which then creates the tightness on the medial side where releases happen. So
Hemant, any other point apart from this too?
The natural, mechanical alignment principle or philosophy that we've been following is essentially to accommodate for the prosthetic failures or prosthetic material limitations. That has been historical. Today, I think with Barand's paper of 20% patient dissatisfaction, what I think the whole bandwagon has shifted towards the alignment philosophy, thinking that that is the reason for those 20% dissatisfaction.
Exactly.
I completely disagree with that philosophy.
Exactly. I think so the reasons, the pitfalls which clearly from the panel we can understand that when you do a mechanical alignment, there is a need for ligament release. And at times it can be severe if your original varus was severe. Also, that normal human constitutional alignment is not always 0 degrees. And a lot of people have shown that. Bellman was one of the first. But do both of this contribute to the dissatisfaction rate which we are trying to correct is a question. And my question is this, that although the constitutional alignment for a lot of people was originally varus, wasn't that the cause why that person has developed arthritis? Why do you want to go back to the alignment which has caused... I
think enough longitudinal studies have not been done to validate the fact that more amount of native varus actually ends up causing more arthritis.
Also, the second question to me is that varus was designed to work with 2 cruciate ligaments and a lot of good ligaments, and also with a cartilage which was healing itself over the time. If there was a damage to that, the body was healing, that there was some regeneration that was occurring. Whereas we are trying to replace it with a mechanical implant which has medial and lateral similar design, and maybe a mechanical alignment is the way to go. But I think that is the reason people started thinking an alternate alignment was needed.
You can see how, why, this attraction towards going kinematic or doing minimal soft tissue release. Obviously, it's logical that less soft tissue releases, less pain, rapid recovery. All that can be understood. The simple question is, what are the boundaries that we are stretching for implant failures? And today, historically it's been 3 degrees. Today, I believe they're coming out with papers saying that 6 degrees and 7 degrees of varus on the tibial side can still be tolerated by the newer implants. Question is, With conventional techniques, it's impossible to say whether you have cut the tibia in 2 degrees virus or 4 degrees or 6 degrees. It's possible only with robotics or navigation.
So we'll come to that. So now the kinematic alignment. Any of the panel member has done true kinematic alignment anytime? Yes, Suhas. So
We've done a feasibility study of all alignment strategies, and our experience has been when you put a pure kinematic start point and then when you capture gaps, more often than not, most of the gaps are unbalanced. So in a set of 100 patients, we could only accept pure kinematic alignment in less than 10 patients. Most of them had to be moved out in favor of balancing the knees. So my sense is in our patients, pure kinematic alignment is much difficult to attain as compared to restricted or functional alignment.
So the true kinematic alignment is true femoral resurfacing. You start off with the femoral resurfacing by pure bony procedures with no ligament releases. You remove exact amount of bone that you're going to replace on both medial and the lateral, both distally on the femur and posteriorly, using a caliper. And the idea is to restore the constitutional coronal alignment. But as Arun said, that we just don't know how that particular patient's original constitutional alignment was. So the pitfalls for the kinematic alignment, yes, Harish, do you?
I just want to make a point that in a process of developing from normal knee to the arthritic knee, there is a progressive loss of cartilage and bone and with subsequent contracture of the tissues on the concave side of a deformity. And that's accepted that as the disease progresses, arthritis, the concave side become more contracted and the convex side start getting stretched out. Now, if that is going to happen, the only way or only time when you can actually use the kinematic alignment is in a natural knee, because then nothing is contracted. If you want to use the same kinematic alignment in an arthritic knee of X, Y, Z percentage, then as the arthritis become more advanced, you may have put implant in the kinematic alignment, but you still have some ligament which are unequal. That's what he has just mentioned, that 90% you have to keep on tweaking after accepting initial kinematic.
Unless it's
kinematic is not something which is going to work unless
So
you
I
do it
think-
in a very minimally damaged knee.
So I think we have a panel here who's probably not very happy with the pure kinematic alignment. But yes, like the mechanical alignment, the kinematic alignment had pitfalls. It's sort of a vague concept, at least initially to begin with. There were lack of homogeneous studies. And how do you judge the pre-arthritic constitutional varus? Also, for patients like from India and Asia, the outlier range with severe varus was significant. I think the concept that only the cartilage is going to wear out really probably stays true only for a small amount of varus or valgus. Another point is that the lack of patient-specific implants. The current implants are proven suitable for AMA. Are they good enough when you put in a different angulation for kinematic alignment?
Also, posterior slope too is very different as well, and especially with kinematic alignment if you have a high posterior slope, right?
Right, exactly. So I think, with the current implant trying to do a kinematic alignment, and therefore the long-term data, which is only from Howell, and that too also with a set of patients which did not have a very severe varus or valgus, round about 10 degrees max of varus, and mean deformity of -1. He had more valgus patient than varus in his study. All other studies with a short-term alignment. And I think the key thing, I think, is if the kinematic alignment was good, why would we have more alignment philosophies like restricted kinematic or adjusted kinematic or mechanical, adjusted mechanical alignment? Yes, Suhas.
I think the concept of kinematic alignment is quite strong. What Howell said is if you can recreate these, can resurface the femur, you will recreate the axis. So the problem with pure kinematic is the practical application of how you account for bone loss and how you can account for ligament laxity and tightness that happens.
Suhas, I think the point is not only that, the point is that you will, so let me come to this, that over the time, on the kinematic philosophy, a lot of people started thinking that what is the original phenotype of individual? And if you see, a lot of researchers from 2018 to 21 have described different phenotypes in different ways. The latest being McDessie. And this is what I think, if you look at the 9 phenotypes that he has described, based on only 2 angles, which are very important angle, the lateral distal femoral angle and the medial proximal tibial angle. And I think the concept here is that when the joint collapses on the medial side with varus, these 2 angles don't change. And if you recreate those angles, you're going to get patients' original constitutional alignment back.
Yeah, provided there is no bone loss.
So that is exactly what I'm saying, that the next step after the collapse of the joint is there's going to be a bone loss. And not only bone loss, does panel believe that there's going to be some remodeling of the bone as well?
This is a
It's just one plane alignment, that's a coronal. What about sagittal? You could have another similarly S-pack classification. And then where do we stop? It's very difficult to judge.
Mind you, whenever you have a tibial bone loss, it's never in the center or you don't see one point, especially if it is posteromedial.
So depending on
which
whether
point
your
are you going to
ACL
take
is-
for your MPTA? MPTA can be, construed differently. And especially for deformities that are more than, say, 15 degrees of varus, it becomes more and more difficult to apply the CPAC classification.
So I think the CPAC classification, which is mainly based on those 2 angles, MPTA and LDFA defines arithmetic HKA, which is different than mechanical HKA, and the joint line obliquity. But the problem is this, that here in his study, the normal patients were from Europe, and they had the same distribution as the 500 patients who were arthritic, but this population was from Australia. However, the problem is this, that after that, a lot of people have published, including many studies from India, and the distribution is completely different. With significant varus, this is a study from Guruva Reddy's Suhas Your Center, and if you see the AHK, which is significantly higher compared to any of the other studies.
So we had a discussion with Dr. Megdesi on this, and the Japanese also have proven that there is a precedence that as arthritis increases, there is a chance that you actually jump a phenotype. So it is quite possible that people who started off with type 1 or neutral, as the MPTA increases, those patients get actually pushed towards type 1.
Exactly. So I think that means the LDFA and MPTA is going to change.
Yes. So we had more type 1s and then 4 and 2 as compared to the Caucasian populations who had more, the highest was type 2.
And I think the same thing, Vaibhav Bagaria's study, he's yet to publish it, but is showing a similar distribution as yours.
We have seen our CPAC classification, majority fall in type 1.
65% are CPAC type 1.
Is it that people are jumping the phenotype from 2 to 1, or is it that the type 1 phenotypes are more likely to develop arthritis?
It is not, because we had more type 2s to begin with, but there is progression of arthritis and patient is changing phenotype.
Yeah, I think probably that is true, because I think if you see here in this recent study, which has tried to look at the studies all across the world, and if you see one from India, from again Guruva Reddy's Center, that the non-arthritic patients had 21.1% in type 1, and that jumped to 58.8 with the arthritic knee. What it means is that the concept that the constitutional varus remains the same because of the LDFA and MPTA is maintained is probably not true. Now I wanted to ask you this, that here are, I think we'll quickly go through this. This is the 2 patients with MPTA and LDFA is still in a very minimally deviated state, 86 degree and 87 degrees, and I would probably be happy to cut in line with those. But here, if you have MPTA, which is 7 degree on one side and 10 degree in varus the other side, would anyone cut the tibia into that much of a varus?
So here again the bone loss has kicked in, right? So here, this is where you will let your alignment philosophy drive your surgery. If you're a restricted kinematic alignment surgeon, you will restrict it to an HK of 3. If you're a functional alignment surgeon, you will have a HK of 5.
And what would you do here, where there is such severe gross disturbance. The MPTA is 12-degree varus. LDFA is in 12-degree as well.
Congratulations on trying to measure those on those knees.
No, I think it is. So it is always possible to measure, but it is in such a range that I don't think really this philosophy applies of maintaining that. However, what is important, and when you do a mechanical alignment, of course, this was the guided with computer navigation, you have a long-term results. And I think I'll skip this joint line, which also has another controversy, but I think we have some hybrid techniques, and I think most of us have thought that we would use some form of hybrid technique. All the panel members agreed to that, and I think we have some case presentations on them, so we'll cover those. But basically they are, either you do it on the femoral side, kinematic alignment, or you start from the tibial side, or you restrict your angles with kinematic alignment to be within certain range of 5 degrees. Or most common what is used today is the functional alignment. That means with one of the technology, either navigation or robotic.
Can I make one statement?
Yes.
If you see all these alignment philosophies and strategies, everybody say, I use kinematic or adjusted kinematic, etc., 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 and I get a good balance at the end. So the bottom line of all these alignment philosophies, and I get a good balance, right, without significant release. So I think the important thing is getting a balance. Whether you get it with slight amount of varus or exactly bang neutral, wouldn't make a huge difference to the outcome of the patient.
Exactly. I agree with Dr. Harish. Balancing is most important. Then comes alignment.
So I think that is exactly, I think current probably concept is to get the functional alignment. That means your alignment may deviate from 180 degrees a little bit here and there to favor that you do less and less ligament release.
Unless we actually know the pre-arthritic state, you have to default to a well-balanced knee. I think that's why a balance-driven strategy will work as long as we don't know what is the pre-arthritic status for that particular individual.
Okay, so I think for those who have computer or robotic, you can make those adjustments on the screen. For the rest, I think, let me ask across the panel. Mudit, where do you, so you aim for slight varus for your patients?
So again, because I am using computer navigation and robotics, I would probably be using more of functional alignment, assessing the gaps. I would have, I could go down to maybe about 2 degrees or 3 degrees of varus at the max on the tibia, and aim at an overall HK of about 3 degrees. So whichever way I need to do lesser release to get my alignment in that.
So your target is within 3 degrees, and you first try to do it on the tibial side. Harish?
I think 3, 4, 5 are just the numbers. It depends on what you believe is your maximum limit.
No, what you believe, you tell me what you believe.
3 to 4 degrees, because I do not know beyond that.
You adjust that on the tibial side or on the femoral side?
Usually on the tibial side, because tibia anyway has a defect. So if you get it varus on the tibial side, then automatically a defect becomes less. Overall, it wouldn't make a big difference.
Arun, what do you do?
I think for the vast majority of people who do not use robots and computers, stick to mechanical alignment. For those who have robots and computers, you can tweak it a little bit so that you minimize your releases. For those who are using conventional instruments, in case you end up with a little bit of varus or valgus, then call it functional alignment. Then you'll be all okay.
So we phenotype all our patients. Most of them are CPAC type 1. Then either we use a restricted kinematic alignment strategy or a functional, because both have very opposing principles.
But with restricted kinematic, you're getting worse of both sides. You're getting not completely kinematic, so you still have to do the ligament release, and your components still don't look in a good
We did a randomized control trial in bilateral knees, CPAC type 1, where we did restricted kinematic on one side and functional on the other. On the restricted side, because alignment is sacrosanct, we couldn't move much, so we had to do more release. But we maintained the CPAC phenotype. But on the other side, on functional, which is more of a balance-driven strategy, we had the ability to change the position of the implant. So we had less release, but we changed the phenotype. So we are awaiting the results of that.
Probably for the functional alignment gives you less releases.
Less releases, but you change phenotype.
And yeah, Hemant?
Yeah, I'm using, say, 15-20% of my knees using robotics, and rest are all with conventional techniques. So when I'm using robotics, I'm basically aiming for functional alignment whenever the deformity is, say, less than 15 degrees. Otherwise, I'm aiming for adjusted mechanical. And conventionally, again, you are aiming for mechanical, but again, falling short by maybe 2-3 degrees, and that is what I think we have done for the last 20-25 years.
Yeah, Yadav.
Basically, on femur side, we are same as Ranavat alignment. On tibia, whatever we are doing for minimum release, as Dr. Arun pointed out, do measured resection and take a tibia in little varus. We have our own ways how to achieve varus tibia. Femur same. And we have done CT evaluation, what we are doing by without robo. So in the name of alignment, basically it is a more of propagation of newer technology.
All right, so again, adjustment on the tibial side. Edward?
Tibial side adjustment.
So it's my belief that a good knee is a well-balanced knee. I believe, like Christian Clay has taught, is that I use the Mikulicz line, and I don't want to go to zero because if I make a mistake and go valgus, it's overstretched. So I will go under Mikulicz line by 2, maybe 3 degrees at most, so that makes my releases a little bit less, and my patients are more pleasant with that. That's my philosophy.
Right, so I think I would summarize at the end of the case presentation, etc. But for now, I think we know that what is important is whatever philosophy you follow, the balancing still remains extremely important. Okay, let's have some case presentations on, and we have first Dr. Mahajan. He's going to present a case for mechanical alignment.
Workflow is, hi, good afternoon, everyone. Workflow is mechanical alignment, but not to chase zero. As simple as that. So it's a mechanical alignment, not to chase zero. All cases, computer navigation since 2008, and now last 1 year, well is 100% driven. Patient profile, 66-year female, end-stage arthritis, both knees, pain left more than right, lateral thrust, positive, no deficit, ROM up to 110 degrees, well-controlled diabetes, and good cardiac status. And that's her X-rays. Nothing much different than an Indian patient with a large lateral opening. You can see the large lateral opening, which I think one should consider what to do because it's going to be around 15-20 degrees of varus easily. That's a standard weight-bearing X-rays. That's a clinical picture. And that's Velis robotics, where on the left side, it shows 24 degrees of varus with a 5 degrees of hyperextension. And you can see the middle side is completely tight, 2 and 15 and 4.5 and 13. So that's the tightness on the middle side, as you can expect, with a large lateral opening of 50 millimeters on the lateral aspect in extension and flexion. I use sensor tensor. Once I cut the tibia, here you get a good alignment, good assessment of the rotation of the femur. And that's how the planning was done for the left side. After if you see the tibia is 2 degrees. If you see the tibia, we tweak tibia maximum by 2 degrees in the large varus, not more than 2 degrees of tibia vera. Here 9.5 in the middle side, lateral side, and slope. And the femur, we went for rotation of 13 degrees, but that's a posterior condylar axis, not an intercondylar, they are not epicondylar axis. It's a posterior condylar axis with an extension flexion of 2 degrees. And after that, what we could get was a 5 degrees of varus, but 16 flexion. So we went and cut more of femur. And the last alignment is 2 degrees of varus, 4.0 flexion. And if you see all the gaps, balancing is pretty precise with the left knee. So
did you do releases or?
Minimum release, because if I do the rotation of the femur with a run-out technique, something like that, I have to do very minimal release on the posterior middle aspect. And once I remove a lot of meniscus and the posterior root, it opens up quite quickly. So very minimal release, I would say no, but very minimal release.
The rotation will balance your flexion inequality in medial and lateral gaps.
Yes.
How will it change your extension inequality?
As soon as you open with the robot, what I've seen, if I remove the posterior condylar femur much, what is required, it opens up the posterior capsular part as well. And the root and the posterior meniscus, the meniscus taken, it quite open the extension. With a varus of 1 or 2 degrees, I think it becomes very easy in extension.
Did you need reduction osteotomy?
Pardon?
Need reduction osteotomy from the tibia side?
Part of it, what is required, not really much.
Can you show us the previous slide?
Yes, I will. Sorry.
The one before?
How it go back, please. Sorry.
So I think you had...
Just think it's your robot screen and go back, no?
He has to go back. Yeah, sorry. Yeah, that was the initial planning after that.
Your pre-balance was 3 millimeters and 13.
Yeah.
To begin with. And you gave 2 degrees of varus.
Yes.
So how did you get rest of the correction in extension?
Yeah.
Because your rotation, as sir said...
As I said, once you remove, you don't go all the way posteromedial. It happens. We have the robotics largest series. It does work for us in the way what we do. It doesn't have much of release, but it does open up very quickly.
So here you removed almost 11 millimeters from the femur medially, posteriorly.
Yeah, there's a rotation part.
So that's a huge difference between the
Instead
two
of 9,
condyles.
so that's why, because of if you see the rotation now, if you see the flexion balance is equal now. That's all because of the rotation of the femur. That's what Ranavat block does, isn't it? Ranavat block does the same job. If you do parallel to the tibia, you remove the posterior middle part of the femur.
What surprises me is that with 13 degrees of external rotation, in theory, you would probably be cutting more than 11.
That's the posterior condyle axis. So what I'm saying
I
is...
understand, but normally, even with about 7 degrees of rotation, you end up...
In a bad rotation, in a bad varus, we have to go that much of rotation on the robotics. We've done that, yeah.
So it does look pretty more.
Yes,
13 degree, is that usual, or this is one-off case where you had 13 degree of external rotation?
Bad rotated deformities, we have gone up to that much. Yeah, but if you see if there's one more reading there, if you go for a transepicondylar axis, it comes to 4 or 5 degrees or 6 degrees.
Okay, so very good. I think so here with the assistance of the technology, you aimed for 2 degree of varus on the tibial side and you ended up in the end with 2 degree of varus.
I'll show you the further x-rays. This other right side is 21 degrees, 4 degrees. Here again we have done what is 3 degrees external here. After the posterior tibial cut, we got that planning. And again here we got 8 degrees of external rotation, posterior condyle axis now, not 13. This right side, we did 8. We got the good balancing here. At the end of it, we got 2 degrees and 3 degrees of flexion and 2 degrees of varus. The balancing is good on the gaps here. And that's a post-op X-ray bilateral done at the same time. Okay, so I think I'll show you the scanogram as well. That's a scanogram to see. Any comments on that?
It looks pretty good. I think on the left you are almost 0. On the right probably a degree or 2, but that's very difficult, depends on where you draw the line. Yeah. But yeah, it's good. I think you set off achieving mechanical alignment, but not going for 0.
Yes.
But with technology, you could achieve 1 or 2 degrees.
I have a few slides to go for, a few more patients. But anyway, the literature doesn't show that it's very kinematical alignment is very better than the mechanical alignment on most of the patient series here. Some patients have better, longer walking distance initially and get patterns look like normally, but otherwise there's no difference in terms of the revision, complication, range of motion in most of the studies. So there's no functional advantage as such in terms of kinematic alignment. And secondly, my personal view, most of the patients, our patients, have a moderate to severe varus, 10 to 20 degrees of varus and not like 2 or 3 degrees of varus. Osteoporosis is a predominant factor in India. Constituency varus adds to a varus of that nature. So why change the gold standard and follow the basics, what you've been doing for years, and most of the patients happy. Thank you.
Thank you. Thank you, Dr. Mahajan. We now have Dr. Das.
A quick question for the panel. When we're talking about kinematic alignment, what is the most varus on the tibia you will allow? 3 degrees, 4 degrees, 5 degrees? What's the cutoff?
So let's start. How many people will go up to 1 degree varus? Put your hand up. Okay, would anyone go up to 2 degree of varus on the tibia? 3 degree of varus? 4?
3 to 4. 3 to 4. Just to do less
5?
releases.
We've gone up till 5.
Okay. Well, I go up to 2 max.
So good afternoon,
Okay, Dr.
everybody.
Das.
My presentation is on bilateral TK with restricted inverse kinematic alignment. Now, how it goes? Next. Coming to inverse kinematic principle, it is one of the new patient-specific technique. In this kind of alignment, it is a tibia-fast gap balance technique, restoring the native tibial joint line obliquity, and tibial anatomy is completely restored, but the femoral anatomy, it creates close to the native, both in coronal and sagittal plane. With the following principle, the most important is anatomical tibial cut. It means one has to take equal medial and lateral tibial cut so that the tibial joint line is maintained. Gap balancing then done by the adjusting femoral cords without any soft tissue release, but within a boundaries of 3 to 5 degrees. If it goes beyond that, then you might have to release the ligament. And the final goal is the knee has to balance in extension, and you have to keep slight lateral laxity in flexion. This is my case. It's a 69-year-old female, slightly overweight. She has hypothyroidism, osteopenic. The T-score is minus 1.9. Both the knees CPAC 1, and these are the X-ray, AP, lateral view, skyline view, and the scanogram. Now my balancing philosophy is restricted inverse kinematic alignment. I do tibia first, maintaining the physiological joint line, and before planning, I have to take all the osteophyte all around the tibia, and it's sometimes very difficult to take out the osteophyte from the posterior aspect of the femur. If you use a bone hook, then sometimes it is possible. As I do PS, so I release the posterior cruciate ligament and MCL only up to anterior third. And coming to registration, if the medial tibial condyle is worn out, then you have to take into account the total cartilage loss and bone loss on the medial side. Now, my constraints are, it's a robotic assisted surgery by Valley 3, it's an image-free robot with attuned PS implant. Equal median and lateral resection correspond to implant thickness is the most important step, and slope is also decided by the implant attune, and in PS it takes 3 degree, and in CR slightly more, 5 degree. And femur resection is done to balance in flexion extension by adapting the femoral cuts. No soft tissue is released between the 3 degree to 6 degree boundaries. And these are this is the case, is the initial planning graph. And the knee is bit hyperextending on right side. I planned my tibia. I took 3 degree varus cut. Now you see when the tibial medial side cut in right side is 5.5, that I took into account the loss of cartilage and bone on that side. And in left side you see the tibial cut is around 8 in medial and 9 in lateral. So it is almost towards resurfacing of the tibia. And I add 4 degrees of slope. Now this is with the sensor tensor graph. Again I assess the planning graph, and this is how it is. It is balanced in flexion but slight tight in extension and shows some hyperextension. So in femur I cut less distal, a little bit less in distal femur. I gave 1 degree of external rotation and 2 degree of extension right side. Similarly I plan my femur on left side. And finally, I got the balance graph. Now, what was the initial is the varus was a bit more on left side and less in right side. And the end of my plan, I got a good balance in flexion and extension. And this is my post-op X-ray. Now, retrospectively, when I analyzed the radiographs, then this, the right side, it remains same, the CPAC type 1, and it postoperatively becomes CPAC type 1, but in left side, it changed to type 3. This is just because I added rod, because the bone quality was poor. And this is the second case, where in right knee, again CPAC type 7, and it remains type 7 after implantation, and in left side, the CPAC remains same. Another knee, same CPAC type 1 in right and changed to CPAC type 1 left. This is my inference. Now, these are specific steps and what's critical in success. Anatomical tibial cord is the most important step in inverse kinematic. The tibial anatomy is restored by removing bone and cartilage corresponding with the implant thickness of medial and lateral plateau. Adding extension rod to the tibia or femur may impact final alignment. And the advantages are many, but one is the last one is inverse kinematic alignment. There is less external rotation and better preservation of femoral valgus angle as compared to MA, thereby mechanical alignment, thereby less femoral anatomy modification and tibial joint line observation, joint line orientation preservation. By that way, it preserves knee phenotypes, leading to better clinical outcome and patient satisfaction. Thank you.
So the question is that when you put so much varus on your tibia, how does your tibial rod not hit the cortex on the medial side? You had 6 degrees of varus on the other, one other case?
Yes, sir.
So do you, and then putting a rod, doesn't that become difficult?
No, sir, it was not difficult.
Okay, so good. Any questions from the panel?
I believe that any deformity more than 15 degrees, you should not be trying to calculate these angles because MPTA and LDFA completely are skewed. It's a 3-dimensional deformity. You are looking at a 2-dimensional X-ray and trying to take a point on which you're going to base your measurements. It's completely skewed. So any deformity more than 15 degrees, I think should not be applied.
Exactly. I think any of this alignment philosophies really applies to less deformed patient, which we don't really often see in our population.
So
Okay,
I think
thank you
this
very
CPAC classification has to be taken with a pinch of salt. We've discussed this with Sam McTessie as well, that in our population with significant bone loss, it's not very accurate. Therefore, don't use that. Firstly, it's only coronal, as Hemant said. It doesn't look at the sagittal bone loss, but it's not very accurate. You missed out our own phenotypes, which we published in KSSTA. 4 basic groups, both for varus and valgus knees, which is a little more practical because it also takes into account the extra-articular deformities that we see in our part of the world, which is not covered in the CPAC classification.
I think so, yeah. There are many classifications that I think will apply to differently for our population. And thank you very much, Dr. Dash. We have last presentation from Dr. Jurani on pure kinematic alignment.
Good afternoon, everyone. Let's see if we can do unrestricted kinematic alignment in a severe varus fixed flexion deformity. So this is the patient. You can see that patient has got varus and fixed flexion, both knees, right most severe. These are the x-rays. It's got right PFN also in situ. And we need to remember that the kinematic axis passes through the center of the femoral condyle. When we draw a circle there, the center of that circle, the kinematic axis passes through that. So we don't need to calculate through these angles, but we need to calculate perioperatively that the distal joint line and the posterior joint line are perpendicular to this kinematic axis. This is the deformity, 19 flexion and 16 varus. Now, first of all, we need to see how a normal knee behaves in an arthritic condition. It has, apart from flexion extension, it has got internal and external rotation and anterior and posterior translation. We only focus on the flexion extension of the knee and forget about the internal and external rotation of the tibia on the femur and the anterior and posterior translation, which is restored by unrestricted kinematic alignment. These are the 10 commandments of unrestricted kinematic alignment. The first is cut equal distal femur and distal femur, medial and lateral, including the cartilage loss and the saw curve. So classically, you cut 8 and 6 or 9 and 7, that's what you cut, and you measure it. So don't just keep cutting, but you measure 9 or 8 from the lateral side, 5 or 6 from the medial side, 2 millimeters of cartilage loss, 1 millimeter of saw curve. That will give you a perpendicular distal joint line to the kinematic axis of the knee. So that's how you calculate the distal cut. The posterior cut, the interepicondylar axis, the insole boot are of no relevance. The important thing is you cut equal posterior medial, posterior lateral, 8 or 9 millimeters, equal cuts without looking at any other rotational landmark. The tibia cut, you need to lateralize your jig by a centimeter to give adequate varus if you are doing conventional instrumentation. When you lateralize your jig by a centimeter, usually give 2 to 2.5 degree varus and 6 to 7 degrees slope to replicate the kinematic axis of the knee. and you measure from the tibial spine, not from the worn area. The medial and lateral side of the spine should be equal, 8 and 8 or 9 and 9. And once you do that, these are the way your cut should look like. 8 and 5, 8 and 6, posterior medial, posterior lateral equal, and tibia from the tibial spine has to be equal. This will replicate the pre-arthritic joint line and also reproduce a trapezoidal flexion space with an intact posterior cruciate ligament. So the lateral flexion space has to be little lax, 1 or 2 millimeters lax. The extension space has to be absolutely rectangular and well balanced. So you see there is extension balance, it's not negotiable. It has to be parallel and equal. The flexion space has to be trapezoidal with retention of PCL. For the flexion part of the deformity, you need to release the capsule and not cut any additional distal femur bone. Once you do that, you don't need to downsize. There is no formal ligament release. So the MCL is sacrosanct. You don't touch the MCL, you don't pie crust, you don't downsize. Because when you downsize, you tend to external rotate the tibial component. So your rotation has to be, both components has to be rotationally aligned. And there is no formal soft tissue release medially. So there is no pie crusting, no downsizing, no semimembranosus release. When you do all of that, you'll reproduce the offset which is between the femur and the tibia, usually 8 to 10 millimeters. Measure it before you start your cuts and reproduce it after the trials. And once you do all of those 7, 8 steps, you will beautifully restore the internal rotation of the tibia on the femur. So remember, the knee moves in 6 degrees of freedom. It's not only flexion extension, but it's internal and external rotation. The medial pivot has to be restored, and there has to be no anterior drawer. And once you do all of that, your patella is going to track beautifully. So see how beautifully the tibia will internally rotate, and the extension space is not negotiable. There is no lateral laxity even after such a severe deformity, and no ligament release. And you'll see that the patella will track beautifully, not because you externally rotate the femur. External rotation of the femur has got nothing to do with patellar tracking. Patellar tracking will be reproduced once you reproduce the Q angle by giving adequate valgus on the femur. And when you do that, your patella will track beautifully. The restoration of the internal rotation of the tibia on the femur is also a great adjunct to ensure your full flexion. We have overemphasized this straight line that we keep drawing. See, 2 to 3 degree varus on the tibia doesn't make any difference. In fact, it's an adjunct for gait. And once you take a single stance, the joint line is parallel to the ground. And this is the patient walks to 1 or 2 degree of hyperextension of the knee, which is good for the patient for the stance phase of the gait. And lastly, when you take a fluoroscopic view, the patient has got no condylar lift-off and a nice femoral rollback. So gentlemen, please try and reproduce, replicate the normal kinetics and kinematics of the knee by following the 10 commandments of unrestricted kinematic alignment. Thank you very much.
Anup, 2 questions to you. One, was this patient a fully correctable deformity, varus?
It was partially correctable, yes.
Because I think if it is a correctable deformity, I think your cuts are going to be okay. But if you have a deformity which is not correctable, and your cuts are going to be lesser on the medial side, it is going to leave, it's not going to be a gap which is going to be balanced medially and laterally.
It is going to be, Dr. Maniar.
In some cases it may be, in some cases. That is one.
If you determine not to do any ligament release, you take more varus on the tibia and it will be perfectly balanced in extension.
But you've not taken much of a varus cut here. Very
taken
little.
3 degrees, yeah.
And the other this thing is that, do you believe that even with this severe deformities, there is no remodeling or the change in the femoral alignment from the original alignment has occurred? Now you're taking out 9 and 9 millimeter or whatever equal in an arthritic bone which has remodeled into a deformity. And you are following that. You're not following the 9 millimeter which was original.
So in this case, when you look at the condyles have not remodeled unless there is big hypertrophic.
So how do you judge that? That this patient's condyles have remodeled this one has not. How do you know that?
Both by the X-ray and by opening the knee, you exactly know whether the condyle is remodeled or not.
And so what do you do if they are remodeled?
And you adjust the rotation. Then you still decrease your rotation to cut equal posterior medial and posterior lateral.
Okay, I think...
One point, as he mentioned, rectangular even in the extension. What we do practice, even if laterally, even in extension, little laxity is there. And it doesn't causes any problem. Even little laxity in extension or even in flexion, it increases the range of motion. So it is, even if it is not like that rectangular in extension all the time. It may be little lax.
1 millimeter lateral laxity is acceptable, but more or less it should be well balanced in extension.
Edward?
Anup, I love your passion about kinematic alignment, but I have this question. If the ACL is cut and you do good balance, is there any implant that will recreate the native rotation of the knee?
So the normal rotation ACL intact is 14 degrees head. After taking off the ACL is 10 degrees. When you take off the PCL also, it reduces to 4 degrees. So PCL retention, our ACL is gone in arthritis, but PCL retention reproduces 10 degrees of internal and external rotation of the tibia on the femur.
How often do you have a normal PCL, especially in an Indian woman who has a varus deformity of 20 degrees?
90% times.
Okay, I think we have, thank you very much.
I
Anup.
agree, PCL is always intact, even in the severe varus side.
Thank you, Anup. Excellent presentation. We have 5 minutes for the question and answers. So please come up to the microphone and...
So I'll ask the first question. Rajesh.
Yes.
I think, I'm a little more confused after this session, to be very, very honest.
I think if you
I will give you a summary.
Parag, ask the audience how many of them are also confused.
So they are clapping maximum now.
I always say makes things simple.
So Rajesh,
always say.
I think I'll
summarize, and even Dan Berry is going to run the next session. I'm sure by the end of this session and the next session, when we go home on a Monday morning, when we do a TKR, we should have some clarity on what we should do.
I think there is a clarity here in the sense that the mechanical axis alignment that we've been following is a gold standard and is something to go by. However, we do need to think of the alternate alignment that has come up in last 15 years or so, because it will allow you to rethink whether you should chase zero or not. You can be in some amount of varus, and okay, if you have to do less and less ligament release. I think that is the take-home message.
Most important, less and less release.
Yes, I think the point is this, that trying to get your knee aligned and balanced, both are important. If by tweaking your alignment from 0 degrees to slight varus, that is 1 or 2 degrees or 3 degrees of varus, which you go according to your philosophy, is going to reduce your ligament releases, then think about it and do it. I think the other take-home message would be that pure kinematic alignment or all these phenotypes that we're talking about are not constant. And that is why we have so many of those studies. And therefore, I don't think you can think about it, you can read about it and follow it, because in next 10 years you might hear more about it, but I don't think you need to really divert too much and go after that. Ashok?
I think the most important point that you missed out, besides the fact that implants may survive kinematic alignment, the question is the implant fixation within our type of bone going to survive that alignment? I think that is the key.
Very good.
Implant poly will work, the implant material will work, but whether that composite within the bone is going to survive this alignment.
Yeah, I think the implants are designed for mechanical alignment, and you need to take care, understand the quality of your bone. And I think Edward said that earlier, that most of them fail on the tibial side. So whether to make that 1 degree or 2 degree of varus on the tibial side or on the femoral side, also a key question.
But again, Rajesh, with cementless components coming in, the whole equation may change, because then that fixation becomes a more sound fixation. Here you're dependent on cement, which can fracture over time and lead to debonding and loosening.
Malaji, we've been through that in the US. We went through cementless implants, and then we had stress shielding on the edges. And so then you have loading in the middle.
Yes, I think the
You have
cementless
that
implants
problem. So
still
I don't
has to
know.
prove that itself. Okay, Ashok, go on. Quick question.
More than a question, a comment. I think all these alternate philosophies of alignment came on because Phil Noble in 2006 spoke about this 26% dissatisfied. Gil Scuderi has published, it's now down to 5 to 6%. At the end of the day, my question is, when you remove equal distal and posterior in a severe varus knee, and we're talking only on varus knee, if you take equal amounts of bone posteriorly and distally, inevitably you're going to be converting that into an internally rotated femoral alignment. And when we talk about soft tissue releases being minimized or being compromised by a slope on the tibia, explain to me how you get to the posterior osteophytes without releasing those.
So Anup will probably explain that to you a little later, because I think we have, but your point is well taken, that these are the things which are tweaking.
And one last point, does changing alignment improve outcomes?
And I think
it does not. I don't think it does. It has stood the test of time. I understand you do minimal adjustments in whichever way, you adjusted mechanical or kinematic or whatever. But the very fact that kinematic within itself has changed 5 times in 12 years is testimony to the fact that it's not a stable alignment.
Right. There is enough evidence to show that if the obliquity of the joint line is maintained, between the CPAC type groups, there is an RCT in JOA which has shown there is much better forgotten joint score as compared to the situation where the joint line obliquity was not maintained.
And
calculating for the short term, though, only for the short term.
Calculating the joint
line.
line.
Wait till 10 years, wait till 15 years, and see what happens to that bone and cement.
Ashish, last question for us.
So talking about again this putting the tibia in varus, when we have someone said that we can go up to 4 or 5 degree varus. Now that will load the medial tibia too much and not load the lateral tibia after the implantation. Can we not adjust little bit of varus in femur? So a degree or 2 in femur, 2 or 3 degree in tibia, and get the tibia at 3 degree and femur at 2 degree.
So I think that is one of the philosophy, that adjusted mechanical alignment on the femoral side. So you can do that, and it's up to you to decide what you want to follow, right?
Just one comment I wanted to make, just one comment.
I think we are...
If you see this, this controversy about alignment has done very good to all our fraternity. Because you can do TKR the way you want. End of the day, evening you get a post-op X-ray. If it looks varus, look at it and just say, oh wow, what a great alignment. It's kinematic and patient is impressed.
Well, thank you very much with that note.
It doesn't matter what you do.
I don't think you aim for doing that. You achieve what you want to achieve. Don't listen to what he's saying, Harish. Okay? That's your aim should be. Well, join me in thanking the panel for a absolutely super discussion and the presenters.
Thank you so much. Thank you, Rajesh sir, and all the panelists for such an engaging panel discussion. May I have all the panelists and the moderator for a group picture, please? And up next, we have the session 6, the use of a robo in knee replacement surgery. May I call upon the moderator, Dr. Daniel J. Berry, and the panelists for the session. That would be Dr. Vaibhav Bagaria, Dr. Alberto Kali, Dr. Chandrasekhar P, Dr. Thorsten, Dr. Anup Jurani, Dr. Mahesh Kulkarni, Dr. Rajesh Manyar, Dr. Amar S. Ranawat, and Dr. Sachin Tapaswi.
All right, let's get the panelists up. I can see everybody's getting organized. I can tell you, after listening to that last session, I've never seen passions run quite so high about 2 degrees of alignment, but that's what it is. So we're going to have a good session this next session. It is fair to say that robotic surgery has probably created more interest than any topic in the last 5 years in knee replacement, and it's also probably fair to say that it's created more controversy than any topic in the last 5 years in knee replacement, notwithstanding the alignment controversy, which is partly brought on by the fact that robots are available. So I'm going to introduce our panel and just ask everybody to introduce themselves, running down the list very quickly, and then we're going to get on with this session. I've got about 10 or 12 questions to ask the panelists about robotic surgery. Go ahead.
Hi, this is Vaibhav. I am from Mumbai.
Yeah, Mahesh Kulkarni from Pune.
Rajesh Manyar from Mumbai.
Dr. Chandrasekhar from Bangalore.
Anup Jurani, passionate about kinematic alignment.
We noticed that.
Alberto Carli from
I'm kind of scared, in fact, Anup, after that. Jesus, you looked so serious up there. My God. I was like, oh, has he got my panel? Oh, hell, he is.
Sachin Tapasvi, Pune.
Amar Ranawat, HSS.
All right, okay, we got a tremendous panel. We've got some good questions, and we're going to have some fun here. And if not, we'll serve the appropriate panelists a drink. We'll see how it goes. My disclosures that I received royalties from DePuy on some hip and knee products. So this is my first question to the panel. We all agree that there's a lot of interest in robotic surgery, but let me ask you, what's driving the increased interest and adoption of robots in knee replacement? Is it companies that are driving it because they want to sell them? Is it surgeons driving them because they want to sell something? Is it surgeons driving them because they think there'll be a real change in what they can do? Is it surgeons using it as a form of marketing? Give me your opinions. There's probably some others. Let's start with Amar.
Marketing.
Wow, that was a concise answer, and it might be true. Okay?
I think it's the quest of trying to find what works best and most consistent.
Okay, so Sachin, you think that it's a new tool that might let you do new things more consistently. Is that what you're going to say?
Please.
Okay,
Yeah.
fair enough.
Marketing and then achieving a consistent outcome.
Okay, so you think it's a little bit of both?
Giving us a lot of data points, especially on flexion kinematics, the initial deformity, and our ability to do alternate alignment more accurately with robotics.
Okay.
Switched over from navigation to robotics, so interest was purely not marketing, for delivering the same result to each patient all the time.
So you want consistency?
Yeah.
Okay, Rajesh?
Consistency, the slightly two different things for in USA, where the computer navigation was not so commonly used.
Yeah.
I think a lot of people are getting to it because of the correct alignment that computer can give, which is part of the computer navigation is part of the robotics. But everywhere else, I would think it is the consistency of what you want to achieve that is driving it.
Okay, fair enough. And is there any element of the ability to make minor tweaks that are hard to make with manual instruments?
Yes.
Yes, you think so? Okay.
I agree with everyone. Marketing followed by consistency, but marketing is losing its ground because the city like Pune has become a robot neutral city. Everybody has one.
Yeah, once all the companies have one and once everybody's got one, then the marketing element goes away, right? Okay.
I think science, number one. I know I'm contrarian to everyone here.
Yeah.
Number one, science. Number two, art. Number three, commerce. When you have all three, thing wins, and it will win. And you shall see it 10 years later. Science, because it gives us ability.
It's going to win practically because everybody's got one. The question is, will it improve outcomes? But we'll get to that.
Yeah, so science, yes, because you will see, you have got the next questions. We'll tell how science addresses it. But I'll talk about the art. We are all craftsmen, but any tool that makes us better craftsmen is appreciated by all good craftsmen.
Fair enough.
Commerce, anything that drives up your volume will succeed. So all three, science, art, commerce.
All right. Well, we'll see about that. Okay, let's go to the next question. What are the main capabilities that a robot provides that manual instruments do not provide? Let's start on this end of the panel on brief, consistent questions.
Number one, fun. Number two, my ability to deliver what is best for the patient with less soft tissue release, with the titrated alignment philosophy, which I call intelligent alignment, to solve the problem of the last session. So ability to deliver an intelligent alignment, ability to reduce soft tissue release, have more fun in OR, more consistent, less blood loss, and of course, more patient volume.
I see you're a believer, okay.
I think it basically an experienced surgeon and a young surgeon with a few number of robotics. I think a younger surgeon will bring the alignment faster and he will learn the alignment very much faster.
So you think that for
shorten the gap.
So the inexperienced surgeon will get to the level of an experienced surgeon quicker because they've got a better tool. Is that your argument?
Exactly.
Fair enough. Rajesh?
I think the consistency in getting the alignment and tweaking that alignment, that is the key reason I think this, that is what it gives you.
So the ability to fine-tune something that was hard to fine-tune before in a scientific way, is that your point?
That's right. And the second is to know
I have to interpret sometimes.
So that's for the alignment. And for the balance, it gives you an idea beforehand, before you make your cuts. Just after making a tibial cut, You put your tensioner and take your balance graph, and it gives you an idea what is going to happen.
So you can do something before you commit. Is that your point?
Exactly. And at each step, you can do that after a anterior or posterior cut of the femur. Again, you can check your balance and you can tweak. And all the recuts that you can do with Robo is just super. You can go through that very quickly without taking much time.
Okay, fair enough.
Adding down to the same points what Rajesh and Vaibhav said, dynamic joint balancing. You can start as a mechanical guy and switch out to a functional guy on tables. You have all the options. Tweaking those 2-degree varus and femur and tibia is not possible on conventional instruments.
Yeah, it's hard to do it.
Proof at every calibration at 0 to 120 degree. So that's the reason why I switched out robots.
Fair enough.
Unquestionably a great asset for uni-compartmentals, no question.
We're going to talk about the unis eventually, yep.
So for the sagittal plane, its manual instruments don't tell us anything about the flexion of the femoral component. So the flexion of the femoral component and the slope of the tibia is far more accurate with robotics.
Fair enough. Alberto.
Image-based robotics helps you preoperatively plan. That's the main advantage. Otherwise, it's another more complicated way of verifying your alignment. That's the only benefit I can see.
Okay.
So I think the capability is preoperative registration, planning, post-operative confirmation that you've got to the correct place. And I think the second capability is not needing to open up the intermediary canal on the femoral side.
Okay. Do you think that matters really?
It doesn't really matter, but that's the only capability.
Okay, fair enough. Amar.
I don't think there's any advantages.
Okay. We know where you stand. I know how you're going to answer a few of the other questions later. That's fine. Thorsten, anything to add?
Yeah, I mean, it's nothing, but probably better intraoperative control what you are doing.
Okay, fair enough. Who wants to take this? We don't have to have everybody answer this. I'm just going to ask one or two people. Rajesh, can you give us a quick rundown? What are the main differences between robotic systems? Let's not have a marketing talk. Just give us scientifically what are the main differences. 2 or 3 points for the audience.
Burr versus saw.
Burr versus saw. Okay, fair enough.
That is the most important difference.
Okay.
The second is whether the bulky instrument is attached to your table or is it separate and giving you room.
So the exact configuration of the robot itself, fair enough.
Otherwise, most of the system will give you exactly the same, the alignment, the balance, the ability to tweak all the three, both the components.
Let me ask about 2 other ones. What about haptic boundaries?
Haptic boundaries, so autonomous versus semi-active.
Yeah. You can ask whether that's good or bad, but some people, there's both.
And image-based versus imageless.
Image-based versus imageless, fair enough. Anybody have anything else to add? I think those are the main ones, and they're the ones to be aware of. We're not going to say that one's better than the other, and there's obviously competition between different companies that provide different assets, but they are different. All right, so let's start with the next question. Which types of cases might benefit most from robot use? So Thorsten, I don't think you're using the robot, but if you think about it in your hospital, you're in charge of many, many surgeons. There's thousands of cases done a year. Which cases do you think might really benefit from this technology, if any?
If there are cases, and I think, complex deformities.
Okay. So you think it's going to be the complex cases, not the simple ones that...
Complex cases, complex deformities, and several levels. So.
Fair enough. Amar?
I mean, I don't think you need it for any case.
Okay.
So yeah, that's...
So you're not a believer, we know that. Okay.
So I think it's 2 sides of the spectrum. It's most beneficial for those very mild to minor deformities where you really don't need too much of a correction, and for those who have an extra-articular deformity and retained hardware.
So you think it's the 2 edges?
Absolutely.
The patients that are more or less undeformed that you want to just tweak and dial in just that last half degree, and then the rest of the ones with a huge deformity where you want some help.
Absolutely.
Okay, Alberto?
I would tend to believe that image-based robotics is probably the most useful for me. So that would be a complex case where I need to get a CT scan for preoperative planning. That's what I find this to be the most useful.
The sort of situation where standard instruments are kind of hard to use and you're doing a lot of Kentucky windage. Yep,
But you need to use it every day to be able to use it in a complex case. So do 1 case every day, 2 cases every day for you to be able to do that complex case.
Okay, so if you're not doing it all the time in easy ones, then you can't do it in hard ones. Is that your argument?
That's right.
Might be true, okay.
Image-based robots, so definitely complex primaries helps.
You like it complex?
Also in the moderate OA, if you are planning for a kinematic, it helps. So doing every day, one or the other philosophy helps to get
So
a
if you have a kinematic philosophy, it might help you more than if you're a mechanical alignment person. Is that right? Amar's going to argue about something, I think.
No, just, you know, if you're going to operate every day, you definitely don't need a robot.
Okay, fair enough. Rajesh?
I think every case is going to benefit with the robo because of the computer navigation giving you the alignment. However,
So you
I
like
would
the
say,
you like the precision of it.
yes, I like the precision of that. And the only time where, you know, in a mildly deformed case with not much of a remodeling of the tibia or the femur, you are not likely to be in an outlier zone with the conventional instrument. So that's okay.
If you're an experienced surgeon, right? Fair enough. Okay.
If you believe in alternate alignment philosophy, then each case is considered to be a case for
Yeah, I
robotics.
agree with that. If you're going to try to start deviating much from mechanical alignment, then it probably helps you more.
You know me, I'm a believer, so I think it benefits all cases, but primarily extra-articular deformities, those with retained hardwares, being at the cost of being dogmatic, all unis, and all those where you are choosing to have an alternate alignment philosophy or leaving constitutional varus.
Okay, so it's interesting. There was actually more consensus there than I thought there'd be, and the big consensus was around tough cases with big deformities, especially extra-articular deformities, people that are using alternate alignment philosophies on a routine basis, and then we'll get to the uni question, but that's probably true too. Okay, under what circumstances is it worth learning robotic methods? So there's a lot of surgeons out here. Some of them are doing, I would guess, 10 total knees a year. Some are doing 500 total knees a year. Some are at the start of their learning curve. Some are well into it. When is it the right time to think about it, or is there always a right time to think about it? Thorsten, you want to say anything about that? You control a lot of surgeons.
I mean, it's always worthful to learn something.
Okay.
And I think it's good to learn it and at least to judge about it.
Okay. So if you're going to talk about it, you got to try it?
Exactly.
Okay. Amar?
You know, I think we have 9 Mako robots at HSS, and I don't know how many other systems that we have. But when we asked our fellows a couple years ago on their exit interview, they all basically said that their experience involves too many robots.
Yeah, most of the fellows in the US right now are looking for more experience with manual instruments because they're afraid they aren't going to know how to do them pretty soon. Sachin?
Yeah, I think, you know, it's definitely a worthwhile exercise to learn what the robotic technique or technology will be, because believe me, in about a decade of time, we'll have something which is more AI based, and probably you don't want to be left out when the whole world is progressing.
Yeah, there's no doubt that it's going to be a big part of practice, right? So if it's going to be a big part of practice from the practical standpoint, it's helpful to know something about it. Alberto?
Nothing else to add, I agree.
Okay, fair enough. Anoop? Nothing more?
An youngster, if he wants to be a robotic surgeon, I would tell him to be a good conventional surgeon for initial few years, train them in navigation, and then proceed over to the robotic.
I think that's super important.
Don't jump into the robotics straight away.
I don't have a question about that in here, but the whole education element of robotics is a little bit concerning, right? And it gets to the points that were made earlier by Amar, that with the pervasiveness of robotic surgery becoming very, very common in some countries, it's going to become common here. The concern is, will surgeons ever learn to do a good manual instrumented implant? We'll get to that point in a minute about your bailouts when problems occur. Rajesh?
I think the basic training is the most important part, the conventional total knee arthroplasty. However, if I think a resident has seen a number of robotic surgery or the navigated surgery to begin with, he can jump into that because it's a different aspect. It's alignment. And I think going back to manual instrument shouldn't be a difficult task anyway.
Except they have to know how to use a saw.
Definitely, I would say for a young surgeon, learning manual surgery is utmost importance.
Yeah.
But for an arthroplasty surgeon, you cannot not do robotics.
Okay.
I'll quote Alvin Toffler here. The ability to learn, unlearn, and relearn is a superpower. So they talked about younger generation. I think the older generation should learn it.
Future
Bring
Shock,
much more
Future
value.
Shock by Alvin Toffler. That's who you're quoting, right?
They'll bring much more power to the robotics if the older generation learn.
Fair enough.
Experience and technology within combination.
So all of you, virtually all of you said that there's some value in learning robotic techniques in the coming decade. How should somebody do it? Should they just go to a course and learn it in a half an hour or 45 minutes, or do they need to go visit people, work on it, practice, use cadavers? What's the right way to learn it? Let me just ask a couple people who've gone through it. Rajesh, I'm going to ask you first.
I think, and this is the most important question, because the learning curve any procedure has. With the robotic, you have a chance to reduce your learning curve by 80% even before starting the operation. And that's exactly what you pointed out too, that you should understand it, learn on the sawbones, then maybe do it on the cadaver. Just attending the meeting is probably not going to be enough. In fact, it's going to be confusing. It's only when you start using it, you know what steps to take. And so I think you need to go through these phases. You need to see someone, understand the concept, and go through training.
So can I ask you your opinion on that topic?
So visit.
Okay. Go to surgeons that are doing it.
That's right.
Is going to a company course enough or not?
Sorry?
Is going to a course run by a company enough or not?
No, that's not enough. You need to go to the OR, talk to the surgeon, sit and discuss the planning, see a few cases, and then start doing.
For young surgeons, they can do fellowship programs where the robotic programs are done regularly. For the guys who are already having good numbers, they can do visitation, senior one-to-one visitation, and learn from them.
I think that's well said. I mean, people in training are going to get the training and training. It's people that are already out of training that are thinking about a new technology. That's the group that's going to have the toughest time, I would think. Sachin, anything else to add?
Yeah, I think so. I mean, I completely agree with you. Since I do a lot of sports preservation and replacement as well, I've learned a lot of new techniques, but learning robotics and trying to master that has been the toughest skill set of them all.
It's been tough.
It's
not
been
easy. Why has it been tough? I'm interested that you said that.
So the reason being is that when you're good at conventional surgery, or so-called you feel that you're good at conventional surgery, suddenly you have all these numbers that are thrown into you. You have all these new alignment techniques that are thrown into you.
Yeah, and you suddenly got a lot of data you never had before, right?
Exactly. And then suddenly you start feeling, am I making the right move? Am I doing the right thing? And then you get too engrossed in looking at the screen, and then you start forgetting to look at the actual knee per se, which is where you're trying to drift away, and you need to really refocus to try and bring yourself back on track, to understand that, you know, it's actually the clinical field that matters more, and you need to actually learn to disregard some of the numbers.
Yeah, it's not a video game.
At you.
So that was really well said. I hope all of you heard it. That was terrific, Sachin. Thank you. Okay, now here's my next question for you. What are the main technical problems that you as a robotic surgeon have already encountered or are afraid you may encounter using a robot? Let's start at this end of the panel. And let's have some honesty here.
No, I'll be very honest. So there are problems with both techniques and technology. So if you talk about techniques, again, getting adapted to all those numbers, as Sachin said, it can be a bit mind-boggling. The ability to manage the OR in terms of visibility of tracker can be an issue. Of course, we know about pin track issues, which is a given, but sometimes even the robotic arms, just like any software, can get jammed. So the ability and the confidence to switch on from robotic to mechanical, again, is an important thing. And you made a very valid point that you must learn both. So if your auto mode driving fails, you should be able to take care of the steering yourself.
Yeah, and I'll just go one step further, that you need to know when things are going bad with the robot, right? So that's the other element, right? So there's one, to know how to fix it, but there's also the element to recognize it. And we've already seen some problems in North America where surgeons blindly followed the robot after the arrays got loose or something like that and did some really stupid, bad things. I'll just tell you. Yes, sir.
As you just mentioned, I think loosening of the trackers as well as losing your checkpoints.
So how do you make sure, how do you recognize that problem's happening, and how do you look out for it and avoid making a catastrophic mistake? Because if the tracker's loose, I'm sure the audience understands, you can suddenly be way, way off, not a little off, way off.
Always watch what you're doing. You need to have the experience to understand that the robot is not doing the right thing.
So if you're cutting 2 centimeters off the distal femur, something's wrong.
Yeah, and also there are enough alarms in the robotic system that I use, which will allow, which will basically tell me that something is off. It wouldn't allow me to progress, especially.
Yeah, you hope so, but remember what happened with the 737 MAX, right?
Exactly.
The alarms weren't always right. Okay.
So I think the pin loosening, and I think that's why I don't bypass the step of checking the point. And that's a very important.
Okay.
The second thing is that you always have to go back and forth. When you start using this technology, you may have to go back to cadaver or to the sawbone and understand something that you did not see first time. So it's going to be back and forth to the sawbone.
That's an iterative learning process. Great.
And also going to a surgeon and asking him what happens when such a thing happens.
Yeah, so you definitely want to know that before you get into the operating room by yourself, right?
Exactly, but so even after you started doing it, you might have to do it.
Yeah.
But if you remain with it, you're going to get there.
Okay.
It's not. It looks difficult to begin with, all these numbers, etc. But once you start, I think you need to sit and break it down. What is important first? Which numbers are important? Only follow those.
Yeah, be careful not to get overwhelmed by the data.
Patience when you're venturing into robots, because you have to just let your ego down and then say that I am not going to finish this case in 20-25 cases. Initially it takes time. And then
so a little patience with yourself.
And then also establishing the team in the OR is very, very important.
Good point.
For high volume surgeons, it's very difficult for him to sit, calibrate on the table. So you need to have a strong team who will take over, moving the robots within the system, having patience. And third, most important is pin loosening, third. And the fourth is whatever the robot shows, the numbers is what the surgeon has on the brain. So ultimately, whatever you feed to the robot, it does what you feed. So most of the times it's a bit tough initially, but don't believe the numbers if you feel that you are complementing your work yourself.
Fair enough. Anoop?
Measure the cuts always, and keep checking and verifying that you're right. If you're way off, then something is wrong. Then you need to re-register.
So that's a really good point. Double check based on common sense and your knowledge of what things should look like, right? Alberto?
So as my experience with image-based robotics, definitely registration can be a nightmare, especially in the hip with bad bone and loose arrays.
So be careful about the registration.
Extremely careful. And the knee maybe not so much, but the hip especially. And then obviously soft tissue assessment. When you go ahead and correct your varus deformity when you're doing a uni and you're using an image-based thing like a Mako hip, for example, and you correct the knee to neutral and then you flex that knee, once you get past 45 degrees, the entire knee becomes disconnected. I've seen expert surgeons in my institution who do this day in and day out, and I ask them to do that tracking again, and then do it again, and do it again, and on 4 times they got 4 completely different waveforms. And the rep every time said, "Looks great, doc." And that information is what the robot uses. So I don't think the robot really understands soft tissue data, and we have no idea what we're doing when it comes to letting the robot trust us with that. So that's my main concern.
So we're a little on the early days on that side of things, not as far along as some people might like to pretend. Sachin?
Yeah, I think I really echo Alberto's statement there. That exactly is the main problem that we really face.
Okay, fair enough. I'm not going to ask the last two because they're not doing robotic surgery routinely. Okay, what's your bailout and how do you identify and prepare for the time the robot's wrong? Sachin, let me ask you to start with that. Let's make these kind of quick because we have a few more questions to get to.
So I think the bailout here is to have all the conventional instrument tray ready to have a backup.
So you got to have them in the operating room and you got to have them available.
You have to have all the instruments open
100%
on
of
the
the time.
table. Yeah, 100% of the time.
So this idea that the robot suddenly gets rid of all those instruments is not quite right.
Absolutely not.
Okay,
yeah.
Fair enough.
So that's one, and you also need a higher constraint backup, just in case, you've done some crazy thing with your robot. You need to put a rod up or down the stem, you need to put a stem on, then I think that needs to be ready as well.
That scares me. So bring a hinge every time you use the robot? I don't know. Okay, Alberto?
Agree with everything Sachin said, and then for a robotic uni, once you've already made the cuts and you realize something's wrong, there is no bailout. So you're in real trouble there.
Okay, we're going to talk about that in a minute. Anoop, anything else to add?
No. Conventional standby always.
Always ready.
So conventionally standby, but say you're doing 3 or 4 cases, you don't open those.
You have them sitting there ready to open. Yeah, fair enough.
Second thing is we need to ask question that how many times did you actually need to bail out? In the navigation that I can't remember in the last 10 years that I've needed to use a conventional.
Fair enough. So it's not a common event, but if it happens, you got to always be ready, right? Anything else to add, guys? No. Yes, Amar.
But you never ask what's your bailout when your conventional instruments don't work, right? My point being, if you really think of yourself as a knee surgeon, you should be able to do the knee placement without any instruments, just a saw, right? If you can do a reasonably good job, it doesn't have to be perfect, a reasonably good job with just a saw, then you're a knee surgeon. Yep. Then you know fundamentally what you're doing.
I don't disagree with you, but I promise you that if you ask everybody in this room to do a knee replacement with just a saw, we would see some very interesting x-rays. We're going to get to questions later. Okay, my next question is, how do you and your hospital make the economics of using a robot work? They're expensive. Let's start with a guy who's got to run a hospital, Thorsten.
So in Germany, everything is extremely cheap. So our benefit to put in a knee replacement is about 800 euro per case for the hospital. If I use a robot, I pay about 900 euro for everything.
Okay.
for the robot, for the stuff around the robot. So the hospital in Germany actually doesn't earn money by using a robot. You lose money. That's the reason why the robots in Germany are not really frequently used.
Do people like to use them because they get the market share, so they get patients into the office?
The only reason is to attract patients, to be modern.
Okay,
and,
yeah, right, to see like, okay. Sachin, how about you?
So I think, there are a couple of various commercial models, how robots work in India. And I don't think this is a forum to discuss those commercial models. But typically, if I put a split in the Indian patient database that we have, there are patients who are self-paying and those who are insured. Currently, about 90% of insurances do not allow robotic joint replacement surgery. So the patient has to pay out of pocket, and the note has to go in the official case file that you've done a conventional knee replacement. Otherwise, they don't get reimbursed for the conventional 100%.
In India, is it common for the companies to give you the robot, assuming that you'll do a certain volume of their knee replacements, or not?
I think that's classified.
Really? Because I can tell you categorically that's happening in the United States, and that's not classified information.
I guess it does with some companies. The ones which I use, probably, at least I don't work on that model.
Okay, fair enough. Other comments?
To be fair, they give away a robot to one guy in town and make the other guy buy it. That's how they do it.
Well, if they're giving it away, you can be guaranteed that they're doing it for a reason, and the reason is they want to sell you the implants at a high price because you're now locked into using the implants. So there's no free lunch, right? Rajesh, any other comments? Comments from the art, science, religion side of things?
Good. Yeah, so both art and science. So coming to the point, marketing alone without good art and science will fail. Time immemorial has shown that a product only being sold for marketing will not work.
Okay, fair enough.
It has to be backed by art and science, and that will make the economy work.
The length of stay can be reduced with the robotic surgery's length of stay. One, we can save the cost there, but not the medical.
The data on that are a little soft, right?
Also, the instruments which we open on the table, we don't have to open all the instruments. That is another economical usage, and then probably the happy patients which get the happy patients.
There are, well, that might be true. Okay, so here's the 10 million lock question. Does using a robot change the outcomes of total knee arthroplasty? And if you say yes, is it usually or occasionally? Quick answer, starting with Thorsten.
If you are believing the non-biased literature and the reviews, the answer is no.
Okay, Amar?
No.
No.
Generally, no.
Usually, yes.
Okay. I knew we'd get some interesting answers here.
6 months, definitely yes. We do a lot of bilaterals in India. The pain quotients, if they are less, it's definitely less. If I have to get my tooth extracted and there's a technology which gives less pain, I will go for that technology. So definitely yes. The first 6 months, long term, yes, to be seen.
Okay.
The answer is yes and always. In two terms, it improves. The one is the number of patients that I would say, wow, who's got the great result.
Okay.
Changed from 70% to 90%.
Are you sure that's not because you told them a robot's great and they're extremely happy and they've got a placebo effect?
I'm saying this from my computer navigation time as well.
Okay.
When there was no extra charge to the patient for computer navigation, it's just that I wanted to use computer navigation and I used. They didn't know. I think that the consistency in the results changed once you have some alignment guidance.
Okay.
And also probably for each individual patient.
I'm going to take the moderator's prerogative. Give us an extra 5 to 7 minutes because we will have plenty of time for discussion because there's 25 minutes for questions.
Definitely enough papers to suggest that the short-term outcome is definitely better. We don't know the long-term.
At least in a few patients, right? Yeah, fair enough.
Usually, we've been hardwired to talk only about survivorship and forgotten joint score.
Okay.
There's so much more to outcomes that's never measured, never accounted for, and so much personal variation.
Okay.
Usually, yes.
Okay, you guys didn't see it, but I flipped the switch here and added unicompartmental arthroplasty. So
before that, I wanted to ask one question.
It's got to be fast.
There is a question here whether will it improve the result, but can being more accurate deteriorate the result? No, there's not going to be a problem by using something which is giving you better alignment and better ability to balance.
Fair enough. I think the downside's probably fairly low. There's pin track problems. There's a few things, but not too many, probably, right? Okay, how about for unis? How many of you believe that there's a value for using a robot in a uni that exceeds that in a total knee? Most of you. And that's just because the uni is a little bit harder instrumentation-wise without a robot. Would that be the main reason? Anybody disagree with that, Alberto?
I would just say alignment. It keeps me from overcorrecting the patient. That is the single reason why I do it.
And unis are just a little tougher to make sure you get that right every time. Amar?
But again, it really comes, it is tougher, I'll grant you that, but it's really a volume-driven thing, right? People who do a lot of unis do great jobs, and they've done them with conventional instruments for many, many years. So it's the problem with unis is you don't do that many of them, and so therefore it helps to have a better tool.
I think I'd agree with that, and I think it's also true that the same thing effect is probably the case in total knees. If you're a supremely skilled and experienced surgeon, the value of the robot to you in terms of changing your outcome is going to be less, let's face it. Yeah. I mean, it's just, because you're very consistent without the robot, right? Okay, here's my last question for you. What are your watch-outs to a surgeon about to start using a robot in total knee replacement? We're going to start right here.
So team, technique, and technology. So team, I think it's very important to have a supportive team.
Okay.
First few
does that mean the rep, or does that mean something better than that?
Everything. The frustration comes from, the first few cases, comes from inability of trackers to be seen by the camera.
Yeah.
Spend more time. Or inability for your staff, because it's a space occupying lesion in the operating room.
Yeah, it's big,
So
some
team,
of them.
Okay, then the technique is, of course, don't put yourself in a time pressure. It's going to take first 20 cases, you're going to spend more time, be patient.
Okay, that's a great comment.
Backup. The peace of mind is most important. So backup. So if you have all three, you will learn one case at a time.
That was terrific. Thanks. Those were really good. Yep.
I think obviously sawbone workshops, cadaveric workshops, surgeon visitation, and proctors come into your theater for the first few cases. But I think most of the robots are married to a system, so you need to sit down and understand that implant system thoroughly, so that you can actually have some bailout options with the standard instrument.
It doesn't make sense to be learning a robot and a new implant system at the same time, right? That's crazy. That's completely crazy. Rajesh?
I think exactly the same, that you should be able to do it on the same implant that you are really used to. That is one. The second is that your team needs to know what exactly is happening in the OR. You need to train.
So not only do you have to train, your team has to train.
First you train yourself, then the team, and pick very simple cases to begin with. In terms of the deformity, in terms of the flexion,
so don't try it on your biggest extra-articular deformity the first time.
Patience to learn, patience to keep the learning, and believing what you are doing. And it might be irritating first few cases with the time, but I've always told patience is the most important key, and making your team believe that this is better, then works out better for the patient.
Okay, thank you. Anup?
Beware of osteoporotic patients.
Okay, that's a very good watch out because of the pin track issue, right?
Pin track fractures, yeah.
Yeah, and the fact that you can have the tracker loosen a little more easily in those patients too, right?
That's right. So osteomalacia.
Don't start with those patients.
Don't start with those patients. Yeah.
Fantastic.
I would just say if you're beginning to introduce robotics into your practice, they take it as if you're starting a new implant system. Why are you doing this? Get some baseline understandings of what problem clinically you're addressing. I have difficulty balancing knees. I struggle with complex cases. I'm inefficient in the operating room. What is the actual problem that you're having?
I don't have enough patients coming into the office.
Yeah. Or I'm manipulating 1 in 6 patients. Understand what your metrics are, and then when you introduce this new thing, watch your metrics. If your cases are twice as long, patients stay 3 times longer in the hospital, there's a problem.
Okay?
Yeah, I think...
Sachin, you get the last word.
Okay, I think one of the things that I'd like to add is that for the first few cases, have an extra pair of trained eyes in the room who's not scrubbed up, who's watching over your shoulder, because you're going to be engrossed watching the knee, watching the screen.
That's a good one. So don't get caught with the idea that you're sort of distracted by all the technology. You have somebody else there making sure it all makes sense. Yeah, Amar.
I do have a watch out. Watch out, it might not be as fun as you think it is. I have a colleague who, we operate on the same days, and we come out of the rooms around the same time, and every time he comes out, he's drenched in sweat. He's using the robot all day long. Just saying.
Maybe he just doesn't like to pay for a fitness center, I don't know. Okay, ladies and gentlemen, we've exhausted the questions I have, but the way this session is structured, we now have about 15 minutes for your questions. So please come to the microphones. The floor is open. I'm sure this is a hot topic. I can tell you're all engaged and interested. Let's have some questions for the audience. Let's start with Professor Bose.
Yeah, Dan, I think the audience is even more confused after this panel. The previous panel we said that, alignment is not that important, you can go 2 degrees this way. And now suddenly we change that precision is all about, robotics giving you the precision. The icing of the cake is that the robotics actually lets you deviate accurately. I mean, where are we? What's the, the message in all this?
Yeah, so I think that your point is a good one. And so let me paraphrase it a little bit. I think that you're concerned that in the last panel, everybody said that there are lots of different ways to do things, and now this says there's a way to get exactly one number or another, right? So I think that each of them probably has their own idea about what they want, and the robot lets them get what they want. That's not the same question as whether each of them wants the same thing, or whether one of their ideas is better than the other, or whether one of those will turn out to be better results for the patient than another. That's unproven, I think.
If you go by the previous panel that the balance is the main thing, the balance we all agree that it is a surgeon thing. Does anybody differ on that? The final balance comes from the surgeons.
The balance is very important, but you can't go too much out of the alignment. So that's what the crux was, that with the alignment philosophies,
we do agree everything contributes, but
you want to have
talking
a boundary.
Talking just about balance, is it would you believe, say suppose discrepancy between what you think and what the robot shows, which would you take?
No, because what Robo is showing, you have to see it clinically as well.
If there's a discrepancy, which would you rely on? That's my question.
You will try and tweak your planning so that you get the reliability on either side.
Okay, there's a lot of people that want to make a comment. I'm going to ask you to make yours first and then Amar.
Robot is neutral. It shows you the data. What you do with the data is your own prerogative. It's like going to a place. Your car.
We agree on all that.
I told you there was some religion in here. Did you see that? Going to the
philosophy.
The alignment, the robot shows you better. We agree on that.
The religion is opium. The philosophy is
soft tissue balance. Which one tells you better? That's my question to you.
Okay, Amar, you had a comment.
Yeah, I mean, the tricky thing about all of this is we've all seen knees where it's a stable knee to your examination. Patients getting recurrent effusions, and they're having subtle instability. Yeah. And you can examine somebody else's knee, and that knee is flopping around like you can't believe, and they love it. Right? So we don't understand how the brain-knee, connection works.
I think we have to recognize that. Well, I think that in gross terms, an unstable knee is bad, right? And we're trying to not get unstable knees. But it's true that some patients tolerate some level of instability very well, and others tolerate it very, very poorly. Why is that? I have no idea. Thorsten.
I mean, the question is very good, which I wrote it out, because if we talk about balancing alignment, for example, alignment is a good question. Nobody understands alignment totally.
That was clear from the last session, right?
Yes, and the question is, could be the robot helpful regarding alignment? Yeah. And the answer in the literature is no. So all the reviews, they compared robot and conventional different alignment techniques.
It's hard to show
no benefit.
It's hard to show a big clinical difference, right? It's clear that you can hit targets, but whether it changes the outcome, that is unproven, I think, so far. Okay.
So we were doing computer navigation for the last 17 years, yeah. And then now today suddenly the robots has jumped into the market. Yeah. Do you feel any difference there between these two technologies?
Okay, so let's ask.
One, and what subsets of patient we are doing in the country? And you can sometimes get osteophytes like a whole condyle. And how do you titrate those tissue balancing with the robot? Okay. Is that the question?
Let's ask somebody who's been doing both robotics as well as now robotics, but previously lots of navigated surgery. The person right behind you, let's just ask what. Are you doing robotics right now?
Getting into it.
Okay, so Rajesh, you started with computer navigated surgery, now you're doing robotics, is that right?
That's right.
What's your answer to Dr. Jain about the difference?
I think your ability to get your cuts right, particularly in the sagittal plane and the slope, is much better with the robotic. Overall coronal alignment is the same. The recuts are very good with the robotics. You don't need to put your jigs again and fix them. You can just achieve that within a second, your recuts with the robotics.
Anoop, did you have a comment?
Yeah,
So in computer navigation, you can cut and check, but if there is an error in cut, you can't correct it. Suppose you planned 3-degree flexion, you cut 6-degree flexion, you can't do anything about it, just check it.
Well, you can correct it manually, right? And then recheck it.
No, but how can you decrease the flexion of the femoral cut? Suppose you have cut at 6 degrees.
I agree, it's hard, right?
So
Can you do it? Yes, but
How
it's
does
hard.
the robot help there?
No, but robot, once you plan 3, it will cut 3.
I've seen a couple of X-rays today's in presentation. If you go back, the components is more than flexion, even around 9 or 10 degrees of flexion, one of the case here. So how does the robot help there?
Okay.
So I navigate now. I robot both. Like if I have two theaters, I navigate one
good.
theater,
So
I robot one
let's hear
theater.
your answer to his question.
So image-based robots is something which I am for in, because you get to know your posterior condylar offsets very better, both on the medial and lateral side. You can mimic one of the condylar offset. You can basically shape match the femur, and basically you are marking the same patient's knee. You're not creating a 3D image there. So that's how it differs from an imageless navigation philosophy to an image-based image. And then my femurs have come down one lesser. If you hold two femurs, size 3 at a size 4, my femurs are coming down. That means less metal I'm putting in with tweaking the sagittal offset. So that gives better feel for the knee. So for me, switching over from navigation to robot, I feel image-based robots, for me, to my personal experience, are better, because since I navigate and robot, image-based robots throw up the CT scans. So you have the condylar offset, you have the medial lateral symmetry, you have the anterior symmetry. You play all the 3 axes, coronal, sagittal, and rotational. And alignment is yours, whichever alignment you want to choose.
Fair enough. Anybody else have something to add? One last comment?
So I think robot is a natural progression to navigation. The foundation is navigation. What robots does in addition to navigation is it helps execute to the precision where you want to be. Number 2, the newer softwares. The navigation softwares have more or less remained static for a decade. The newer ones, because the cost have been put in, the softwares are much more intuitive, and with AI coming in, they'll be much more helpful. Ultimately, the computer or the robot will have no religion, no philosophy. It's your philosophy, the surgeon.
Okay, we're going to go to microphone 7, then 3, then 5, then 2. So microphone 7.
With the robot, we are talking about precision. What about the basic character of the implants? Most of the implant sizes are based on the Western population, and the Indian bones are definitely different. There is a mismatch in precision there also?
Does anybody want to take that? So you can do so much of the robot, but if the implants aren't designed for your population, it's hard to match it perfectly. Does anybody want to take a shot at that?
Yeah, but certain Indian makes are very good these days, as good as the US makes, and they are designed for our sizes.
Okay.
They match more our sizes. So I think
you think that problem's getting solved?
And most of the implants have multiple sizes and narrow sizes and all that.
So you think that the implant companies have responded adequately? Fair enough. Microphone 3.
Yeah, I think in my practice it's about 15% of robotics and rest is still conventional. I think there are 2 areas of robotic surgery today that I find are still surgeon dependent and could change from surgeon to surgeon. There are 2, one is big deformities whenever you're correcting. The question that was asked by Sanjeev, you still do not know what balancing you will achieve at the end of resection of the osteophytes or even reduction osteotomy. I've been trying to quantify that reduction osteotomy and to see how much balancing you're going to get at the end of your balancing is still not quantifiable by robotics. So even whatever pre-planning you might do, you might still get the lateral side, to get say 18, 19 millimeters. Medial side, if it is 8 millimeters to start with, and what reduction osteotomy is going to give you, whether it's going to give you that balance, we still do not know. That is one. And second,
so predicting what some of our interventions will do with the soft tissue envelope is not something a robot can tell you. And fair enough, we'll agree with that.
Second aspect is the tensioning that you give to the tissues, and the numbers that you get on the screen are completely surgeon dependent.
Yeah, I think that to me is probably one of the biggest areas of deficiency. And Session, you brought it up, I think, in that example that you told us where somebody tried it 4 different times, or was it Alberto? And they got 4 different answers, right? This is an area that clearly the technology is not very good in.
Well, also just to say, Dan, I mean, today I must have heard at least 10 times from the audience, is it okay if I leave 1 or 2 millimeters on the lateral side? We are so paranoid about instability and about subtle laxity, all of us.
And do you think anyone can tell 1 millimeter?
I would charge that if we had a cadaver right here, and all 10 of us came up and independently assessed the knee and wrote down our numbers independently, our reliability wouldn't be bad, it would be catastrophic.
It might be a pretty good paper, actually.
And secondly, Dan, it's becoming a fight between haves and have-nots. Can you ask the audience how many actually have access to robotics today?
Okay, that's a great question. So, show of hands, how many of you in the audience on a routine basis have access to a robot in your operating room? How many of you do not? So I would say it's about 80% no and 20% yes, roughly. What's that? 80% said no, 15, 20% yes. That's my guess.
Dan, you have to ask a third question.
Okay.
How many would wish to have a robo?
Okay, how many of you wish you had a robot that don't? Yeah, so a reasonable number of brave souls raise their hands. Maybe there's actually a few more out there.
Then I think the question that Hemant asked, you won't know what is going to happen to the ligament situation, but it's a dynamic process. And just as you do it in a conventional technique, you keep on checking again and again. With robo, you can keep on checking and the numbers will change and it will guide you even further. So I think it is no difference.
Okay, microphone number 5.
Is the coronal alignment and the robotic tool overshadowing the importance of sagittal and the axial plane anatomy? Because with chasing the balancing numbers, we tend to kind of over externally rotate or internally rotate, and the implants that were designed were basically for the mechanical environment, and we put in this newer alignment philosophies using a robotic tool, will it lead to some kind of a problems in the future?
Okay, so that's a great question. Who wants to take it? Anoop, you're not allowed to because we know where you stand on this. No, it's okay. You're allowed to say something too. Go ahead.
Most of the robots will have limitations on the sagittal plane balance as well as the coronal plane balance as well. So you would have limits of internal, external rotation, which are obviously have to be approved with the FDA in the United States. So you have how much of flexion on the femoral component and slope on the tibial component is allowed and permissible.
Boundaries.
You have boundaries. You could either have a narrow boundary for yourself as a surgeon, or you can set wider boundaries for yourself, depending on what your alignment philosophy is.
Anoop, you're pretty hardcore on the kinematic side. Are you a boundaries at all guy or no boundaries?
No boundaries.
Zero boundaries. So what's your answer to that question?
So I agree with you that most implants are designed for mechanical alignment, and when you're doing kinematic alignment with the implants designed for mechanical alignment, you will have lateral under coverage because you're internally rotating the femur. So you'll have lateral under coverage. So you should use implants with a broad trochlea, so you don't have issues with patellar tracking.
I'm married to only one implant if I have a robot, so that will...
You can always marry twice, so you can...
You can always choose the system you want to use, depending on which implant has a long-term good record, other than going for a new one.
We'll try to avoid getting, extrapolating from that to social situations. Arun.
Dan, I have a question to you and the panel.
Yep.
For years and years, people spoke about navigation, which uses the same software as robots. And yet there was nobody really desperately interested in navigation. Why suddenly this interest in robots which uses the same software? Why have the ones who are using navigation, I can understand it's one level above. But the guys who are never using it, who used to jump from the podium saying never use navigation, are suddenly the ones who are proposing the use of robots now. So I'm just trying to figure out
it's a very interesting observation. We'll get the panel's comments in a minute. But I think your question is a good one, and it's a very real one. My own guess is that to some degree it's been a little bit of an element of people getting used to the idea of technology in their operating room. To some degree it's an ability to market something new that patients bond with. Patients didn't understand computer navigation, but they understand the idea of a robot. So for marketing purposes, a robot is much more valuable than computer navigation. There's no question about it. And lastly, I think the companies have embraced it. It's much more expensive to sell you a robot than a computer navigation system. Companies love that, and I think that they've really pushed it. If you're going to ask me, that would be my answer. I'm not sure it's fair. Maybe somebody else has a different answer.
I mean, Arun, I was sold off on a robotic system by watching a total hip replacement. And it actually is an eye-opener if you watch a robotic total hip replacement, and then the ability to do a total hip, a partial knee, and a total knee using a robot is much better than probably just using for a total.
I can understand that, but I mean, navigation was first brought in for knees, so, anyway.
Fair enough. Okay, microphone number 3.
But we have already achieved like more than 90% success and accuracy by conventional method. If you are doing surgery properly, Then what further do you think we can achieve by adding robo in our practice? Conventional, good surgery, more than 20 years survival, 95% patient. Now,
Okay, I think you're going to get the last
can
question.
you increase that thing further?
We got it. So do you really think with the pretty good results of manual instruments, we're going to improve on them very much with using a robot? Let's say ask first the true believer.
So there's always room for improvement. You yourself have the answer to the question. Is 90% good enough? So when there is a scope of improvement, that's what makes human human.
Do we think the robot will get rid of that 5 or 10% that's not happening?
If you know what to hit, it will help you hit that.
Maybe.
Yeah.
Okay, Raj?
It has got rid of the malalignment issues, that 10%
Yes.
or 20 or 30% outliers, it has definitely removed.
It will help with the outliers in the inexperienced hands.
And,
Fair
and
enough.
there is a possibility that you can get better.
Alberto?
We tried changing the implant numerous ways. It didn't do anything. We introduced computer navigation to improve alignment, and then we realized that alignment wasn't that important. I think that robots can help perhaps with instability and more complex preoperative planning, but I don't think the soft tissue tensioning is there yet.
Amar, as a non-believer?
Yeah, I mean, I've mentioned this study numerous times, but, you know, Jean-Noel Argenson published what I think is an outstanding paper, prospective randomized 10-year follow-up on computer navigation versus non-navigated. The alignment was better in the computer nav side for sure, but at 10 years, there was no clinical difference. And like Arun was saying, this is just a fancy computer nav. Right? So it doesn't change cementing, it doesn't change wound closure, it doesn't change all the other things that we have to do to make a good operation.
That because we were chasing the same target.
Okay, so you think that by chasing new targets, we might do better? I think that's the question that we'll have to answer in the future. Ladies and gentlemen, I hope you enjoyed that panel. Please join me in thanking them.
Thank you so much, sir. And all the panelists for demystifying about robotics for all of us. And that was such a wonderful session. So I would request the moderator and the panelists to kindly pose for a group picture. Up next, we have the last session for this wonderful brainstorming day. We have the last session, that's the session 7 coming up, which is the case presentations on primary, complex or revision total knee arthroplasty. So I would request Dr. Amar S. Ranawat, the moderator for the session, to kindly get along the session, and the panelists for the last session, that would be Dr. Neeraj Atkar, Dr. Daniel J. Berry, Dr. Harish Bende, Dr. Sunil Rajan, Dr. Shubhranshu Mohanty, Dr. Arun Mullaji, and Dr. Rajesh Mania to kindly come up on stage. And I would also request the panelists for the day, the presenters for the day, sorry. That's Dr. Preetam Agarwal, Dr. Rushai Bhalodia, Dr. Sanket Devanji to kindly be seated in the first row. Dr. Ramnik Mahajan, Dr. Suhas, Dr. Jagdish, Dr. Karthik Reddy, and Dr. Karthik Subramaniam. Dr. Preetam.
Okay, looks like our panelists is a little light, but they'll probably trickle in, just probably getting some coffee. Are you ready with the first presentation?
Left click.
Dr. Agarwal?
Let's start.
Are you ready?
Yes.
Go ahead.
Good evening, everyone. So my case is, it's a 73-year-old male patient with bilateral osteoarthritis knee. He has pain since last 2 years. He was more symptomatic on the left side. And on examination, there is a flexion deformity of 15 degree on the left side with valgus 30 degree on the left and 15 degree on the right side. Range of motion till 100 degree. And this is the long leg X-ray of the patient, 33 degree varus on left and 18 degree valgus on the right side. So this is the CT scan of the patient. I don't have the lateral views. So
Well,
there is
that's
a big posterolateral defect. And
so let's stop right there. Who on the panel is getting a CT scan? Harish, let's start with you. Are you getting a CT scan preoperatively?
We need to add a good quality AP and lateral, and if there is, if you find on that some significant bone defect, maybe CT scan, but good AP and lateral and a scanogram to see how does the hip and overall bone to
Yeah, so you saw this case. Are you getting a CT scan?
I wouldn't. I mean, it wouldn't make a big difference to me.
That's my, okay, good. Arun, would you get a CT scan?
Yes, because we are doing some research studies, but not otherwise.
Fair enough, okay.
Routinely, no. I do good, X-ray with lower femur and upper tibia, and as well as skyline view, and as well as the scanogram.
Okay.
No.
No. All right, so no one's using a robot, no one's getting a CT scan for the robot, someone's getting it for research, but why did you get the CT scan?
Because I do image-based robotics, so that's why I got the CT scan.
Okay, there's your answer, good. Okay, we don't need to see it though. Let's keep going.
So this is the pre-op clinical picture of the patient with a varus thrust. He was more symptomatic on the left and he wanted to get operated on the left side only.
Okay, so I mean, I guess that's the bigger question. He's got bilateral flexion contractures, bilateral deformities. Is this a case that you would consider doing bilaterals on if the patient were willing, Harish?
I think I should prefer unilateral. We need to see also the other medical factors in the patient, the age, the hemoglobin and the albumin level and medical comorbidities like hypertension, diabetes, etc. But one at a time should be good enough.
You're not concerned about the bilateral flexion contractures and correcting one limb?
The left is little more deformed. The right is not that deformed. It's just about 15 degrees, which is not too bad.
Okay, fair enough. Arun, would you want to do bilaterals or?
I do bilaterals very frequently, provided the cardiac condition is good.
Right. Dr. Mohanty?
Yes, grade 1 and grade 2 patients without any cardiac comorbidities, I would go ahead with a bilateral total knee replacement.
I do bilateral simultaneous knees, but I would say in this case it's a question of understanding the patient's health and whether there's a real reason forcing you. The modest flexion contractures wouldn't push me too hard.
Right.
Yeah, I do bilateral as well, but just in straightforward cases, not in complex cases.
Right, so I mean, I think, there's no question there are indications for bilaterals. They have to be healthy patients. So all things being equal, though, there are situations where patients have significant enough deformities that you should consider bilaterals in those particular cases. When the flexion contracture is large enough bilaterally that it would, it might affect their outcome. All right, keep going.
So I planned for a robotic-assisted functional alignment with a medial subvastus approach. I do all my knees with medial subvastus. So this is my CT planning. So I planned a 3 degree of valgus from the mechanical axis for the distal femur cut. Initial plan was 2 degree internal rotation to the transepicondylar axis and the overall limb alignment of 3 degree valgus with a femur size of F and tibia size of 6. So this is the examination under anesthesia. The valgus deformity was partially correctable.
So, but you had a mechanical access, a 0 newt mechanical access. That's what you're aiming for.
No, I aim for 3 degree valgus.
Well, go back to that picture. Go back 2 slides.
Okay. One more.
Yeah, that looks like it's a 0 mechanical.
Sir, at the lower down, the mechanical axis is 3 degree valgus.
Okay.
Because the distal femur cut is in 3 degree valgus, and the tibia in neutral.
All right. So let's keep going.
So this is the exposure with a medial subvastus after the exposure. So this is the gap check. When I give a valgus stress, the gap is 13 on the medial side and 1 on the lateral side. And with a varus stress, I can balance the knee in extension. That is 10-10 both on median and lateral side with a limb alignment of 3 degree valgus. In flexion, when I give a valgus stress, the gap is 9 on the medial side and 0 on the lateral side. And when I give a valgus stress, it's a varus stress, I can balance the knee, that is 9-9 both on medial and lateral side with a final 3 degree of valgus. So I balanced my knee both in flexion and extension with 1 mm more on the extension because of the flexion deformity and overall alignment of 3 degree. So this is the cuts and this is the final gap check after the bone cuts and the alignment is 2 degree of valgus. And this is the final picture and the patellar tracking is good. And this is my post-op X-ray.
So you're suggesting you did all of your balancing through bony cuts?
Yes, sir.
You didn't do any soft tissue lateral?
I have not done any soft tissue release in this case.
Okay. Now, do you think you could have done the same thing if the deformity was not partially correctable?
No, if it's a fixed deformity, then I need to release it partially.
All right, so why did you use a constrained insert there, the audience is asking?
Sorry, sir?
Is that a constrained insert?
Yes, yes. I use a constrained poly because the medial side was lax. MCL was attenuated. That's why I use a constrained poly.
So wait, you used a computer and a robot, and now your medial side was lax?
I want to be safe, on the safer side. That's why I use a constrained poly.
Well, so let me throw something at you here.
That was pretty interesting, right? Because you just said that you didn't need to balance the knee, but then you ended up using a constrained implant because the knee wasn't balanced.
Right.
It's a little bit interesting.
It is, and I want to correct something in the audience here. Is the medial side lax, or as I suggested, your lateral side is tight, right? You need to open up your lateral. It was partially correctable, but it wasn't totally correctable. You need to open up your lateral side so you can get a bigger spacer in, a bigger insert in to balance your medial side. Your medial side isn't lax, but your lateral side is tight, right? Anyone disagree with that?
No, I mean, we have all seen that the medial collateral was insufficient and the lateral was tight. And just to correct it with bony cuts, in my hands, it's impossible.
Yeah, I would agree with that statement. And you actually would suggest it's difficult too. And you didn't resurface the patella.
No, sir.
And you didn't do a fascicectomy.
Sorry?
You didn't remove the...
No, I removed the osteophytes.
Okay.
Yes.
So is that your routine?
Yes. I don't do patella.
And do you do electrocautery around the patella?
Yes, I do that.
Okay. I think there's some good evidence that you should get rid of the lateral facet, though, if you're going to not resurface the patella. Does anybody here, who resurfaces the patella? Raise your hand on the panel. And the rest are selective resurfacers? Or never? Who never resurfaces the patella?
Never. I'm never.
Never. So if Orson and Ashoka, never. Okay. And then you're selective? Always, always. Okay. You have anything else to add?
Yes, this is my final alignment X-ray. It's around 3 degree of valgus that I was aiming for.
Amar, may I?
Sure.
This guy has a significant plano valgus, in other words, a flat foot.
Yes.
You're leaving him in 2 or 3 degrees of valgus, and then you're putting in a constrained implant with a post. I think if he's a younger guy, you're going to risk post wear. I think the key is really to balance that knee. I think all the drama about the robotics and the angle and the planning is all very good, but at the end of the day, you need to have a balanced knee joint. You cannot rely on a block of plastic to stabilize a valgus knee. I think that's a fundamental principle.
Yeah, I mean, I agree with that. I think this knee is at some risk for late instability and or post-wear. But so far he's doing good, and we should applaud you for your efforts.
Thank you, sir.
You have anything else to add?
No, that's all.
Amar, the discussion should be that in case of in presence of plano valgus pit, what is the approach? What should be the approach?
Is your question, should the foot be done first, or?
Yeah.
So who would want
to address the foot, or you just forget about the foot, or you leave the alignment to neutral rather than giving it valgus?
So let's go down the panel. Who is getting the foot fixed first? Rajesh?
Only if the foot is very asymptomatic, I would get a consult from a colleague, foot and ankle surgeon. If an asymptomatic plano valgus, I wouldn't go after the foot.
All right, is anybody getting the foot done first?
No, and generally speaking, the foot and ankle guys don't want to do it first. They want you to straighten out the leg, and then if there's still problems, they'll fix up the foot. I think what Merrill Ritter's data showed us, though, is that if you straighten out the leg and you've got a bad plano valgus foot, that can still screw up the knee. Yeah. So if it's really bad, you may have to go fix it secondarily. But what I would say is you don't want to leave a knee like this in valgus. I think that was Arun's point, and I agree with that, because that is going to cause a problem, the double valgus.
Can I just make one point?
Sure.
I think with the previous discussion on robotic surgery, I think the message is going that you do robotic surgery and you can get anything corrected without balancing the soft tissue. You don't need to do balance. And this is exactly the case which somebody may do, I mean, you do robotic, and then you don't balance, and then you constrain design because you think it is medial lax. So that message should not go that robotic doesn't mean you don't need to do balancing. You still need to do it if it is required.
I 100% agree, and I think it's we've always talked about this being a soft tissue operation, right? It still is, as I meant. Not only do you have to balance, but you also have to respect the soft tissues and make an appropriate incision and and close the wounds properly. All those things are factors that can have major impacts on the outcomes of the knee replacement. But yes, I agree. If I'm doing a valgus knee, the last thing I want to do is leave that knee in any residual valgus. Does anybody have would defer on that?
Just one other point, Amar. Everything said is absolutely correct. Using a constrained option without some sort of even a mini stem is another recipe for that getting loose. So in addition to everything else, not leaving it in valgus, getting it to a neutral alignment, doing a soft tissue release, and I couldn't agree more. Use of robotics is not a sort of a facet where you forget the soft tissues. And no matter how much you say that you don't do soft tissue releases, I have a question to ask. How do you subluxate the tibia in front of the femur without a soft tissue release? How do you do that? I mean, at the end of the day, if you have to pull the tibia in front of the femur, there has got to be some amount of soft tissues. How do you remove posterior osteophytes on the medial side or lateral side without some soft tissue? So if you say you minimize the soft tissue releases, yes, I get that, I accept that. But to say I do no soft tissue releases, that's a hard one.
One important point to add that in case of valgus knee with flexion deformity, I prefer to use a PS knee rather than a shear knee. Of course, with a balanced knee, because that allows you to correct the flexion deformity by sacrificing the cruciate, as well as that given option of placement of your components little bit. You have some play in the placement of the components.
Yeah, I mean, that whole concept for me has changed now that I do a lot of CR knees where I sacrifice the cruciate ligament, and so because of these ultra-congruent designs and everything else. So in general, if I do a valgus knee, as I published on it, I'll use a PS knee. If I know I'm going to cut the PCL, I will probably start off with a PS knee. But I think nowadays there's plenty of cruciate retained designs where you can use a cruciate retained design, but you probably are sacrificing the posterior cruciate. Right? Anyone disagree with that statement? All right, do you have any other points you want to make?
No, thank you.
Okay, thank you very much.
Can we have Dr. Sanket Diwanji?
Good evening, everyone. I am going to present a case of a bilateral complex primary TKR. 59-year-old female who had a severe both knee pain for long duration, difficulty in walking with gait instability. She had no comorbidities. The right knee had a valgus deformity with hyperextension deformity, mediolateral laxity, flexion -10 to 100. Left knee had varus with fixed flexion deformity and 90-degree flexion. These are the AP lateral and scanogram X-rays. She had 34 of valgus on right and 22 of varus on left side.
Okay, so let's stop there. Thorsten, let's start with you. How are you going to tackle this problem?
If I have a 3+ medial insufficiency, that means the medial collateral is almost gone, then I would directly go for hinge knee on the right side.
Okay.
On the left side, you can do what you want.
Okay, anybody have anything they want to add? Rajesh?
I would not automatically go to a hinge. Even this might, at the end of cuts and balancing, you might need a constrained one, not just the PS. But yeah, I would agree that a hinge has to be on the back.
Does anybody have any other concerns about the knee? And
Clinical examination is again important that when you give a valgus stress, you have to see that whether there is a, you have any, it's a opening up quite easily or there is some restraint there. So that gives you an idea about the, whether the MCL is functional or not. I would keep on the table constraint is ready, but on the table I'll decide about whether to go for a hinge.
so the question I have though is there any concern for why this patient has this deformity? Is anyone concerned about a Charcot knee or a neuropathic knee in this situation?
Yeah, I think it's always good to eliminate a neurological condition, especially if there's hyperextension. Was there hyperextension on the valgus side?
Yeah, he said there was, on the right side, not on the left.
Yeah, so on the right side. So I would be really concerned that there is a neurological component to it. If it is a neuropathic joint, then perhaps Thorsten might agree that a hinge may not be the best option. You'd rather use a TC3 rather than a hinge.
Yeah, Arun, that's right. So it has to be a special hinge knee. It has to be a pure hinge knee. But again, I agree with you. If it is a neuropathic one with hyperextension, a hinge knee is probably not the best solution. That's a very good comment. Then you need a very special hinge knee with a big bumper, or you use a CCK or VVC.
So that's an excellent point that I wanted to bring out, which is not all hinges are the same. And some hinges are designed with extension blocks to prevent hyperextension, and some aren't. And if you put one that is not designed for it into this kind of case, the locking mechanism will break. And then you have a big problem, especially if you've cemented stems up and down the femur and the tibia. All right, keep going with your presentation.
So, patient preferred stage-wise surgery. So, I did right knee first. I used lateral parapatellar approach, and proximal tibia and distal femur cuts were taken under navigation guidance. Lateral pie crusting was performed, and next-gen PS implant with 17 mm insert was used.
All right, so let's stop right there. Thorsten, yeah, go ahead.
One short question. Do you think that a PS design can correct varus valgus deformities? Because you used a PS design here, there was a valgus deformity. Do you think that the PS can do it? PS gives you more security or more safety?
Actually, I always use PS implants. And since as the surgery progressed, I could get a good mediolateral balance. So towards the end of the surgery, the medial collateral ligament was tight enough to balance the medial compartment. So I preferred, because in this case, I had kept LCCK and RHK as a backup. And I was planning to use if needed. But during the course of surgery, I could get good balance, so I stopped with PS.
The MCL was better, much better than you expected, and much better than you had shown us in the preoperative. Okay.
Yes.
So have you taken key messages that you're trying to make? I think using the least amount of constraint is generally a good philosophy to follow. But we were also discussing that the patient had hyperextension, and some knees are at increased risk for developing late onset instability, and this might be one of them. And so even though it was balanced with the PS, you might have been better served having that backup in there with a constrained knee for, like I said, for down the road, especially because this knee also has been left in a little bit of residual valgus. We don't have the full length x-ray, but
I have post-op full length.
Okay, so why don't you show us that?
And left knee was operated 1 year later, routine medial parapatellar approach. And this is the scanogram at 6 years follow-up.
All right, you got lucky that she had a lot of ventrolateral bowing of her femur.
Yes.
How much bone? Just one point on this. When you look at these films and you start assessing the medial collateral because you think that it's elongated, a lot of these deformities, because of the sort of bone loss that occurs on the posterior tibia, you have a rotational deformity occurring at the level of the joint line, and that seems to give you an impression that the medial collateral is extensively stretched out. That may not be the case, and you may end up being able to balance the knee because it is intact.
May I ask a question? How much bone cut did you take?
I took very thin cuts for the right side because when I put the navigation system in, it was hardly cutting 1 or 2 mm from the lateral femoral condyle, distal lateral femoral condyle. And since it was 2 legs, you can see the level of resection on the tibia is also significantly higher than the fibula head. So I took very conservative cuts.
And, and that's the take-home message for the audience. Whenever you see those preoperative x-rays where there's medial stretching or lateral stretching on the other side, those are knees where you have to start off with very thin cuts, thinner than you normally would cut. Because otherwise, you still used, looks like, 15, 17 millimeter polys, and you had thin cuts, right? So that's the risk when you have stretching of a knee preoperatively. Yes. But, okay, and you have some 6-year follow-up. Well, that's fantastic. All right, any other comments or questions from the panel? Who's next?
The pre-op, we should get a varus correction X-rays. That give you a good idea about how much correctable it will be on table. If it is fixed, then it becomes difficult. He hasn't shown any pre-op varus correction X-ray in a coronal plane.
I'm sorry, what do you want? You want pre-op?
Pre-op varus correction X-ray for the valgus deformity. If it corrects significantly, then you know that you probably may not need anything more. The balancing will be easy.
Yeah, so
That's
I mean,
one of the
but
things
do you need an X-ray for that, or can you just do that by clinical exam?
We can take it on clinical exam, but if you take an X-ray, it maybe just records exactly how much correctable it was.
So that's a medical legal issue to make a recording of it, but you don't need that information to do the operation and to, you're trying to determine, is it correctable, is it partially correctable, or is it fixed, right? That's what you're trying to figure out, and you have to make sure then, is it because it's a soft tissue problem, or is it a bony defect problem, or a combination of the two, right?
It helps your surgery.
Yeah.
And always take a skyline view, the operative view.
100%.
Thank you.
All right, thank you very much.
Thank you so much, Dr. Sanket. Up next, we have Dr. Suhas.
Yeah, good evening, everyone. This is a very similar case, but the gaps which I had during the surgery were a little different. 76-year-old lady, morbidly obese, side-swipe deformity, right side valgus, left side varus. Because of the comorbidities and the body habitus, we decided to do it in a staggered fashion. We did the left side first. So this is the scanogram. You can see it's a 29-degree valgus deformity, and her mobility is grossly restricted. So in such cases, she was both valgus as well as hyperextension. Here, the decision-making points that we had to consider is what are the bone cuts, what alignment we would leave these patients at the end of surgery, what is the rotation on the femur, and is there requirement for releases. So if you can see the data that we got from the software, the joint was very lax. So the issue was not correctability. The joint opened up both in flexion extension. The issue was the hyperextension. So here you can see that the gaps were too much, 28, 29 in extension, 24 and 26 in flexion. So in such situations, when you have so much gap, your options are to actually distalize and proximalize, distalize the femur and proximalize the tibia. So how much would you go up to? Because I had to really come down in terms of those skim cuts. So in this particular patient, I removed just 1 millimeter on the lateral side, on the distal femur, 3 on the medial side. Posterior femur was 4.5, 5.5. Distal tibial cut, though this is getting measured from the defect, it was almost 0 on the lateral, 0.5 on the medial. In spite of doing all this, the tibia was kept at 90, and the femur was around 1.5 degrees of valgus. Because of the distalization and proximalization, there was some amount of lateral tightness that came in extension at the end of the trialing, so I had to do some ITB release. And in spite of...
Let me stop there. So how did you release? Did you completely release the IT band, or did you pie crust it? What did you do?
So I usually use a 11-number blade, and then Either you go inline or horizontal or perpendicular based on how much release you need. Since this is a robotic system, each amount of release you can actually quantify and see how much the lateral side is opening. In spite of distalizing the femur by 5 millimeters almost, and tibia was also raised almost by 4 to 5 millimeters, I still ended up with a 13 millimeter poly. There was a firm endpoint at the end of the procedure.
So let's go back to the one slide back. There was a large posterior osteophyte. Yeah, there you can see it on the CT image there.
Yes.
So how does that factor in? We talked about it earlier. How does that factor into your balancing?
So if it's a flexion deformity, it is a big, it's a bit of a concern for me. I would undercorrect my deformity because my extension gap will open up after removal of the osteophyte. Since this was already such a...
But you're guessing that, or is the robot telling you that?
Sorry?
You're making that assessment, but you're guessing how much more it's going to open up when you, right?
It has to be an estimate because there is no recommendation looking at the volume and the size of the osteophyte and how much correction you actually get at the end of removal of the osteophyte.
Right, so I mean, I think that was the point made, though, in the prior panel, that this is one of the limitations of robotic surgery, is that we don't know how to quantify those, those changes that are made to the soft tissues once these osteophytes are removed, or if you do a tibial reduction osteotomy. So all these things are very hard to quantify robotically.
Especially to...
in terms of the posterior osteophyte, it's very important to remove that early in the procedure and then do your measurements. So we always, for many years, we've been excising it with a curved osteotome right in the beginning as part of the exposure.
So we've also...
When you do your measurements, you've already taken that out of the equation.
Yeah. Especially for varus knees, we do that. We take a skim cut on the posteromedial aspect so that I can gain access to those posterior osteophytes, and only after that we do the balancing.
Okay, go ahead, Mahanti, you have a question?
Suhas, there is if you see the preoperative X-ray, in the sagittal plane, there is a lot of posterior tibial slope.
Yes.
But your, post-op X-ray shows there is an anterior slope.
Yeah, I mean, it looks like she had a stress fracture.
So she has almost a 19 degrees posterior slope on the lateral side and almost 20 degrees posterior slope on the medial side to begin with. So I think this was probably not native, but because of the progression of the deformity, that was the amount of slope or remodeling that had happened in this patient.
And intraoperatively, how much slope you take in this?
If I remember correctly, it was 3 degrees.
And is that a fixed number that you have, or is that something you calculated?
So for a PS knee, the recommendation for a triathlon is 3 degrees of slope.
So that's what you're just...
Yes, but if I do a CR, I do give a little more slope, trying to match the native.
But you wouldn't put 20 degrees of slope in there, would you?
So the maximum we've gone up till is 7 degrees.
Do you think the hyperextensions which you have with a significant posterior capsular laxity, the slope, if you give less slope, it is better actually for you? It's nothing to do with the PS or CR need. The amount of laxity which you have, you give less slope, you're automatically trying to correct some amount of posterior tightness.
So I let the balance decide that for me in terms of implant positioning. Here, my gaps were almost 24 and 26 in flexion. So already the effort was to actually decrease the gap.
If you see the post-operative X-ray, can you show the post-op X-ray?
Suhas, can I ask a question?
Yeah, it looks there is an anterior slope in the tibia, isn't it? The stem extender which has been shifted posteriorly, that is because of the posterior slope. Anterior slope.
Would upsizing your femur have taken care of some of the flexion and stability?
When you do gap balancing and you move the implant around, you're talking in terms of absolute numbers in gaps. So there is no role for upsizing or downsizing the femur.
But by doing that, you would actually reduce the flexion gap. And one of the things that you want to do, because out here you have a hyperextension deformity, that would be one of the components that you might, not ideal, but this case is not ideal.
Yes.
And this is really a compromise situation. Everything that we're talking about is some sort of a balance between what should be done and what is actually feasible to be done. because you are converting from 22 odd degrees
Almost
to
28
yeah,
millimeters.
28,
Yes.
whatever, to 3 degrees or 5 degrees. So just a suggestion, maybe upsizing that femur could have made this a little bit easier.
I think what you've done actually is perfect because he has not upsized the femur, so you have a larger flexion gap, and he's slightly anteriorly tilted the tibia, so he's got a larger extension gap, so he's matched the two. So I think he's balanced it out very well.
As the gaps came down, if I needed little more tightening of the flexion gap, I would have just moved the femur posterior instead of upsizing it. But if there is notching, then I would definitely upsize the femur.
Do you have any, could you show us the outcome of the patient? Do you have any follow-up or something?
Not yet. This is quite recent, so, and we have to do the left side also.
Tibial component looks a little bit in varus as well.
So overall was 0.5 degree of valgus, what we measured at the end of surgery.
Wait, you do have clinical follow-up?
So 3 weeks post-op, this patient had a buckling, and then she ended up having a fracture on the distal aspect of the femur. So here the question for me was it an insufficiency fracture? There was no height trauma in this patient. Or is it just purely because of buckling, or was it because of a pin tract fracture? But here the pins were slightly more proximal. If you can see posteriorly, right after post-op, you can see there are none of these holes were there. So she just had a buckling, and then she ended up with this fracture. So my question was the role for prophylactic intramedullary rod on the femur. Is there current recommendation? We have for the tibia, but it's mainly for obesity and loosening. But on the femoral side, I couldn't find much in terms of recommendations. Purely is it based on our ability to assess the bone quality? Because this was a PS femur, and this was triathlon. I couldn't add an extension on the femoral stem. I had to do actually change to a revision stem in order to put a femur extension.
It's, you make an excellent point there that most of the modern primary knee systems now, you don't have the ability to put on femoral stems. I think we almost went backwards. And almost every company is the same in that regard. So I think, it's one of the reasons why I kept using an older design, because I do use residents and fellows, and things do happen occasionally, and you do need to put a femoral stem in occasionally in cases of notching or otherwise. So, yeah, that's a big problem. But
this is the only article I found from Peter Skulko where this was the exact combination that I had: 75-year-old lady, obese, osteoporosis, and when you have a severe preoperative valgus, and when you correct them to neutral, you tend to overload the medial side and cause an insufficiency fracture. So in such patients, either you do a CR knee, or if you do a PS, then do it with an implant which has a femoral extension for a primary femur.
But how sure it wasn't your pin tracks?
So they were more proximal, so that is the reason I put all the 4 etiologies. Because it was a bicondylar fracture, if it was more pin tract, it should have been more proximal and mainly involving the medial condyle. Insufficiency fracture is the only one where 50% of the times in a valgus knee it is either medial, or it could be both medial as well as lateral, as it was in this case.
What was the size of the femur in this case?
2 femur, 1 tibia.
Yeah. So this has actually been described by Sami Tarabici in Journal of Arthroplasty 2017, particularly with small size femurs,
yes,
PS designs, and is a very similar case to what you are demonstrating.
There is a ratio between the prosthesis versus the distal femur, the breadth.
Yeah.
So when the ratio is smaller, the chances of fractures are higher.
Yeah, because once you've taken the box out, there's not a lot of bone
It's
on
the
the
box
medial
cut,
lateral.
yeah.
So there was osteoporosis, the box was big, she buckled, so there were multiple factors causing this fracture.
All right, so now you got a challenge. Now what are you going to do?
So we went back in, it was a Robotics type 2, the implant was stable, so we had to fix it with lock plates on both sides.
Everyone agree with that treatment plan, or how old was the patient?
She's 76.
76. Does anybody have any desire to consider doing a DFR, a distal femoral replacement? Everybody would fix this? Okay. I will say, though, that more and more patients are getting DFRs, especially when they're approaching 80, because it does allow them to immediately weight bear. Did you make her partial weight bearing?
So there is a different kind of scenario where you already have arthritis and patients have a distal femur fracture. Those are the ones where, and they are above 75, 80 with this kind of comorbidities. We try to do a singles procedure like a distal femur replacement.
Yes, but I'm saying even in the setting of supracondylar fractures, we're doing it more often.
Yeah, so that at least we can get them out of...
What kind of weight bearing did you do for this person?
For this, right now, she's non-weight bearing. At least we will wait for 3 weeks and then probably slowly start using a brace.
I saw her struggle in the initial video that you showed. Yeah, so this is going to be tough for this lady, right? And
she just waited too long to, get the surgery. So she was so far down in terms of her general ability to ambulate.
So would there be a role to give, injections of teriparatide or, zoledronic acid or any of these pre-operatively before you take them up? Because you can see very distinctly there's severe osteoporosis.
So usually they automatically go on these regimen right after surgery, right from anti-resorptives to parathyroid hormone.
Giving them pre-op will not have much use because patient won't be able to walk, and unless you load the bone is not going to get better. So the best idea is to get them corrected, make them start weight bearing, and then start all these chemical therapy so that the bone becomes better.
We've had many cases where patients actually walked and never had such an issue. But probably physiologically she was so weak that she ended up here.
Well, I already know what I'm going to do next year. I'm going to invite a bone metabolic specialist, and we're going to get some lectures. Because, clearly from today and from years past, the osteoporosis and osteomalacia, the vitamin D, this is a serious, problem in this subcontinent. And, I think either medical doctors or it just needs to be more recognized and treated. It's a major problem in this country. You have a question, Mike?
So Haas, do you use that long leg brace when she started walking? Walker with long leg brace. Have you used that post-operatively?
So we usually use, this case, we usually use a range of motion knee brace so that we allow them 90 degrees of flexion. But it's definitely...
On walking, she was using that long leg brace or not? This is the question.
So the history is usually quite suspect.
So my suggestion, what we do when there is a severe osteoporosis, overweight patient, walker with long leg brace, so that minimize the chances of fracture.
Maybe she was not compatible with it. She had a brace to begin with.
Okay. All right. Thank you very much.
Another important point is that whenever you are doing plating, you have to do plate on both sides, like what Suhas has shown. Unilateral plating only on the lateral side doesn't help. That is inadequate fixation.
Okay, while we're getting the next talk up, can I just ask some of you guys that are dealing with these patients with a bad metabolic bone disease, if they're not able to load the joint effectively because of big deformity, do the pharmacologic agents preoperatively make much difference? Yes or no?
So I mentioned that we shouldn't give them pre-op because it won't make any difference because they are not loading the bone.
That's my question. So does it help? Does it help for osteomalacia? Maybe it does. Vitamin D might. So vitamin D, yes, but anabolic agents, no? Okay, thanks.
Good evening, everybody. I'm going to present a case of 60 years old male presented with complaints of right and left knee joint pain. The past history of right and left knee replacement 5 years back, and right knee was infected and underwent a 2-stage revision. The history of hypertension is present, so no other comorbidities. This X-ray of left knee joint, presented with complaints of pain and swelling, history of trauma. It's diagnosed as a periprosthetic fracture, and MCL and LCL are intact, diagnosed by ultrasound. Clinically and hematologically, no signs of infection. So what do you say? Like X-ray, you can see the aseptal loosening of the femoral and tibial component also.
All right, so Rajesh, how do you want to tackle this?
So I think the two things, clinically or on the radiologically, it does look that this is an septic loosening all over. Whether it is septic or aseptic, maybe we should take it as septic and then do the tests and aspirate and prove that. Why the fracture has occurred? I think because the tibia is loose. I'm just a little surprised that there has been a fracture on the fibula in the past, because you can see it is well united. And I think this current fracture is something like a loose tibia and a stress on the lower part of the tibia. If it is infected, it will have to be done in 2 stages, where the implants come out and you'll need to stabilize that fracture with either a intramedullary cement stem, or I'm just thinking what else can be done. But you need to stabilize that fracture, take the implant out, get the infection out, and then do the surgery at a second stage.
All right, so let's assume it's not infected, because you didn't aspirate it, but you did blood tests.
No, aspiration is negative. So
Okay, fine. So it's not infected. So Ashok, how are you going to tackle this? How are you going to remove these implants without displacing this fracture even more?
I don't think that should be a problem, Amar. This is loose. I suspect, in spite of what he's saying, there's possibly a septic loosening. But even assuming that this is aseptic, I think that should not be too difficult. There is a radiolucent line going all across the front and the back of the. So you put in a stacked osteotome, oscillating saw, whatever, and this should be pretty easy to remove. Keep the poly, remove the poly, do the femur first, and then get the tibia out. And I would do technically what you described, I mean, in one of the earlier sessions as a 1.5 revision. I mean, I would do that, send everything else for sonification, get the cultures. In the event that this happens to be infective, you've dealt with that part of the deal. Hopefully, that should stabilize it. If not, you can proceed accordingly.
So despite telling you there was no infection, you still have a high suspicion?
I would suspect.
Okay, and that's fair enough. Harish, you want to add? Is anybody going to preliminarily fix the fracture first?
Yeah, that's what I'm telling you.
Oh, okay.
If this patient was asymptomatic to begin with, and he has never complained of pain or discomfort on that side, clinically there is no infection, then I'll just treat the fracture first, fix it. It's not a very difficult fracture to fix. Give 3 months, 6 months for the fractures to heal. 6 months, 8 months down the line, when the bone has healed very well, I have a relatively simpler solution for revision. I can just remove the proximal plate, screws, and do a simple revision. If I want to do everything today, then I'm getting unnecessary into complication. And I don't think that is required.
I got your point. So Arun, do you agree with that plan, or how would you tackle this?
I think that this patient actually has severe osteolysis from poly wear. There's a huge defect on the tibia, huge defect on the femur. I'll discuss with him, be absolutely sure that it's aseptic loosening, and probably try and do it in one go with a long stem on the tibia, along with a possible derotation plate if it's not stable enough. That's how I would do this, all components. And I don't know what's happening to the patella. I'm not sure if it's been resurfaced or not, but I might go ahead and even resurface the patella.
Can I say something? If you try to remove this implant, even if it is loose, try to get everything out, probably you're going to make a very shattered proximal metaphyseal area. You may not end up having a proper surface on which you can put an implant. You may end up requiring something like a tumor processes.
That's why I asked the question, who's going to fix the fracture first? Dr. Mohanty,
put a tentative plate there, just a temporary
that's
plate, and then go ahead and do everything.
That's what I was telling, that, you can temporarily unicortical plate, putting unicortical screws there temporarily, then rim the tibia, and then you can go ahead with it. That should not be a problem.
The other thing
Dr. Barry, do you want to add anything? Thorsten, you want to add anything?
You've said the main options. Which is the best one could be debated.
So which one do you think? That's what we're here for. We're here to debate.
What are the facts? The facts are we have a state of a two-stage exchange. We have a loosening. I think that's an obvious loosening of the tibial component, femoral as well. So we have a loose implant. We have a fracture. We have probably an infection. First of all, you have to rule out the infection, of course. And then I would do exactly what Aaron said. I would change it into a stamped tibial component, And probably I would do some kind of additional stabilization with a strut graft. My question, Arun, is why would you replace the patella? The patella is very thin, it's very sclerotic, and if you put in a patella resurfacing there, the danger of fracturing the patella is quite high.
Agree with that.
So yeah, I mean, I would, in my opinion, put a plate on first, unicortical, just to stay low. Because if it does displace, when you're removing components, even loose components, it's difficult. You got to hyperflex, you got to do stuff to that leg, and yeah, you can make this much more complicated. So let's see what you did.
No, clinically infection is ruled out. Even intraoperative, although we sent for frozen section, infection is not present.
Wait, go back to the x-rays. Hold on. Yeah, the x-ray, the x-ray. One back. So, yeah, no, yes. So what happened? You put it in and you went out the back? All right, so tell us what happened. So did you fix the fracture primarily?
Is that a right knee or a left knee?
No, showing right knee also. Left, we are discussing about left knee.
Okay, so this is the right knee.
Yeah.
So his right knee is loose. Different problem.
These are the intraoperative left knee fractures. The implants are loosened, and infection is ruled out by frozen section. And Arun Mullaji was asking about the patella. Patella has found that fractured patella. It was fixed with wires. And
So
one stage revision was done.
It had been resurfaced, the patella?
No. It was fixed. Patella was fractured.
Did you fracture it?
No.
It wasn't fractured on the
It
x-ray
was
that you
fractured.
showed.
Earlier it was fractured.
Show me the fracture.
Radiologically, you cannot see. It's a thinned out and fractured.
Okay, so now, now I see the radiologic wires, so I see it was fixed. All right, so how did you tackle the fracture in the tibia? You didn't plate it or do anything preliminarily to stabilize that fracture and the tibia?
Sorry?
You didn't do anything to the tibial fracture to stabilize it before you tried to put the stem down?
No.
Okay.
These are 18 months old post-op x-rays. Shows fracture healed well.
All right, any comments from the panel?
I think it looks very good.
Looks good. I mean, I think the whole question there revolved around whether it was going to turn out to be infected.
Right.
And I was suspicious it was going to be. Apparently it wasn't, but I was suspicious about it, just like Thorsten was. And if you'd gotten in there and it looked infected, I think that would have really changed the whole plan.
Yeah. So, I can't hear.
The patella fixation. The patella was fractured.
Do you have a merchant view? Do you have a merchant view? Skyline view?
So the wires, you show the slide, you have wire inside, right? In the patella side, the femoral component side. So what they're doing there?
You're worried about the wires hitting the trochlea,
Yes,
correct?
yes.
So no option left to fix the fracture.
The wires are on the undersurface of the patella?
Yeah.
Could you have used
cover it
a
with
suture instead of the wire? Ethibond, for instance, because when you have periprosthetic fractures of the patella, typically you don't want to be putting internal fixations in terms of metal.
Or fiber wires.
So
Fiber wires have been
was it a vertical fracture, a
But two
horizontal
number
fracture?
It's a vertical fracture.
Vertical fracture.
It's a vertical fracture, and the reason they're worried about it is because the intraoperative photograph, you could see the wires on the undersurface of the patella. So that's why they're worried, I think.
No, I understand that. But my point is, if you're going to fix it that way, I would have just left it. That might have been a better solution than having a wire touching the trochlea. That's going to cause a major problem. You know, so if it was a vertical fracture patella, you could probably get away with leaving it or using, as you said, sutures. Now, you know, you go to Arthrex and some of the other sports companies, they have really robust sutures and fiber tapes and fiber wires that can, hold bones together.
But the wire's not there in the X-ray on the left, the lateral view. So did you go and take it out later?
Yeah, we have taken out.
All right.
Can I ask a question, please? What did you do exactly to the fracture in this side here, in the audience? Hello. What did you do to the fracture of the tibia when you stabilized that tibia? How do you do that, intraoperatively? What do you do? Did you put a temporary plate as was discussed? Or
No, I didn't put any plate.
How did you manage to put and manipulate the entire knee
Intramedullary reamer. I stabilized with intramedullary reamer.
Intramedullary?
Reamer.
Usually somebody was holding the tibia from outside and trim the tibia, stabilize the tibia from outside.
But the stem length which he has used for the
Huh?
stem length which he has used for the tibia, he hardly has gone beyond the actual lower end of the fracture. How can that stabilize the fracture? I mean, it's good that it has healed. The patient is lucky. But I would be scared to just leave it like that with that short stem, which has hardly gone not even an inch beyond that lower end of the fracture. And to expect it will heal without having a collapse.
He's beyond it, I think, far enough. I don't have a problem with the length of the tibial stem.
It's small. It's not engaging the cortex there.
As per Dr. Ranawat, that success cannot be challenged.
Exactly.
Good that it has healed. Patient is lucky.
All right, anything else to add?
Sir,
It's a right side.
What was the range of motion, post-op range of the motion, this patient?
What's his post-op range of motion?
I'll show you later.
Okay, so let's go.
It's a right side. Already 3 years back underwent 2-stage revision.
You only get one case. Let's go.
These are the intraoperative pictures. These are the post-op X-rays, 18 months.
All right, so you use bone graft on the femoral side. Yeah, I mean, I think now we're seeing the use of cones and sleeves for more of these defects rather than using. You use allograft?
No, cement and screws.
Just cement and screws. Like, okay.
Are you really happy with it? I mean, you changed the joint line dramatically. You have a patella brachbacher. Probably this is a PS design or
PS design.
PS design. Probably
PSC.
severe instability as well. So why didn't you change the joint line better? You build up the tibial part. What's about the screws? Do you have? Can you explain me the screws? Why didn't you build up the femoral component? Let the tibia in the same level, then you have a good joint line. And
No, these are the primary implants, PFC design. So only we have option of maximum 17.5 poly. So if you go down the tibia, the poly will, you need more, means constrained poly.
He's saying, why did you not distalize the femur so that your joint line is restored rather than raising the joint line by taking the femur so proximal?
No, it was more bone loss. I thought, means already I have distalized more femur.
I mean, listen. I understand that you're doing what you're doing with what you have, right? You probably don't have sleeves. You don't have cones. You don't have a hinge. Like that medial femoral condyle is at risk for breaking and fracturing, and this knee is at a high risk for a hinge. If I were doing this knee and I felt there was good stability after I did it, I would make sure it was an easy conversion to a hinge, because you now have a problem if that medial epicondyle breaks.
yeah, but I mean, this system has augments.
Yes.
And you could use augments in the femoral part.
No, 100%. No, yes. So,
and you can bring it down, and you don't have to build it up on the tibial part. I mean,
I 100% agree.
As you said, it's correct. The patient is very poor, so budget is low. I cannot use sleeve stems. So managed with screws and cement.
Then it's clear. Okay.
Okay. Excellent. Is that it? You done?
Post.
All right. Great. Next.
Thank you, Dr. Jagdish. Next, we have Dr. Karthik Reddy.
Here, the post-op range of movements. No, last one.
All right. Just tell us what it was. If it was good, that's great. Okay. Good job. All right, next.
Thank you.
Thank you.
We got two more. Let's go.
Good evening. This is a case of 57-year-old female patient who came to our OPD just a couple of months back. This is a recent case. So the main complaint is difficulty in walking, wobbling and buckling of knee associated with pain for last 1 year. The chief complaint here is more of instability rather than pain. So she had a road traffic accident 2 years back, knee was dislocated. Fortunately, there is no neurovascular injury. So closure reduction and plaster, all this procedure has been done elsewhere, not in our place. So closure reduction and plaster application was done immediately. The plaster application was maintained for 2 months. So a two-staged multiligamentous reconstruction has been done. So which has been done, the last surgery was done approximately 11 months back. So in the first stage, ACL and PCL has been done, and the second stage, PLC and MCL has been done. So this is how she is walking when she presented to us. Very unstable knee on the right side.
Okay.
These are some examination videos.
All right, so let's, Rajesh, I'll start with you. So what are you thinking?
Well, I think that there is gross ligament instability, and it's a global instability. Although the repair was done, this is the situation, and I would keep hinge ready.
You're gonna have a hinge ready. All right, Ashok, you gotta have a.
I'd like to see the X-rays first.
Okay, but you're seeing a clinical exam.
No, I'd still want to see the X-rays.
Okay, show us the X-rays.
Range of motion, she has a hyperextension of about almost 30 degrees. Range of flexion is good. There is no stiffness.
We can see it. Yeah, okay.
This is the pre-reduction X-ray. This is immediate post-reduction. So these are the standing X-rays.
All right, so Ashok, you're up.
Hinge.
Hinge, okay.
I think if there is no neurological issue here, it's just a post-traumatic, 90% you can even do with the primary PS knee. If you balance it very well, you have to just take the less femoral cut. We may have to upsize the femur to fill your flexion gap. And you have to keep constraint design, of course, standby. But my prediction is probably you can do it just with the primary
okay.
implant.
Arun, anything to add?
Probably a fixed hinge.
Fixed hinge, all right. Dr. Mohanty?
I agree with Harish that if the MCL is competent enough, then I would go ahead with a PS knee only. But I keep constant is standby on the table.
Dr. Berry, anything to add?
Not really. I mean, this lady, the way she walks scares the heck out of me. And I think that even if she's on the borderline of maybe being okay with something less constrained, I'm thinking about a hinge here.
Yeah. Thorsten, you're doing a hinge?
My answer is quite clear, but the gait showed probably some kind of neurological disorder, I don't know. And then we are on the same discussion as we had before.
Okay.
So I agree with Arun, fixed hinge, that's why he said fixed hinge.
Yeah, I mean, my take-home point would be I don't have a problem starting off trying to put in a knee, but at the very least, I would have a constrained knee. I wouldn't put a PS in, even if I thought at the time it was stable.
At a minimum.
Yeah.
Somebody like this who's already demonstrated they keep loosening up, things going worse, going bad, unstable.
Right.
Go a little overboard on the constraint, not underboard.
I agree with that. All right, tell us what happened.
So this is the immediate post-op X-ray. This is the TC3 semi-constrained. You had to use the distal femoral augments because even with the minimal cut, the knee is going into hyperextension. So we had used the distal femoral augments.
Okay, so let's he distalized, right, the femur. He's got a stem on the tibia. Anybody have any comments or criticisms?
He has taken, I think, a big tibial cut. You can see the base plate is touching, almost going below the tip of the fibula there. So that big tibial cut probably will mean that you may not be able to fill the gap, which is there. And then you may have to use a big insert and maybe constraint design. So you have to also be very prudent on the tibial side. You should take very little cut so you get adequate space to play with.
I agree with that. Anybody else? You didn't use a femoral stem.
I should have used, I don't have a good answer to defend, but I thought there is no bone loss. So the bone stock is good enough to support the femur is what I thought, but should have used it.
Yeah, but you put in a constrained knee, and I think just like we were talking about being sort of overly cautious with the constraint, you should probably be overly cautious with the fixation as well, right?
Especially in bad bone, right?
Yeah.
The only other thing I would just say is that you can see some asymmetry of the medial and lateral side here in terms of the joint space, which means that even with a TC3, there's still some residual instability, which makes me a little anxious.
100%. All the more reason to put a stem on the femoral side, because that post can't do all the work. So it's going to transfer a lot through the femur. And I think the point I want to make is we spent all day talking about alignment, right? It's fixation, right? Cement technique. That is the most important thing. If you screw that up, it doesn't matter what robot you used, right? So focus always on, and don't minimize your fixation. So show us what happened.
So intraoperatively it was stable. So this is 1 month post-op X-ray.
So let's go back. When you say intraoperatively it was stable, are you checking that with the TC3 trial or?
Actually, that's with the trial.
Okay, so here's one of my pet peeves. Whenever I do revisions, I don't want to use the constrained trial to check my stability. Of course the knee is going to be stable, right? You want to put a PS insert trial in, right? So I'll put a PS insert trial in and check my stability, and if I'm happy with that, then I'll put the real constrained insert in. Are you following me? You don't want to trial it, doing this with a constrained insert in gives you no information.
Makes sense here. So this is 1 month post-op video which the patient has sent.
Looks like she has a little residual valgus in her knee.
Do you really think she's stable? I mean, if you go back to the X-ray, you see a quite big gap on the medial side, and on the first X-ray there was a gap on the lateral side. I mean, even a CCK like this has limitations, and I don't think, if you look at the X-ray, there is a big gap in the medial side, and if you see her walking, that's not a normal walk. She still tries to compensate her instability.
But again, the same point, she's walking on that block of plastic post. She's walking on that.
All right, well, you got her walking. You have anything else to add?
I think not much of papers that has been published on this after TK after a multi-ligament structure, but whatever the published from the Mayo Clinic, there is increased risk of revision, reoperation, and implant constraint. This is what the major paper that I have found in literature. But I want to ask the panel, how many of you would consider a primary total knee replacement in an elderly patient coming with a multiligamentous knee injury?
I think that we made the point, though, if you're going to do a knee replacement, you probably should have, at the very least, a constrained knee in a multiligamentous, prior injury. All right, so you did the right thing in that regard. Your alignment could have been a little better. Your balance could have been a little better. You could have had a stem up of the femur, but so far, so good.
Amar, I don't think you can balance that knee. You're just either going to have to depend on the poly or a hinge. There's no question of doing soft tissue releases and balances because the quality of the tissues is so pathetic. You can't really balance it.
No, I mean, but that's the decision that you have to make intraoperatively and then decide to go to the hinge, right? All you can do is assume that he made the, correct assessment and that the MCL was strong enough to support, right? But yeah, I mean, I think I agree that the story of this knee is not over. All right? All right, let's get the last speaker.
Good evening, everyone. Just a bit of small two cases. with regards to knee. The first case is, I was fortunate enough to get a osteoarthritic knee in a neurofibromatosis patient. So it's not so common, relatively seen, patient with neurofibromatosis presenting with severe OA knee. Just to give a brief slide about the literature of neurofibromatosis. It's a neurocutaneous autosomal dominant genetic disorder. Mainly 3 types. The type 1 is the most common one, which is the von Recklinghausen's disease. It is associated with a defect in the tumor suppressor gene neurofibromin, which suppresses the multiplicity of the cells. The neurofibroma 2 consists of vestibular schwannomas and meningiomas. The type 1, which is our patient, which is a majority of neurofibromatosis cases, are basically characterized by pigmented skin spots known as cafe au lait macules, freckling, optic gliomas, neurofibromas. The musculoskeletal symptoms, which is of prime interest here, include bone deformities, including pseudoarthrosis in patients of neurofibromatosis, weak muscle, weak muscular strength, osteopenia, osteoporosis, and a high risk of fragility fractures. In majority of patients with neurofibromatosis, the treatment is mainly clinical monitoring and intervention, orthopedic as well as other intervention whenever required. This is just a brief preview of neurofibromatosis. Coming to the patient profile, the patient was a 64-year-old man with history of neurofibromatosis type 1 and diabetes. He had been operated in the past for neurofibromas, like painful neurofibromas, where the biopsy was done and it was diagnosed to be type 1. And the patient presented primarily with pain and inability to walk. This is the pre-op X-ray. Sorry, the X-ray is flipped. Actually, it's a left knee X-ray which has been flipped and shown in this manner. Sorry for the poor quality X-rays. So this is the pre-op X-ray. This is the pre-op gate.
All right. So who has any experience doing this? Thorsten.
I did 2 of these cases, one in Buenos Aires, one in Hamburg, and this is a disaster, to be honest. I put in both, I put a hinge knee. My infection rate is 50% because one got infected. So so if you do something in those cases, hinge knee would be a solution, could be a solution. But you should always have a vascular surgeon on your side because it's a disaster because all the vessels are modified, and that's my experience.
So as you said, like this was like 4 years ago in the pre-COVID area, and it was relatively early in my career. So as the patient turned up in my OPD, I took a few days off, bought some time, called all my seniors, did some review literature, and then I called the patient after 1 week so that I'm well prepared to do. And to add to the burden, the patient belonged to a poor socioeconomic status and operated in a trust hospital. So this was the pre-op status, and not much intraoperative recordings. This is so intra-op, I had kept LCCK as a backup. And although clinically there was not much laxity, that's the reason I never thought of any hinge knee. Fortunately, I was able to, like clinically I never thought I would require a hinge knee, but LCCK was kept as a backup. And I had kept a neurovascular, like a vascular surgeon on call, like in case I needed him on the operating day. The challenge here was to buy even put the tourniquet on, because there were a lot of neurofibromas in the groin region, and I usually use tourniquet. So that was the first time I did a TKR without a tourniquet around. And then the skin incision, I couldn't take the picture of the knee. The skin incision was curvilinear because of the neurofibromas in and around the anterior aspect of the skin. But luckily I was able to have a good view after the approach. Didn't go for a subvastus approach at all, went for a standard medial parapetal approach. And luckily the medial defect after all the resections was quite minimal, so I was able to get off with just one screw and some cement buildup. It was less than, posterior medial defect was less than 25%, so I just filled it up with a cortical screw and some cement buildup, although I had kept augments and wedges as the backup, and just a small stubby as to have some additional stability to the knee. This post-op X-ray was taken in an oblique view. This is a post-op gate 1 on day 1. With no knee brace, and the post-op knee was stable, fortunately for me.
All right, anybody have anything to add or comment on the panel?
Good job.
Thank you, sir.
Yeah.
So this is the 6 months post-op X-ray. Since I couldn't get a proper view, AP view in the immediate post-op X-ray, fortunately the patient is still following up with me and is doing good. The only review of literature, all the points which I could list out pre-surgery was to assess the bone quality in case of a neurofibromatosis, as osteoporosis and osteopenia are like very much documented with neurofibromatosis cases. To assess the ligament laxity and soft tissue laxity, usually it is a multi-ligament laxity which is seen in neurofibromatosis cases, and it is usually bilateral. Fortunately, I was, like the patient who came to me had just one isolated leg issue. The tourniquet, as I said, was difficult to apply. The skin incision was customized. The TBL was cut as minimal, so I could get away with 11 poly. And the constrained knees was kept as a backup. This was the only article which I could find in the literature where a TKR was done in a neurofibromatosis patient with multi-ligament knee instability, where they ultimately had to convert the patient of post 3 years follow-up into a hinge knee.
So I have some experience with this kind of case, and I would like to say that I would have primarily put in more constraint, because you just have 3-4 years of follow-up, and even in 2 cases before, I think it's better to err on the side of doing a more constrained knee. Immediate X-rays, they look good, they do good for a couple of years, but in the long term, I really don't know. So sometimes it's better to use a little higher level of constraint. I do understand in India, we're limited by what's available. We don't have these off the shelf. You've got to do a lot of struggle to get them. So you've done a great job. But I think the message for the house is, if you get some similar cases, don't hesitate to get the set, wait for a week. You took 3 days off. You would have taken some more days off and got a more constrained process, and do that, because I think the long-term results of these are more favorable for using higher constraint.
Yeah, I agree with that. Anybody have any comments to that effect?
The incision heal okay despite all the neurofibromas?
Pardon, sir?
The incision heal okay despite all the neurofibromas?
Yes, fortunately.
Great. Well, now you're an expert in this rare condition.
You're a lucky guy, my friend.
The question is that, is there, the literature shows that is there a late onset of instability in this kind of knees because of neurofibromatosis?
So the usual onset of instability or any such thing has been like 3 years. That is what I could find in the literature so far. Now the patient has been following up for almost 5 years now. I did it back in 2019, 4 years now. And although I couldn't take an X-ray or upload it here, but he's doing good clinically. He has other issues like spine, scoliosis and other things, but clinically he's doing good. There's one more small case.
I think we're running out of time.
Yeah, I think we're...
Just have few minutes for questions, because we're already 10 minutes over time. But thank you, great case.
Yeah, great case. Thank you.
Thank you, sir. Thank you, sir.
I'd like the panel to stay for 5 more minutes. You guys have any questions right now on any topic we discussed today, you can come to the microphone. Number 3, Prince.
Just one point regarding the first case where there is a plantar valgus deformity. So whenever there is a plantar valgus deformity, never use a CR implant, because literature shows a high failure rates with a CR implant when there is a plantar valgus deformity. Just a comment.
Okay, any other question? Microphone 2? Yeah,
so logistic issue. Now, we find it very difficult to get the sleeves, metaphyseal sleeves, for last couple of years. Now, is it the case only in our country, or Professor Don Barry, US, what is the situation?
They're readily available in the United States. My guess is it's economics. In other words, the implant companies route their expensive implants to places where there's a good reimbursement rate for them. That's my guess.
Are you talking about sleeves or cones?
Metaphyseal sleeves.
Sleeves. I mean, sleeves are depending on only one company is providing sleeves.
Yeah.
All the other company is providing cones.
So what do we do when we have a lot of metaphyseal defects in a revision scenario, or, you know, a couple of cases were discussed here where you said that you should have proximalized the tibia and distalized the femur. Sleeve would be an ideal answer for that, and we don't have it now.
Sleeves are good, but cones are also very good, and I think sleeves and cones can more or less be used interchangeably for most situations, so those are the 2 choices. And then, of course, there's allograft as well, but...
Right, okay.
My answer is we use cones in about 85 to 90% of our revisions in the meantime, because they provide really stability, rotational stability, and they fill up the osteolysis.
Okay, thank you.
Hello.
All right, yes, which 7, yeah, go ahead.
So related to the last case, what is the options for the neuropathic knee joint? Fixed hinge versus rotating hinge knee, and what will be the expected survival? Or one can go directly for the arthrodesis of the knee if the patient has a complaint.
We discussed it already. So if you have something like a neurological disorder with hyperextension, then the mechanism of a rotating hinge knee, a normal rotating hinge knee, is extremely weak. And you destroy, by hyperextension, the mechanism very quickly. So you have two options. First, you order a special one with a block, with a high bumper. You use a fixed hinge knee, a pure hinge knee, not a rotating hinge knee, or you go for a CCK.
Okay, and what is the
rotating hinge knee is not a good solution for these kind of patients.
With this fixed knee hinge, what will be the survival expected?
It's not too bad. I think it's okay. I'm not sure if the pure hinges are available here in India, but because they're quite rare. So, but the survival rate is okay.
Thank you.
Yeah. Microphone 5.
Good evening.
I wanted to ask the panel that we've spent a lot of time discussing alignment and robotics and things like that today. What would the panel feel is the role of things like medial pivot designs or rotating platforms or different sort of implant and anatomical designs in the area of technology, and what role do they play in primary knee arthroplasty?
Great, good question. I'll answer it from my end. I use medial pivot knees. I did use rotating platform knees for many, many years. I found no clinical benefit to that. I will use rotating platform technology in CCKs and in hinges. Rajesh?
Yeah, so medial pivot is not available to me, so I'm not using it, but rotating platform I use, PSRP. But as Amar said, there is no clinical evidence to show that there is a difference with the fixed bearing. And definitely with the better poly available, better design, better locking mechanism, that probably will not show up. But the mobile bearing definitely has a role in the revision situation. So I almost always want to use a mobile bearing revision because it protects your fixation on the stems or a sleeve, whatever you do.
Good evening, sir.
So I use the medial pivot. It's vitamin E reinforced. We don't have to worry about the PCL. We do tend to keep the PCL in all of our cases. It gives you great stability, gives you a medial pivot, and gives you a great range of movement.
I have been using rotating platform for the last 15 years. And I think people want to have a high flexion design because they don't want to squat down, but they want to sit cross-legged. If you want to sit cross-legged, you have to rotate the tibia on the femur. And that is easily done if you've got a rotating platform design, because with a fixed bearing design, you have to have very accurate alignment of your implant and the box on the femur if you're using a PS knee. So I like a rotating platform and I have no problem about it.
My usual primary is a fixed bearing. It could be mobile bearing or sometimes a mobile bearing, PS knees. In revision situations, I tend to use a mobile bearing. I think the key really is not to get too diverted as to which implant is the best. Take one and then learn to use it well and be familiar with that. I don't think there are any significant differences in the outcomes published of one design versus the other.
I have used all kinds of knees and there is no significant difference. Primary rotating platform knees gives me a little bit of independence in putting the tibial component in different rotation, especially in a smaller size of tibia. So that gives me an advantage to put a rotating platform, and that's a little easier. But in obese patients, I avoid using a rotating platform tibia because the stem is short, there is early failure. So I prefer to use a fixed bearing knee in obese patients or sometimes with a extender, stem extenders.
I more or less agree with the philosophies espoused by Amar, Rajesh, and Arun.
Fixed bearing and PS in all my cases.
All right, there's your answer. And I think the take-home message that was said is, it's not the implants, right? It's your surgery. Do a good surgery. The implants are rarely the weak link in how the patient does, right? Do a good surgery and pick the right patient. All right, number 7?
Yes.
Last one, yeah, go ahead.
Yes, sir. Good evening, sir. So my questions are regarding 2 cases. One is regarding the valgus knees. So what are the methods to assess the integrity of MCL in valgus knees? Because will MRI have any role? Because in clinical examination, it so happens that we get a block. Yesterday, in the morning, I have listened that there is a soft block or a hard block. If it is hard block, then it is a bony, and it is soft, then, Then what is the method to assess the integrity of MCL?
So Thorsten, you want to tackle that? What's your method for assessing the competency of the MCL in a valgus knee?
I mean, just a clinical examination, nothing more.
I think it can be hard if there's a bone defect on the lateral side of the tibia. It's just difficult to do it preoperatively. So for me, it's an intraoperative decision, generally speaking. Once you get intraoperatively, you can tell what's going on and you can assess the MCL, but you have to go into surgery recognizing that you're not going to be sure. So you have to have implants that can handle either situation, a good MCL or a bad MCL, and respond accordingly.
I agree with Dan.
Yeah, so I think, I personally will cut the proximal tibia, I'll cut the distal femur, and that's when I assess the MCL. And as I said, usually, in valgus knees, the idea that the MCL is lax is in my opinion, usually a misnomer, because it's lax relative to the fact that the lateral side is tight. You just got to fill that space up, and you got to open up the lateral side. So you have to learn how to release the posterior lateral corner in a valgus knee. All right? I think that's it.
Thank you, sir. And the second part, second question is regarding the revision cases that sir has presented. In the first case with periprosthetic fracture, the tibial base plate has sunken down with the tibia shattered, the proximal tibia shattered. Do we have to fill it up and bring it up, or is that fine?
Yeah, you want to restore both joint lines, and I think using sleeves and cones allow you to do that. There are other different systems that have increased base plate thicknesses, so there are ways to do it. So, I think the cases that you saw with the cement and the screws, those are compromises that you make for probably financial reasons, right? But yes, restore your joint lines on the tibial side and on the femoral side. All right, we're going to cut it short there, or maybe long, I guess, and we'll see you all tomorrow at 9, and enjoy the gala dinner, and visit the industry sponsors. Thank you very much.
The company-sponsored sessions will be on the first floor. Please feel free to attend them. And the gala dinner is in this hall, 8 p.m. onwards. See you soon.